Okay, so welcome everyone, and thank you for attending Legal Aid Alberta's virtual training on mental health and the criminal code. My name is Wyatt Fraser, and I'm Legal Aid Alberta's engagement facilitator, and I'll be helping just ensure everything runs smoothly today. If you get any technical difficulties, please just type it into the chat so I can connect with you to try to get those resolved. So before we get started today, I just want to speak to a few bits of housekeeping. So today's webinar is being recorded and will be available later, either this week or early next week. A link will be provided shortly in the chat to a shared Google Drive where you'll be able to access reference materials given by today's speakers. The materials will be added throughout the day as well as speakers finish their presentation, so you can keep checking and more materials will be added throughout. You'll also receive a link to this shared drive in an email as a follow-up, so you're able to access it in the future whenever you need to. While your microphone and camera are disabled, you can use the meeting's chat window to engage with us and ask questions. To access the chat window, you can look along the menu at the top of the Teams window and click on the little speech bubble that says chat underneath. For reference, you can also look under the More option. So when you're looking at the top of your Teams, there's a More button. If you click that, you can scroll down and find one that says Mute Notifications. So if you don't want the ping noise that comes when people add questions or type their comments into chat, you can always click that button as well, because then that way you'll be able to focus just on the speakers and their talks. We will hopefully have time for questions for each speaker as they finish their segment. We respectfully acknowledge that we are situated on the ancestral and traditional territory of many peoples presently subject to Treaties 6, 7, and 8, namely the Blackfoot Confederacy, the Kainai, the Piikani, the Siksika, the Cree, Dene, Saulteaux, Nakota Sioux, Stoney Nakoda, Tsuut'ina Nation, and the Métis people of Alberta. In an act of reconciliation and gratitude, we acknowledge all First Nations, Métis, and Inuit who have lived in and cared for these lands for generations. And now I'll turn it over to Danny Lynn, Legal Aid Alberta's Senior Advisory Counsel, Adult Criminal Law, for a few more words and to introduce our speakers for today's topic.
Thanks very much, Wyatt. So good morning, everybody, and thank you for joining us today. As partners in the justice system, we at Legal Aid Alberta understand our role and responsibility in helping to ensure a fair and accessible legal system. We are committed to building a positive and trusting relationship with all our stakeholders across the province. For today's presentation, we have an excellent set of presenters and presentations regarding the intersection of mental health and the criminal justice system. We will also be looking at the practice before the Alberta Review Board and the Mental Health Review Panel. In addition, we will be discussing Edmonton's Mental Health Court and working with mentally ill clients and utilizing a trauma-informed practice. So let me introduce our presenters for today. Firstly, we have Dr. Raheel Saeed. Dr. Saeed is a forensic psychiatrist with Alberta Health Services. He is also the Associate Director of Education within the Department of Community Psychiatry at the University of Alberta. Next, we have Michelle Collinson. The Honorable Judge Michelle Collinson was appointed to the Provincial Court, Edmonton Region, on December 13, 2016. Much of her prior legal career was spent with the Alberta Crown Prosecution Service, most recently serving as the coordinator of the High Risk Offenders Unit in Specialized Prosecutions, where she gave advice regarding dangerous and long-term offender applications, and where she appeared on behalf of the Attorney General of Alberta, on behalf of the Attorney General at the Alberta Review Board hearings in relation to those found not criminally responsible due to mental disorder. Prior to the pandemic, she sat regularly in mental health court in Edmonton and maintains an ongoing interest in mental health justice issues. Our third presenter today will be Alexandra Seaman. Alexandra is a senior partner with Dawson, Duckett, Garcia, and Johnson, where she practices criminal, administrative, and professional discipline law at both the trial and appellate levels. She is a graduate of the University of Alberta Faculty of Law and is a sessional instructor at the U of A Law School teaching advanced evidence. She regularly provides presentations on issues including ethics and substantive legal issues to law students and lawyers. Alexandra is a member of the Criminal Trial Lawyers Association, Alberta Prison Justice Society, and is a Legal Aid roster lawyer. Alexandra is an active community volunteer. She sits on a number of boards, is the mother of 2 young children and a fluffy Labradoodle. Our fourth presenter today will be Andrew Holko. Andrew has been a member of the bar in Alberta for over 30 years. Before joining Legal Aid in 2009, he was a partner with Walkowicz and Company for 18 years in the general practice of law, which included being a roster lawyer and duty counsel for review panel hearings. During this time, Andrew received 2 appointments in council. He was a presiding justice of the peace for 10 years and the vice chair of the mental health review panel for 8 years. While at Legal Aid Alberta, Andrew has served in many roles and new endeavors, including mental health court. He has provided training, mentorship, and guidance for articling students and new members of the bar. Andrew has also represented Legal Aid Alberta at many stakeholder meetings and initiatives. And then our final speaker today will be Amna Qureshi. Amna is a criminal defense lawyer who has worked at Legal Aid since 2014. Her experience with Legal Aid has ranged from working in various rural courts, including the Red Deer and Edmonton area. For the past 4 years, Amna has dedicated much of her time to helping create, educate on, and work in Alberta's first mental health court and advocate for therapeutic and trauma-informed justice for the community's most vulnerable. In addition to her work in the courts, Amna co-teaches mental health and the law with Judge Renee Couchard. It's a practicum-based law course designed to provide law students with hands-on learning in mental health court. So welcome to all our presenters today, and I'll turn it over to Dr. Syed.
All right, let me just share my screen here. Right. Can you guys see the presentation?
Yes, it's visible.
Yes.
Perfect, excellent. Well, thank you so much for the introduction and the opportunity to come here and speak with everybody. Just a few acknowledgements. I'd like to particularly acknowledge Judge Couchard and Ms. Amna Qureshi for ongoing opportunities of collaboration between, our department here in forensics and the criminal justice system. We tend to learn quite a bit from each other, and so opportunities like today are very exciting for me to be part of. So the outline of today, basically, I'll cover a couple of different topics. The first part of the presentation will go over a little bit about just the very basics related to kind of mental health. And this will involve terminologies, how we as psychiatrists or forensic psychiatrists make diagnoses, what are some of the major common categories of mental disorders that you're likely to come across if you're representing a client who has mental health related concerns. And then we'll touch a little bit on who does what in the area of mental health. We'll talk then specifically about forensic psychiatry, how our service is organized. And then I was also asked to touch up a little bit on risk assessments and how we do risk assessments in forensic psychiatry. So in terms of terminology, first and foremost, let's just define what a mental illness or a mental disorder is. And depending on the context, the definition actually tends to vary. So we'll start with the medical definition first. So the medical definition is not accurate and it is not precise. And often these terms such as mental illness and mental disorder, they can be used interchangeably. Generally speaking, a mental illness will suggest that there's some kind of internal cause or an ingrained biological or psychological abnormality. So something internal to the body that's creating some mental health symptoms. This is contrasted to an external cause, for example, substances that can also create mental health symptoms. The other term that is commonly used is mental disorders. This is a little bit less specific. So mental disorders from a medical perspective is any condition that is characterized by a disturbance of someone's thinking, their emotion, or their behavior. And one of the major differences between a mental disorder and mental illness, based on how I've defined them here, is that a mental disorder can be due to an internal cause, right? So such as schizophrenia, a brain tumor, epilepsy, or also an external cause. So that could be such as substances. Like I said, often individuals will use them interchangeably, but moving forward for the rest of my talk, I'll specifically be referring to mental health conditions as mental disorders because that's how they're defined within the Diagnostic Statistical Manual and particularly in the Criminal Code as well. So From a legal definition perspective, there's a couple of areas where mental disorders specifically referenced within the criminal code. You'll find it in section 2 as it pertains to unfit to stand trial. So they say unable on account of a mental disorder to conduct a defense at any stage. And then in section 16, which pertains to criminal responsibility, no person is criminally responsible for an act while suffering a mental disorder. So the question then is that, well, is there a difference between the definition of a mental disorder in the legal realm versus the medical realm? And the answer to that is yes. But that actual definition from a legal perspective is a question of law for the trial judge to determine what constitutes a disease of the mind or a mental disorder. And, you know, very famous case laws you guys are all likely aware of in the R.V. Cooper case, they defined it as any illness, disorder, or abnormal condition which impairs the human mind and its functioning, excluding self-induced states caused by alcohol or drugs and transitory mental states such as hysteria or concussion. So this is defined with context. And this is very important for us as forensic psychiatrists, because when we are assessing an individual and we're making a notion that someone is suffering from a mental disorder, we have to keep this legal definition in mind while also having our medical definition in mind as well. I have put my own definition here. This just generally helps understand what we mean by all of these terms. So don't use this as, you know, a textbook definition or anything, but moving forward, the best way to understand mental disorders is that it's an emotional or behavioral problem that is significantly interfering with your daily functioning. That's usually a good rule to start from to figure out if someone is suffering from a significant or a severe mental condition or a mental disorder, is that it should be interfering with their daily functioning at a very significant level. So now that we've defined what a mental disorder is, both in the medical sense and the legal sense, the next question we often get from lawyers is, how do you actually diagnose a mental disorder? And there are several components to how we come to a diagnosis. Step one often involves interviewing the patient. So we're looking for, when we're interviewing the patient, a patient will report a collection of symptoms. For example, they hear voices or they feel quite paranoid. People are following them. So these would be kind of symptoms, self-reported. But then we also observe for certain signs as well. So for example, if someone claims to be hearing voices, and then we see them, let's say, on our unit responding to unseen stimuli consistently, that would be a sign. So these are two things that we're looking for when we're interviewing a patient, the symptoms and some signs. In addition to that, we also interview family or friends. We get collateral information because we cannot completely rely, especially in the forensic context, on the information that is being strictly provided by the individual. We'll do investigations. These can include blood work, urine toxicology screens, CT scans, or MRI as indicated. We may also do psychological testing, and then we collate all of this information and use our diagnostic statistical manual as a guide to help diagnose an individual. So the DSM-5, it contains a set of criteria for each specific disorder that we use to help diagnose. But I always want to remind individuals that DSM is a guide. It's not something that we always inherently stick to whenever we're diagnosing. It just helps guide us in making those diagnoses. One of the most important things whenever we're diagnosing a mental disorder, and this is why all psychiatrists or forensic psychiatrists are trained in medicine or have a medical degree, is you have to rule out medical conditions that can mimic mental disorders. And this is quite common. As an example, we recently had an individual who appeared to have a diagnosis of a severe depressive disorder, but on investigation and blood work, it became quite apparent they were suffering from a severe thyroid disturbance. So they were quite hypothyroid, and that was creating symptoms of their depression. Now, this is important because that individual could have been prescribed medications that they ultimately don't need, when the underlying etiology or the cause behind their depression actually was a dysfunctional thyroid gland. One thing that if you're representing a client and you get reports from us, you might come across this term called differential diagnoses. So, and often we get questions, well, what is a differential diagnosis and what do you mean by that? Well, a differential diagnosis is the different causes that can potentially cause the signs or symptoms a patient is experiencing. And often we'll give a differential diagnosis, the first few times we might see a patient, because sometimes it's too hard to know for certain what is going on the very first presentation. As an example, this is a very common example. So a 33-year-old male comes to the emergency department with his family because he has been hearing voices and he's paranoid that movements are being tracked by cameras around the city and microphones in his teeth. So, once they come to the emergency department, they'll be assessed and they might receive a diagnosis of unspecified schizophrenia spectrum or other psychotic disorder. But then they'll also provide a differential diagnosis of schizophrenia, major depression with psychosis, drug-induced psychosis, a general medical condition, so on and so forth. All this is basically saying is that this individual is displaying particular symptoms. We think it might be related to a specific condition, but there's 8 or 9 different things that can also create the symptoms that we are seeing. And so while they're admitted to, let's say, hospital, we're going to slowly work on ruling out each one of those conditions so we can come up with one primary diagnosis that the individual is likely suffering from. There are other confusing diagnoses that commonly come up if you're representing clients that we often get asked about. And one of the common ones is unspecified psychosis or unspecified mood disorder or unspecified whatever. The question always is, what do you mean by unspecified? This basically means that we know a patient is suffering from a particular condition, but we just don't know the exact etiology behind it. So commonly a doctor will say unspecified psychosis, meaning that they're suffering from genuine symptoms of psychosis. We just don't know exactly what's causing it. And so the point then becomes is, well, let's figure out what's causing that psychosis. The other one is Curie. So they'll say something like Curie FASD. This basically means that we suspect that a patient might have this condition, but we just don't have enough information to completely substantiate it. As an example, like with FASD is, in particular in forensics, we'll get this quite often, is that you'll have an individual whose family member or their mother may have used alcohol and all sorts of other illicit substances during the pregnancy. But they haven't formally ever been tested for FASD, but we suspect that they might have it. So we'll say Curie FASD is that, like there's some history to suggest they could potentially have it, but we haven't really done any formal testing for it. So we're just going to put it on as Curie so that care providers are aware that this is something that may be going on in the background. So the next phase now that we've covered the definition, how we diagnose, we're going to review just some common categories of mental disorders that you will often come across if you're representing clients with mental health conditions. And there are tons of them. So I will cover the most common ones that you're likely to come across, but I just want to be very clear is that this is by no means an exhaustive list. So number 1, mood disorders. Mood disorders, there's 2 major kinds of mood disorders. One of them is a major depressive disorder, and the other is a bipolar affective disorder. And I'll talk about what that involves. Major depressive disorder, a lot of individuals are familiar with this or have heard about this. It's very common. About 11% of Canadians will suffer from a major depressive disorder at some point during their life. And the key thing about a major depressive disorder is the symptoms of this condition are not just limited to mood symptoms. There are mood symptoms such as, feeling of depression and lack of interest or motivation, but then there'll also be physical symptoms. So sleep problems, appetite difficulties, energy, irritability, agitation. And then they'll also have cognitive symptoms as well. So poor concentration often will be described as a cognitive cloud. And another symptom is thoughts of suicide as well. when we're assessing professionals, one of the most common reasons a professional will come to us to seek treatment is actually because of the cognitive symptoms. They'll say, I can't focus, I can't concentrate, my attention's completely off. And that's usually a segue for us to start exploring the differential diagnosis for why they may be having those concentration problems. And it becomes sometimes apparent that they're suffering from this major depressive disorder. There are many different types of depression in itself, and this is where things start getting complex. The key message I want everyone to take home from here is that not all depression is the same, and certain kinds of depression can create unique kind of symptoms. For example, there are some forms of depression where you can start experiencing symptoms of psychosis, and those start becoming quite relevant within the forensic context. One thing I wanted to just clarify is the difference between sadness and depression. Sadness is a normal emotional response to a stressor. So for example, if someone breaks into your car and takes something of value, you would naturally feel sad about it. You're not necessarily suffering from a depression at that point. A depression is something that severely affects your functioning for a consistent and prolonged period of time. And so this is what helps us diagnostically figure out what may be going on, is that the key feature here is that it is severely affecting your functioning, and it's often noticeable by individuals around you as well. The next mood disorder that we come across is bipolar disorder. The illness itself is actually not that common, but patients tend to commonly report that they might have a bipolar disorder when that's actually not the case. Bipolar, as the name suggests, is bi, meaning two, and poles. So there's your symptoms are on two different poles. You're either feeling quite manic or you're feeling quite depressed. And there's different types of bipolar disorder, but ultimately, the way it works is at some point during their bipolar illness, they'll have this period of severe mania. So these are individuals who will have extremely elated mood or irritability. They'll have lots of increase in their energy. They'll have a lot of goal-directed behaviors, and they'll have a severely decreased need for sleep. So these are people who, like, when someone around you is suffering from a mania, there's no question about whether they're well or not. It's very evident they're not. They'll be talking at a mile a minute. They won't be sleeping. They'll have all these grandiose ideas. And often these individuals end up within the emergency department. One of my last patients who was suffering from a manic disorder, he ended up purchasing close to a $200,000 Porsche, which he, obviously wasn't really able to afford, but in the context of his mania, he was able to do that. I'm surprising that they even sold him a car during that stage, but that's usually what happens in a mania. But most people who have a bipolar disorder don't spend their time in a mania. The majority of the time is spent in their depression. And often bipolar patients may be misdiagnosed as having just a depressive disorder because they have not developed the manic episode just yet. The next common illness that you will come across is people with anxiety disorders. So anxiety disorders are actually fairly common in comparison to, let's say, a bipolar illness. A common question becomes is, well, what is anxiety and, well, where does it come from? Anxiety is a sense of worry. It's a very normal emotional response to have. And there's a particular part in our brain, or there are several parts in our brain that are involved in the development of anxiety symptoms. So over here, I just shown, this is very, very basic. The amygdala and hippocampus will often be involved when you're feeling anxious. So they'll turn on when there's a fearful stimulus. You'll start feeling like your heart is racing, you'll feel short of breath, your pupils will dilate. This is all controlled within the brain. So often I help differentiate, well, what is the difference between worrying and an anxiety disorder? Like I said, worrying is quite normal. So for example, you're walking through a dark alley and someone jumps in front of you with a gun. You'll start feeling extremely worried. Your heart will race, you'll get into that fight or flight response. And that is a normal response to that particular stressor. And worrying or anxiety in this context is adaptive. It is designed to self-preserve us. It's designed to help keep us alive and avoid situations where we can put ourselves at risk. Now, how this becomes an anxiety disorder is that if your worrying starts to significantly impact your occupational or social functioning, that's when we know that you might potentially be suffering from an anxiety disorder. And patients will start having anxiety symptoms when, the average person may not, right? And so there's different kinds of anxiety disorders people can have. They can have social anxiety, so people feel extremely anxious in social situations. There's generalized anxiety, where these people are just known as worrywursts. They're extremely anxious about almost everything. They won't be able to sleep at night. Their concentration is not the greatest, and they get extremely fatigued due to their anxiety. And there's a multitude of other anxiety disorders that an individual may be suffering from. The one of relevance, particularly to us in the forensic context, is post-traumatic stress disorder, where people can have flashbacks and re-experiencing symptoms. They can be quite hypervigilant in very specific contexts that in certain cases have led to or have contributed to the commission of an offense. Psychotic disorders, this is very common and relevant within the forensic context, and a very common set of disorders that mental health court will often see. Now, the prevalence of psychotic disorders is not nearly as much as mood and anxiety disorders, and it also varies depending on the type of illness. Now, one thing I want to be very clear about is when we talk about psychosis, psychosis is not a diagnosis. It is merely a symptom of a specific disorder. For example, chest pain. Chest pain is not a diagnosis. Chest pain could be the result of a heart attack, chest injury, infection, and so on and so forth. Psychosis is the same thing. It's not a diagnosis. It's usually an indication that there is a condition that is causing it. And there are different symptoms that can be within the scope of a psychosis. So delusions, hallucinations, disorganized behavior, thought process, so on and so forth. And there are numerous different causes of a psychosis. So schizophrenia can cause it, mood disorders with psychotic features can cause it, a drug-induced psychosis as well, so drugs can cause it, and people that can have brain injuries or neurocognitive disorders, they can also cause psychotic features. The bottom line here is that there's numerous different causes of psychosis. As I say, is if someone has psychosis, our differential diagnosis would be quite broad, and we would have to rule out each one of these conditions to figure out what is the ultimate cause of this individual's psychosis. The course of the psychotic disorders is really dependent on the cause. So schizophrenia, these individuals tend to suffer from long-term symptoms of psychosis. So they're very chronic. Now, medications often can attenuate the symptoms, but they may not cause a complete remission of the symptoms. The effects of substances, the psychosis can be transient, right? So it may last days, weeks, or months. Mood disorders, their psychosis depends on the treatment of the mood disorders. You treat the severe depression and the psychosis will remit. If the depression does not get treated, the psychosis tends to persist. And people with head injuries and neurocognitive disorders, their psychotic symptoms can be quite variable. Drugs, and drugs. This is a huge problem, particularly within the forensic context, because drugs can mimic a lot of other psychiatric conditions. They can mimic psychotic disorders, they can mimic mood disorders, they can mimic anxiety disorders, and substance use disorders are quite common. Now, in the medical sense, an addiction is treated as a mental disorder. In certain legal contexts, that may not actually be the case. From my perspective, one of the substances that is very commonly coming up within our forensic context is methamphetamines. In fact, more than opioids. And the reason methamphetamines are a huge problem for us in forensics is they tend to cause a lot of psychosis, irritability. They increase the risk of someone's aggression, violence, and those kinds of things. And so this is a huge problem within our mental health field, and our addiction services is trying to figure out solutions to address this particular issue. Next is neurocognitive disorders or dementias. So this is becoming more and more of a common occurrence, particularly within our service as the population ages. Dementia is an irreversible decline in one or more cognitive domains that is significantly impacting the function of individuals. And the prevalence of it naturally will increase by age. And there's different kinds of dementias depending on what part of the brain is being affected. So it can be Alzheimer's, frontotemporal, Lewy body, and there's so many different other kinds. This is important because as an individual starts to develop symptoms of dementia, it can have significant impacts in terms of their behavior and their functioning and their ability to control certain behaviors. And this, once again, starts becoming relevant within the legal or the forensic context. It's very common actually for us, particularly in court, to come across individuals with developmental disorders, so such as autism spectrum disorder or intellectual disabilities. I'll touch on just a little bit about FASD because we get a lot of questions regarding this. FASD is an umbrella term that includes physical, mental health, behavioral, and cognitive effects that occur in people with prenatal exposure to alcohol. And so this is actually a very preventable condition. Often when individuals are drinking alcohol, particularly in the first trimester, is when a lot of the brain development is occurring, it drastically increases the risk of someone developing an FASD-like illness. And that can have significant implications for this individual for the rest of their life, for the child that will be born. They'll struggle with all sorts of behavioral problems, addiction-related concerns, impulse control, and those kinds of things. And there's different types of fetal alcohol spectrum-related conditions. One advice I'll give to a lot of the lawyers here, and this is very important, is you have to readjust your approach when dealing with individuals with developmental or intellectual problems to accommodate the severe cognitive impairments of your client. You cannot approach a client who has severe intellectual disability as if you're approaching an individual who is completely normal. The way you speak, and how you present information has to be a little bit different. Otherwise, what will happen, or at least what I've seen is, the issue of their fitness to stand trial will come up, and then we'll say as doctors, oh yeah, I've assessed them, they're actually fit to stand trial. And then the lawyer's like, what? How's that possible? Like, I can barely speak to them. One advice I'll give is seek the guidance from either mental health professionals. So we're available in mental health court, or with your own colleagues who regularly work with clients with intellectual disabilities or disorders. And they'll be able to kind of guide you and provide some strategies of how they communicate and work with their clients. Personality disorders, this is very common. I'm sure everyone has come across this at some point. A personality is an enduring pattern of perceiving, relating, and thinking about yourself and the world around you. To boil this down in simple terms, personality is kind of like the software of our brain, and it really dictates how we interact with the world around us in general. So some people are very shy, some people are very confident, some people are very arrogant, some people are a bit more paranoid and reserved. These would be all classified as our personality traits or personality features. And this is what makes humans human. And this is what creates the diversity of the different people that we have around us. A personality disorder is the extremes of these personality traits. And everyone will have personality traits, but not everyone has a disorder. And in medicine, we've categorized personalities into three major different kinds of categories. The type A's, these are individuals, the way to think of them are, they tend to be a bit paranoid, recluse, eccentric, suspicious individuals. This is not the type A that we typically think about as, the front runner, and they're really trying to in school or their profession. The type B's are known as your classically as, people who are very dramatic. You'll find a lot of criminals who don't follow rules and laws tend to fall within this category. The arrogant individuals, the borderline personality disorders. Classically, an example is they'll say something like, I hate you, but please don't leave me. I hate you, but please don't leave me. This is like your categories of category B of personality disorders. And then the category C or type C often are your very dependent, avoidant, or very obsessive individuals. So why this is relevant is because individuals who suffer from personality disorders, it will impact how they behave, how they function, and how they're interacting with individuals around them. Particularly within the forensic context, this becomes relevant when, let's say, someone is facing criminal charges and they, let's say, do not want to participate in court, or they don't want to participate in specific assessments. It helps us understand why someone may be behaving the way they are behaving. The last category I'll just touch on is paraphilic disorders. And the reason I'm touching on this is not that it's extremely common or anything, but it's very relevant within the forensic context. And there's a lot of confusion around the terminology. So a paraphilic arousal is, or a paraphilia in general, I'll define them. A paraphilic arousal is a stable pattern of arousal to inappropriate stimuli. So it'll be something inappropriate, someone will feel aroused from it. That's it. A paraphilia is a recurrent, sexually intense fantasies, urges, or behaviors to an inappropriate stimuli. And a paraphilic disorder is when this paraphilia is lasting for more than 6 months and it starts to cause distress to the person, or it starts causing harm to other individuals around them. So for example, someone may have, let's say, a pedophilic paraphilia. So it's let's say, they're having these thoughts of children and they're feeling aroused pertaining to them, and they're really bothered by this. So let's say they haven't acted on it or anything, but they're feeling extremely distressed. It would be considered as potentially a paraphilic disorder in that particular case. And specifically, if they start acting on it, that may then also create that harm, which then would be classified as a paraphilic disorder. The one thing I wanted to clarify is that a paraphilic arousal is not equivalent to a paraphilic disorder. In fact, some studies show that about 62% of men in the community report some arousal to at least one paraphilic stimulus. So that doesn't mean that just because they've had an arousal to a paraphilic stimulus that they have a paraphilic disorder. There's all sorts of different kinds of paraphilic disorders. So one of them is known as fetishism. So that's use of like non-living objects, or pedophilia. This is something that often we've heard about, is arousal to prepubescent children, or frotteurism, where when people are touching or rubbing against non-consenting adults. So this is commonly seen in crowded buses or trains, where an individual particularly will stand in a crowded group of individuals and they'll get sexual gratification or pleasure from it. So there are numerous different kinds of paraphilic disorders. And if an individual has one paraphilic disorder, a rule of thumb is try to look for an alternative one as well, because they often are not presenting just alone. Patients tend to have multiple paraphilic disorders. The causes of paraphilic disorders, it's very multifactorial. There are different theories related to it. There are some biological components. There's some childhood learned behavior component to it. The bottom line is it is very multifactorial, and you cannot hang your hat on just one specific factor or cause. And this becomes relevant, particularly within the forensic context, when we have to help understand or explain why an individual behaves the way that they have behaved. The last thing is, I'll just briefly touch on the categories of sexual offenders. So, just because someone has a paraphilic disorder doesn't necessarily mean that they have they're a sexual offender. But just for the ease, I just put it on the same slide here. There are different categories of them. There's rapists, there's non-familial child molesters, there's incest offenders, there's mixed. The key point I wanted to make here is that child molesters are not necessarily always suffering from a pedophilic disorder. And this is something that in forensics we will often help clarify and explain why that is and how these two are different from one another. The final thoughts on just the entire diagnosis piece is I want to share the complexity of making these diagnoses. The practical reality is it's uncommon to have someone who just has one disorder alone. Often individuals will present with multiple disorders. So when, let's say, forensic assessment is ordered, depending on whatever the nature of the assessment may be, when we diagnosis, we might say, oh, he has schizophrenia, he has a personality disorder, he has a substance addiction, and he has, let's say, a depressive illness in addition to that. The key thing here is that sometimes the most prominent symptoms that an individual is displaying may not really even be relevant to the legal issue at hand. And so it is important to then specifically consider the disorders that are most relevant to the legal question. So for example, in let's say a criminal responsibility assessment, the disorder that would be really relevant would be, let's say a psychotic illness, right? Maybe not as important would be something like, say, an anxiety disorder or a personality disorder. So the key thing is I always encourage everyone to think about the alternative hypothesis or motivations, particularly when we're doing these assessments and when we're thinking about the diagnoses. Just briefly to touch on treatments. So when you have a client who's suffering from mental health related concerns, as clinicians, when we're thinking about treatment, the treatment is broken down to three major categories. The biological, which involves medication, the psychological, which involves therapies, the social, which involves housing or financial support, and then there's some additional types of treatments or unique treatments that we can offer in the mental health field. And the location of that treatment becomes very important because it will impact the nature of the treatments that we can offer somebody. So there are certain treatments we just can't offer someone while they're in jail, but we can offer some of those treatments while they're in hospital, for example. So when you're thinking about your client and you're, let's say, working with them and they're in trouble with the law and we're trying to put together, let's say, a treatment plan, the best treatment plans are the ones that hit all three of these components, or at least we're mindful of them. One example I'll give is it's very hard to treat someone's depression biologically with medications when their social issues of homelessness are not addressed. If we really want to treat their depression, we probably would have to treat their social related issues before we really even start considering medications or some of the other therapies. I just thought I'd bring up this concept of community treatment orders. This is very common, particularly in my line of work, in forensics and also in general psychiatry. A community treatment order is essentially, it helps ensure that a patient remains adherent to treatment in the community. Because there's some patients who just will not take their medications for whatever reasons. And if they don't take them, they get quite sick, or let's say they get psychotic, they end up back in hospital, or they end up committing potentially a crime. So it's important that they remain on treatments, and a CTO can help do that. Now, CTO is reserved for special cases. There's a very specific criteria about it. And one of the most important things is that the patient technically has to consent to the community treatment order. But there are some instances where a CTO can be issued without their consent. And practically what happens is that if an individual misses their medication or they don't come in to get their shot or their injection, the doctor has the ability to issue an apprehension order. And so peace officers then will go find the individual, and their job is to just transport them to hospital for an assessment to determine if their mental health condition has deteriorated or not. The last thing I just wanted to touch on this part of my talk is who does what in mental health. There's a lot of different clinicians that you will come across. So it's very important to figure out who's making a diagnosis and who to approach and for what. So versus psychiatrists. So psychiatrists in general, they'll do a 4-year, usually an undergraduate degree in something, and then they'll complete a medical degree in a medical school for approximately 4 years. And after they've completed their medical degree, they'll then go on and do specialization in which is known as your residency, which typically is about 5 years. And then after that, you'll become a general psychiatrist. And if you want to become a subspecialist in a particular area, you can do additional subspecialty training in either forensics or geriatrics or child and adolescent. And some individuals will also have a master's or a PhD. The key role of a psychiatrist is will help with diagnosis, will help with treatments, and will help with risk assessments as well. So these are some of the roles that a psychiatrist typically ends up playing. And the treatments we can do is we'll be able to prescribe medications or also do therapy. Psychologists, their role is a little bit different. So they'll complete usually an undergraduate degree, so it'll be 3 or 4 years, and then they'll go on often to do a postgraduate education, either get a master's or a PhD. And they really specialize in therapy. They can help in risk assessments, and they're really good at utilizing the psychometric tools and the statistics associated with them. So often in forensics, psychiatrists and psychologists, we work in collaboration quite closely. They really help us with some of these psychometric tools to aid us in the diagnosis that we're making and also in the risk assessments. There's therapists and counselors as well. Training is quite variable. So they may have training of just a few months in a particular course or certificate program, up to about sometimes 2 years. Their goal is specifically focused on therapy. And one thing I wanted to clarify is that sometimes what happens is someone will make a diagnosis of an individual, and let's say it's a counselor or a therapist. It does start creating a lot of confusion in terms of, when they present for a forensic assessment, because it's like, well, where did this diagnosis come from? And so therapists or counselors technically are not supposed to be making diagnoses. And so if you have a client who's saying, I have been diagnosed with, let's say, schizophrenia, the most important question to ask is, well, who diagnosed you with that condition? And that might give you some perspective or guidance in terms of what may be occurring with that individual. And lastly, life coaches are becoming a lot more popular. There's no specific training in order to become a life coach. So just the summary for the first part of my talk, we've defined what a mental disorder is. We've talked about the medical and legal definition. I spoke a little bit about how we diagnose mental disorders. We reviewed the different categories of mental disorders. We spoke a little bit about the approach to treatment. And the last component is the role of kind of healthcare professionals and who does basically what. So that was the first part of my talk. Danny, do we take a break now? Or do I go on directly to my next part of the talk?
Well, if you want, we have a couple of questions that have come in on your first part of your presentation, and then we'll take a break after your second presentation. Did you want to answer the questions now or at the very end?
I could probably answer them now.
Okay, so the first question is, when would an individual with a diagnosis of FASD be considered to have a mental disorder?
Excellent. So if an individual has been diagnosed with FASD and they've had testing, that would classify as an individual who has a mental disorder. And the way it is categorized within the DSM is they'll refer it to as a intellectual disability, or it can technically be referred to as a neurocognitive disorder as well. So theoretically, if someone has formally been diagnosed with FASD, the diagnosis of that would essentially indicate that they're likely suffering from a mental disorder.
Okay. The next question is, are there common issues that tend toward a diagnosis of unfit to plead or a mental disorder resulting in a determination of not criminally responsible?
Can you just repeat that question one more time?
Sure. Are there common issues that tend toward a finding of unfitness or a mental disorder resulting in NCR?
Yeah, so the common issues usually when it comes to the issue of fitness and specifically NCR is the psychotic disorders. So one would be, I think, psychotic disorders, and the other is individuals who have neurocognitive disorders or severe intellectual disabilities. So these are the most common ones that will often come up and are very relevant when we're doing assessments of unfit to stand trial or NCR, because these conditions significantly compromise our cognitive functioning and our ability to understand kind of reality and what is occurring. So if someone's suffering from a psychosis, the way they process thoughts, the way they think about certain things, and the symptoms that they're experiencing can be so severe that they're really not able to even appreciate or let's even engage in any kind of meaningful conversation. So whenever we're doing those kinds of assessments, you'll see, particularly in our fitness to stand trial assessments, we'll often comment on the element of psychosis. And we almost definitely comment on the issue of psychosis when it comes to not criminally responsible assessments.
Sorry, I had muted myself. Um, that same individual has asked a bit of a follow-up to that second question, the one dealing with unfitness and mental disorder, and was wondering, is there anything specific in those with respect to FASD diagnosed patients?
Yes, so FASD patients are very challenging because their intellectual, they often are suffering from significant intellectual disabilities. So, they may struggle with just basic abstract concepts, right? So, for example, if I ask somebody, well, what does a judge do? They may not even have the capability of understanding the information that's being presented to them, even when I'm providing education, right? Is that, well, this is the role of the judge. To them, that might be too abstract, and they may not even be able to understand that piece at all. And this becomes a bit of an issue because technically, if they're suffering from FASD and they have severe intellectual disability that's rendering their cognition compromised to that extent, it's kind of like those impairments are permanent, so they will never get better. But now let's say this individual is out in the community and they committed an offense, right? So let's say they assaulted someone. They do struggle with a lot of impulse control related issues. So now they get charged, they come to court, but they're not even understanding what court is. They're not even understanding where they technically are. So then the issue becomes is that, well, like, what do we do? Do we, let's say a doctor will say, yeah, they're unfit. Do they then go towards the Alberta Review Board? Are the charges serious enough that, or let's say the charges are not as serious, sometimes the Crown may decide that, well, it's not worth it. We'll just drop the charges and then the person gets released. So it really depends on the individual's intellectual capability. Not all FASD individuals are that severe, right? So that's what I was saying. It kind of varies. There's often numerous patients that I've assessed with FASD who have a very clear understanding or a very basic understanding, sorry, of kind of the judicial system and what a lawyer is supposed to be doing and why they're in court. But an issue often comes up is that for ones that are very severe and they're in trouble with the law, it's kind of like, well, what do we do? Because on one side, if their charges get dropped and they get released, well, they're likely to commit another crime again. But the other side is that, well, if they're not fit, they may never actually ever become fit. So that raises other legal questions in terms of what to do with them.
Okay, thank you. We have a couple more questions. Individuals asking, when is it logical to refer someone to a mental health or mental health diversion program? So I'm assuming mental health diversion or mental health court.
Yeah, that's a question that I probably will be answering in the next part of my talk. So I'll hold off on answering that right now.
Okay. And then they had a second question is, how will you consider someone who is said to be a habitual offender? What factors could be underlying?
Excellent. So related to habitual offenders and the factors that are underlying them, I'll be covering that briefly in the second part of my chat as well.
Excellent, thank you. There's another question, but I'm just asking that person for a follow-up, and perhaps we can deal with it after your next presentation.
Sure.
So that's the questions for now. Is there any other questions? If you want answered right now, please put them in chat right now. Otherwise, we'll allow Dr. Syed to continue with his second part of his presentation. All right.
Okay, ready to start?
Oh, we do have a question that's just come in. How do you deal with those who are in denial of their conditions?
I wish there was a magic pill to increase insight into one's condition, but unfortunately there is not. Denial is quite vast, and it also depends on the nature of the illness that someone's suffering from. And so in our assessments, we will often comment on an individual's insight into their illness, because their insight also determines whether or not they'll be accepting treatment, or if they even have the ability to make treatment decisions for themselves. So as an example, this is very common actually, individuals who are suffering from very severe schizophrenia, they have often no insight in terms of that they are suffering from this illness that is causing their particular condition. So as an example, I have an individual that I'm treating presently. He has schizophrenia, but he also has HIV and hepatitis C. And he has a belief that there's no way in this world that he's suffering from HIV or hepatitis, because his head was cut off from his body and attached to another body that didn't have HIV. And so by virtue of that, he's not suffering from HIV or hepatitis. Now, this explanation makes absolutely no sense to me, right? And he's clearly suffering from significant symptoms of psychosis. But, if I tell him, and I have told him, like, well, I do think you're suffering from schizophrenia, and I do think you have HIV or hepatitis, that he's adamantly saying, no, I don't. Like, you're crazy. He's like, you don't know what you're talking about. And so the way we handle this is, it depends on the context of where we're treating them. It depends also on the context of the nature of their illness. And often, if someone is suffering from, let's say, some condition, whether it be schizophrenia or depression, the most common thing we'll do is we'll assess for an individual's ability to make treatment decisions. The majority of patients actually do have the ability to make their treatment decisions despite denying that they have a mental disorder. So for example, we'll see someone and let's say they're suffering from an anxiety disorder. I'll explain to them, look, I really think you have this anxiety disorder. These are the treatments. They'll say, no, I don't have it. So then what we're doing is, we'll then assess, do they have the capability of understanding the condition? Do they have the capability of understanding what the treatments do, what they don't do? And ultimately, if an individual refuses treatment, then they have the right to refuse treatment. Remember, like, it's difficult for us to forcibly treat somebody against their will. Like, you have to be extremely compromised in terms of your mental faculties for someone to make treatment decisions on your behalf. So that's kind of how we handle the denial component. Is we try to provide as much psychoeducation as possible, but more often than not, the reality is that they come to us voluntarily. We say, hey, this is what I think you have. And if they decline, they ultimately end up declining. And often I find some of those patients do end up eventually coming back when they find that their health is deteriorating, or their functioning in their work or their personal life just continually remains compromised. So they'll often then come back and say, okay, well, I'm willing to give this a try now because things are not getting better for me.
Excellent. Hi, Sue. I noticed that you had your hand up. Do you want us to open up your mic so you can ask a question?
Sue, for reference, your mic is enabled, so if you'd like, you can take yourself off mute, because by default it puts you on mute. So if you had a question, you can ask it now. Otherwise, we'll let Dr. Syed continue with the second half of his materials. A few moments here. Okay, she said that was just an error.
Was it an error?
No,
okay.
No worries.
So I think those are our questions for now, Dr. Syed, if you wanted to proceed to the second half of your presentation.
Perfect. So forensic psychiatry. This is my jam. This is what I do. And this is what I find probably the most interesting part of medicine. Obviously, I'm very biased, but I'm very passionate about this area. So we often get asked this question, what in the world do you do in forensic psychiatry? And often people think we are forensic pathologists. So forensic pathologists, they deal with individuals who are deceased, whereas forensic psychiatrists, we're working with individuals who are alive and they have committed often an offense. So it's an area of medicine that specializes in the assessment and treatment of individuals who are suffering from mental health disorders that ultimately have gotten in trouble with the law. So this is the area that we practice in, and it's a cool intersection between medicine and the law. So what are some of the roles of a forensic psychiatrist? So a forensic psychiatrist, we can help understand how someone's psychiatric disorder played a role or lack thereof in the commission of a crime. And this is quite relevant to the criminal responsibility assessments that we will do. We can also assess for fitness to stand trial. We can also assist in dangerous offender or long-term offender assessments. We will often do risk assessments. We can also offer treatment and rehabilitation of offenders or habitual offenders. And you'll find us in working in correctional facilities, in outpatient clinics and hospitals. And then we're also involved in diversion programs and mental health courts as well. So our role is quite vast, but we're involved in various different stages of an individual's judicial proceedings, you could say. The difference between forensic psychiatry and general psychiatry. So this is a very important distinction to make, and it's a common question that often comes up. It's like, well, what exactly differentiates you from a psychiatrist? So in forensic psychiatrists, we have an additional subspecialty training in forensics. And so we'll have a board certification in general psychiatry. So, we can practice within the general psychiatry realm, but we also have a board certification within forensics as well. We get specialized training within that additional year or 2 years of training that we do to do formalized risk assessments of individuals. We get training to do specialized legal assessments such as fitness to stand trial or NCR, pre-sentence reports, those kinds of things. We often will appear as expert witnesses to assist the court in various matters. So it really depends on the legal question that we are being asked, and we're assisting to help answer. And one thing that really separates forensic psychiatry from general psychiatry is that we have to consider malingering. Malingering is like the intentional feigning or production of symptoms for some kind of secondary gain when assessing patients or individuals. Now, the reason I put this in at this last piece is that a general psychiatrist doesn't necessarily have to think every single time when they see a patient that this patient may be lying to them, right? But here in forensics, we have to take that into consideration. And you'll see that in almost all of our assessments that we do, particularly related to criminal responsibility, we'll usually comment on the malingering piece, or if we think someone is intentionally producing their symptoms for some kind of gain. Malingering, just as a side note here, malingering is not a diagnosis. It's not a diagnosis in the DSM, but it is very relevant because in the legal context, let's say if someone is facing a very serious criminal charge, they may have a motivation not to go or not to be convicted of this crime, and they may have this desire to, let's say, get an NCR and end up in a hospital instead. So we have to figure out whether or not someone is feigning or faking their symptoms. And how do we assess for malingering in forensics? Well, similar to how we come up with diagnostic conclusions, but there's a few additional things that we can do. One is to assess if someone is malingering, we'll do interviews. So we'll interview the patient, we'll talk to them, and we'll observe them. The next thing is we'll also collect collateral information. So I forgot to put that piece in, which is extremely, extremely important. So we'll collect collateral information. We can do psychological testing as well. We can do, and based on certain psychological tests or personality tests, we can look at certain response styles to help determine whether or not that they're malingering. And there's some very specific psychological tests that we can use to help determine the nature of somebody's malingering. We often will work collaboratively with psychology when we're doing this kind of testing in order to either rule in or rule out somebody who is malingering. So that just covers a little bit about very generally in terms of what we do as forensic psychiatrists. The next thing I just want to talk a little bit about is how is our service organized? Because often people don't really know where we work or where our services is operating. So there's a couple of places you'll find us, and I'll go through the more relevant ones. So I'm particularly based at Alberta Hospital Edmonton. So Alberta Hospital has two components to it. They have a general hospital and then they have a forensic hospital. So I'm at the forensic hospital. You'll find us in correctional institutions as well, Edmonton Remand Center, provincial or federal custodial detention centers, parole clinics. We also have an outpatient clinic. It's called Forensic Assessment and Community Services. A lot of you may have already heard about us. If not, you'll hear about it today. And you'll also find us in Edmonton Mental Health Court as well. So I'll talk a little bit about Edmonton Mental Health Court shortly here and what our role is. So you'll find us in a couple of different settings ultimately. In Edmonton Mental Health Court, the advantage is you get access to a forensic psychiatrist, is generally me that's there. But you also get access to a forensic nurse as well, and we can provide relevant medical or psychiatric information about about the client that you may be representing. Now, there's some very specific roles that we will have as forensics within the courtroom. So number one is we can help with education. So often questions come up, oh, well, what is FASD? What is Curie FASD? What does this mean by this differential diagnosis? We can help provide some clarity in terms of those things. We can also provide information about your client, often very relevant information regarding their mental health, and that may have some implications, let's say, related to the commission of the crime that the individual has committed. The thing, though, is that we just can't open a patient's medical file and disclose all of this information willy-nilly. There is a specific consent form that the client or the individual needs to sign. So often their legal representation will review the consent form with them and then they will sign it. And only then are we able to open up and access their medical records or their psychiatric history and then share it with, let's say the legal counsel that's representing the individual. We can also help problem solve. So this may involve, an individual's getting released from custody. They have severe mental health problems and they need to be connected to, let's say, a clinic or setting up appointments or ensuring when they get their next medication. We can help kind of problem solve strategies to ensure that this individual who's being released from custody is appropriately connected to the correct resources in the community. The other advantage of having us in the courtroom is we can do fitness to stand trial assessments directly in court. Now, the assessments are very, very focused, but it can help guide a little bit in terms of are there active mental health fitness concerns or not. So we can do some rapid fitness assessments directly in the courtroom. The court itself runs Monday, Wednesday, and Fridays, and Amna Qureshi will cover all the details of mental health court a little bit later on today. But the forensic nurse and the forensic psychiatrist were typically there on Wednesdays. So the nurse is there Wednesday morning. I'm typically there on Wednesday afternoon. But we also have a mental health court email, which the nurse will typically monitor on a daily basis. The other area you'll find us is at the Edmonton Remand Center. So I'm there as well. And we do two things at the Edmonton Remand Center. We can do assessments that are ordered from court, or we also run a treatment clinic. So in terms of the assessments, we'll do fitness assessments. We do fitness assessments in person on Monday, Wednesdays, and Fridays. So we get there bright and early in the morning. If there's, let's say, a 5-day assessment order that's slotted and the individual's going to court today, we will do that assessment in the morning just before they go to court, put together a report and send it off to you guys so you have a very clear understanding of whether the individual is fit or not at that time. As fitness is fluid, it tends to fluctuate. Um, so that's where we do a lot of in-person fitness assessments. The other is we can do NCR assessments. So there's different places we can do NCR assessments, but if the individual is in custody and they're at the Edmonton Remand Center, often we'll go directly to the Remand Center and assess the individual there. We also run a treatment clinic. So our treatment clinic runs on Monday, Wednesday, and Friday. So if you have someone appearing in court that have very severe mental health symptoms that are quite evident or prominent, and you want them seen for treatment, the mental health team can always follow up with those individuals. The one issue is that we obviously cannot provide any information regarding their treatment unless the individual has signed some consent. A common question comes up is like, which assessments go to Alberta Hospital? So often what happens is that an NCR assessment will be ordered or a fitness to stand trial assessment will be ordered, and people are under the assumption it will be completed at Alberta Hospital Edmonton. That's not always the case. We are limited in the number of beds that we have in our facility. So we really have to triage who's coming into our facility versus who's being assessed at the Edmonton Remand Center. It depends on a multitude of different factors, but we try to bring into hospital individuals who are typically not well. So they're very sick, for example, and they just do better in a hospital milieu. So it's variable, but I wish I could give a more clear answer in terms of that. But the best way I can describe it is it's a triage process. Alberta Hospital Edmonton, there's a couple of things we do at Alberta Hospital Edmonton. So we have an assessment unit, which specializes in just doing fitness and NCR assessments. So individuals come there, they get assessed, and they head back to the Remand Center. We also have an acute care treatment unit. So this is the unit that I work on. And these are patients who are certified under the MHA, is the Mental Health Act, from correctional facilities will come here for treatment. And so these are individuals who are generally extremely unwell, where they get certified at their correctional facility and then transfer to our unit for treatment. And sometimes there are fitness assessments that are ordered on them as well, so we can do them at the same time. There are rehabilitation units. So these are NCR and unfit to stand trial patients who are under the review board. And the goal of those units is to adequately treat and address any pertinent risk factors for violence, with the goal to ultimately either A, get them fit to stand trial, or B, if they're NCR, to gradually reintegrate them back into society. And then we also have a young offenders unit as well. Alberta Hospital is located on the far northeast side of the city, so essentially on the way to Fort Saskatchewan. We also have an outpatient clinic. It's called FACS is the common name for it. We're located in downtown, so just dead central in downtown on 106th Street. And we offer several services there. So we offer a treatment clinic, so we can see patients for diagnosis, treatment planning, follow-up. Essentially, if they have a probation officer, they can just refer directly to our clinic. And it's a very common thing probation officers will do if the individual has any mental health related concerns, so we can see them for treatment. We also have a domestic violence program, so we'll do risk assessments and treatment as well. It might be part of their probation condition, for example. We also have a sexual offender program, so we'll do risk assessments and treatment. We can also do outpatient assessments as well, pertaining to fitness, not criminally responsible assessments, or pre-sentence reports. And the last thing I forgot to actually put on here is the mental health diversion program is located at FACS as well. This is what our clinic looks like from the outside, just in case people are wondering or if they're passing by. One thing I'll say, we get this like request all the time for our clients, and just given the nature of a lot of our clients, they are living quite itinerant lifestyles. They're often homeless with limited financial supports, and often we'll get this request of sorting out housing, or individuals are told to come to our clinic and we'll be able to sort out housing. One message I want to give on this is it is extremely difficult for us to arrange housing because the wait lists are very long, often months and sometimes lasting more than a year. So it's something that we can sometimes assist in, but I just want to rescale the expectations in terms of how quickly somebody can be housed. It's not easy. And often some of the patients we're seeing, they're quite difficult patients, and so they've sometimes been rejected from multiple different housing programs and facilities. So it's a huge problem, but I just want to make it clear that it's not something that we can easily address at our clinic. I was asked to touch a little bit on risk assessments because this is kind of a very important area of forensics. Is can we predict somebody's risk of doing something in the future, either long term or short term? So let's talk a little bit then about how we do these risk assessments and what really is risk. So I always like to start off with defining what we're looking at. So risk, what is it? Risk is technically the probability that an examinee will engage in a certain kind of behavior in the future. So this could be physical violence, sexual violence, the risk of just committing generally another crime. Those are the kinds of things that would categorize as risk. Now, risk assessment, or what is the purpose of a risk assessment? It depends actually, and it depends on the clinical question or legal question we are being asked. Purpose of risk assessment could be to potentially predict someone's recidivism, potentially to prevent violence. It can also be used to guide treatment, or all of the above. The bottom line is that it depends on several different variables and factors. It also depends on the nature of the assessment that we're doing. It also depends on the location of the individual. Are they in custody? Are they in hospital? Are they in the community? Where are they ultimately? So obviously in the context of forensics, we often will assess someone's risk of violence, recidivism, sexual offending, domestic violence. These are the kinds of risk assessments that we will do. But there are multiple other areas that are not often known about where our risk assessments can be used. So obviously DO or LTO proceeding, very common. Like you'll never see someone who's made an application for a DO or LTO not have a risk assessment. But they're also used in parole decisions. An individual who's been found NCR, we always are doing risk assessments, because if an accused is no longer a significant threat to the safety of the public, they should technically be granted an absolute discharge. And the risk assessments will help dictate the restrictions that an individual will have on their liberties. We often use risk assessments in civil commitments, so certification under the Mental Health Act. It's seen in duty to warn or duty to protect, assessing workplace violence, immigration and deportation hearings, school violence, and many other areas. The most common places where we will actually be doing risk assessments as forensic psychiatrists is usually with NCR, civil commitment, psychiatric malpractice, DO or LTO hearings are usually the common places where we are involved. Not all risk assessments are useful, and not all risk assessment tools are useful either. So there are certain things that make risk assessments tools useful. Number one is accessibility. If a risk assessment tool, or the ability to do a risk assessment, the accessibility is low or almost impossible, well then that makes that tool not that beneficial to that individual. The other is the administrative feasibility. Are we linking it to established policies or practices? The scientific integrity. Is the tool or the risk assessment measuring exactly what it is supposed to be measuring? Practical situation is the efficiency of it. Like, we're all on a time constraint. So we have to look then at, well, how long does it take to do these risk assessments as well? And the other is the testability of the risk assessment or the risk assessment tools. Are some things that will make a tool more useful than others? How do we conduct risk assessments? I wish we just had the ability to look at someone and say, yeah, this person will commit a crime for sure. 95% chance in the next 3 days. I really wish we had the ability to do that, but the reality is that we don't. And so we have to do often a very comprehensive assessment, and that involves several components. Number one is interviewing the client. Number two is reviewing all the collateral information that is provided to us. And that will involve documentations that we receive, but also doing collateral interviews as well of like, other physicians who may have been involved in the care of the patient, family members, those kinds of things. We'll use tools. So there's some very specific risk assessment tools that we use to help guide our risk assessment. And the last component is we then try to integrate all of the above information and all of the pertinent information, and we try to contextualize it to our client or that patient to help understand in what scenarios will they be at higher risk or what scenarios will they be at low risk, or we'll use that information to help guide their treatment to reduce the risk of whatever we've just assessed. One of the key things, and I've highlighted this here, is the assessment is based on the available information. This is why in forensics we have this rule is send us everything, whatever you have. We don't care if it's 1 box, we don't care if it's 10 boxes. Send us everything. The more information we have, the better, because our information is fluid, right? I can only base my opinion with what I have. And sometimes when new information becomes available, it can change our opinion in terms of an individual's risk. I'll talk about the 3 common categories of risk assessment tools. Category number 1 is unstructured clinical decision making. So what this involves is it'll be a clinician speaking to an individual, and then based on kind of their assessment, speaking to them, they'll make a determination in terms of, yeah, I think this person is at risk of doing A, B, or C. Now, there's a lot of disadvantages to this approach. Well, and that is the testability of it and the bias as well, is that each clinician's experience might be slightly different. So they may approach that client that they're assessing in a different way. But there are also some advantages as well, is it's much more flexible. You can really get into the details of who this individual is. You can really contextualize it to that one specific individual. Practically speaking, in forensics, we often do not rely just on unstructured clinical decision making, particularly in the context of court. You really open yourself up to a lot of questions, particularly when there's other risk assessment tools that we can use. So the other 2 categories is actuarial, and the other is structured professional judgment tools. And I'll describe what these 2 are in the next slide here. The key thing is majority of the tools look at 2 types of risk factors. They'll look at static risk factors. So these are factors that do not change. For example, someone's age, their gender, their childhood history, the criminal history that they have. So very static, fixed factors. And then there are dynamic risk factors. So these fluctuate and change over time, which can be quite relevant to someone's risk of, let's say, a future crime. They're also known as criminogenic needs in the area of medicine. And they can involve something like housing, employment, insight into their illness, the symptoms that they're actively having at that time. So for example, if someone is floridly psychotic and they're delusional and they think that somebody is tracking them and they're going to kill them and they're afraid, and so they're procuring weapons to protect themselves. Now, let's say if they get treated and these delusions go away, well, then their risk of responding in a violent way has also changed. So dynamic factors can capture that. So these are changeable factors. So the actuarial risk assessment tools, this is very similar to how insurance companies operate. So let's say, car insurance. So they'll look at your age, they'll look at your gender, your location that you're living in, the kind of vehicle that you're driving, and then they'll compare it to a base population and say, well, individuals that have these factors, they're at 60% risk of having a car accident within the next 3 years, for example. So are focused on looking at these static, often unchangeable factors. So in the context of forensics, some factors will be like, did they live with a biological parent to the age of 16? Or did they have a failure on a prior release condition that they had? A common tool that you'll often come across is called a VRAG, and then there's a sexual version of that as well to assess sexual offending risk, which is known as SORAG. The advantage of these actual risk assessments is one of the biggest advantages that people find is it gives you a probabilistic estimate. So it'll say like, based on these factors that your client has, compared to this base population that we developed this tool off of, this individual has a 69% chance of having a violent offense within the next 10 years because this base population that we base this tool off of, that's what they did, is that those characteristics, those individuals within 10 years, about 69% of them committed a crime. It's kind of useful, that clear number, or people just tend to respond better when they have a very clear percentage number. And the tool is based on very statistically derived factors. But there's also disadvantages to these tools as well, is that they may not be able to track the dynamic changes to somebody's risk. People's situation and circumstances change. And as their circumstances change, their risk of, let's say, violence can also change as well. Their risk of short-term violence may be different from long-term violence, right? And so actual risk assessment tools are a little bit limited in integrating these dynamic factors. That's just not what they're designed to do. And this is where the other types of risk assessment tools come into play. These are called structured professional judgment tools. And so what happens in these specific tools, you're taking well-established risk factors that are related to, let's say, violence, but we're now contextualizing them to this particular patient or individual. And we'll say, okay, well, these 10 factors are connected to or have been shown to be important in individuals' risk for violence, but the ones that are really relevant to my patient are these 4 or 5. So this helps ensure that very critical items are not missed when we're estimating someone's risk for, let's say, violence. They're not very sample specific, right? So they have a very broad range of application. And the coolest thing about these SPJ tools is that they can help guide risk management, right? And we can come up with risk management strategies because we're clearly identifying dynamic factors that can change. And these dynamic factors that can change also impact someone's risk of violence. So for example, housing, right? So let's say if someone is living on the streets and they're actively using substances and they're off their medications. If, let's say, we treat these 3 major factors, their risk of potential violence can also drastically decrease. An SPJ tool can capture that, and the SPJ tool can also help guide treatment for that individual because we know these are the 3 factors that are quite relevant to the individual's risk of future violence. The biggest disadvantage is you don't get a probabilistic estimate. So you won't have an SPJ tool saying, well, the risk that this individual is going to commit a crime in the next, 2 years is 63%. The most you will get is the risk of violence is high, medium, or low, right? And then the question becomes is like, well, what does that mean? Like, what do you mean low? Like, is it like it doesn't exist? Like, how low are we talking about? So this sometimes creates difficulty for, particularly within the legal context, when we say, oh, they're at low risk. The common question is like, sort of, what do you mean by low risk? But remember, the approach is different, because when someone asks us low risk, that's when we get directly into the risk factors, that the dynamic risk factors that are really important to this individual. We'll say, well, based on their past history, we know that we're going to address their homelessness. We've addressed their substance-related concerns. Their schizophrenia is adequately treated. They now have insight into their illness. They know that they need to take medications, and if they don't, they can get sick. So you'll get a little bit more of a descriptive narrative regarding someone's risk using some of these tools. And there's numerous different kinds of risk assessment tools, and that depends on the nature of the assessment that we're doing. So there's ones for domestic violence, there's some for stalking, some for workplace, and then there's some related to just general risk of violence, such as the HCR version 3. So the key is that there's some general tools, and then there's some SBJ tools that are very specific to the nature of risk that we're assessing. Now, what to look out for as lawyers. So let's say you have a client who has had this risk assessment, or you're representing them in a particular context, and you see this risk assessment. What are some things you need to be looking out for? Well, number one is, what kind of risk is the clinician predicting, right? Are we predicting the risk of domestic violence, general recidivism, sexual offending? What exactly is the risk? The second thing is, well, what kind of risk assessment tools are we using? Because remember, each tool has its pros and each tool has its cons. Are we predicting short-term risk, or are we referring to long-term risk? And this has significant implications in certain contexts. So for example, in dangerous offender or long-term offender proceedings, their short and long-term risk becomes very relevant. The other is that, are we using the correct risk assessment tool? Is the risk assessment tool applicable to your client? So let's say you have a actuarial risk assessment, and the base population that it was developed for is very different than your patient. The question becomes is that, well, I mean, can that actuarial tool then actually be used to predict, the risk for your patient? So it's a question for you to ask or think about at least. The other is that, what information is the assessor using to determine risk? And as I explained, is that the more information we have, the better. The less information we have, we can still provide an opinion, but like I said, the more information we get, or if new information becomes available, it can potentially change our overall opinion of the individual's risk. Is the clinician using a combination of both actuarial and structural professional judgment tools? I often suggest and recommend is the use of both tools combined gives you a much more holistic understanding of somebody's risk. It's nice to have all the static factors addressed, use a different tool to look at some of the dynamic factors as well. And this will give you a little bit more of a comprehensive understanding of what is happening with the individual and their risk. You have to think about the issues of bias. And the key point I want to make here is, we can never predict risk with 100% certainty. At the end of the day, we're dealing with probabilities. What is the likelihood someone will commit a crime? What is the chances that they will do this? What is the risk for that? We can never be 100%. And this is what makes our job very challenging, but at the same time, it also makes it very exciting as well. So just a quick summary. So far, we've covered in the area of forensics. We talked about what is forensic psychiatry. We talked about what the role of forensic psychiatrist is. I spoke a little bit about the organization of our service. I talked a little bit now just about our risk assessments and key things for you guys to look for if you have an individual who who's had a risk assessment, and how to critically kind of think about some things when reviewing those kinds of assessments or reports. So I've made this particular part a little bit short, just to open up a little bit more questions from the audience if you have any.
Thank you, Dr. Syed. I think Amna has a couple of viewer questions for you.
Sure.
Yes, thank you so much, Dr. Said. I learn from you so much every time you speak, and I've of course had a really great opportunity to hear you speak many times and educate us on the fly sometimes in mental health court. This is an invaluable resource for myself and many others who work in mental health court and mental health law. So I just want to reiterate how important it is, this is an area of law that necessitates interdisciplinary education and understanding, and we can't do our jobs very well without that. So thank you. We got a couple really good questions, and I'm going to take some liberties with the questions to make sure that you can answer them as expansively as possible to provide the most benefit, Dr. Said. So one of our questions comes from Counsel Callie Swick. Callie is wondering, what would lead to a transfer of a patient, or sorry, an inmate or a client who's being held at ERC or remand center to be transferred to the hospital for an assessment, whether it's a fitness or NCR issue, and how perhaps could counsel advocate for such a transfer if they see that perhaps their client's not doing well in remand?
So a very excellent question. And I kind of alluded to this a little bit is it depends on several factors. Number one is probably the most important factor is bed availability. There are times during the season when we just don't have that many patients on our assessment unit. And then there are times like currently where we're operating at 100% full capacity. And so when things are not nearly as busy, it's much easier. Like if there's a 30-day assessment order, let's say for criminal responsibility or fitness, we can easily just quickly ship them over to the hospital and assess them there. When things are busy like now, we will triage, and we're really trying to triage based on how unwell somebody is and how sick that they are at the remand center. Sometimes for some assessments, given the complexity of the assessment, it sometimes becomes a bit challenging to do some of those assessments at the remand center. So if we know that this is someone we'll probably have to assess 5 or 6 times, or I need a couple of weeks to see them almost every single day in order to do the assessment, then we'll transfer them over to Alberta Hospital. So that's how we're kind of triaging them based on the severity, based on the complexity of the assessment that has been ordered. The way to advocate for the client is it's how it's done in mental health court. So if I'm there, I can kind of see and we can discuss a little bit about what's going on. The other is you can always email me or you can email the Edmonton Mental Health Court, and they'll usually fire the email over to one of the docs. It's typically Dr. Will and myself will help triage what assessments are going where. And this happens quite commonly is that counsel may reach out and they'll express that they're very significant concerns and the individual is definitely not well. We also have a treatment clinic at the remand center as well. So we may already be quite familiar that this individual is not well at all. And so in those contexts, we can kind of move people over. So I hope that helps give a little bit clarity in terms of how that triage process works and how to advocate for your client to go to Alberta Hospital.
Yes, thank you, Dr. Said. This is a niche kind of area, it seems that a lot of counsel are interested in, and we do have follow-ups from Kale and Jacqueline, and I'll try and do my best to kind of combine the questions. I see that there's a lot of interest in understanding perhaps the difference in treatments available for mentally ill clients in ERC compared to the hospital. And, certainly a recognition of incarceration tending to exacerbate mental health symptoms. So I'm wondering, Dr. Said, if you could speak to perhaps one, uh, if you can comment on the difference in treatment that may be received in ERC versus the hospital, and why we should be concerned about exacerbation of perhaps mental health symptoms at remand.
That's a very excellent question. So The biggest difference, and there is a huge difference, is the remand center is technically not a hospital. So the way it's structured and the way it's not run by Alberta Health Services. We're simply a guest in that facility offering a service. And so it's not a therapeutic environment in any capacity. And so what practically happens is when we're running these clinics, let's say on Monday, Wednesday, and Friday, we'll be seeing quite sick individuals. But the problem we have is volume. And it's just the number of patients is just immense. And so what that involves, what that means is that, let's say on a Monday, I have about 50 patients on my list. I'm not able to see 50 patients. That just won't be feasible. And even if I was, it's really, you're not spending any kind of meaningful time with each individual. So what happens is that we end up reviewing a lot of files, and the treatments that are offered maybe, just purely medications alone, and then they'll be followed up in a couple of weeks time, or 3 or 4 weeks, or in 4 weeks, or in 8 weeks, for example. So you're just barely touching, I feel, the surface. We really try to triage seeing individuals who are extremely unwell, but the reality is that as forensic psychiatrists, we're not there at the remand every single day during a treatment clinic. The treatment clinics are only running, 3 half days a week. There is a mental health team made up of, nurses and social workers that will go around and provide some general mental health support to individuals who are suffering mental illnesses. But the environment at the remand center is truly not conducive to the betterment of really anyone's mental health. And so the difference then becomes is for some individuals who are so unwell that they're not functioning at the remand center, it also creates an issue of risk where they become at risk of injury to either themselves or others. So sometimes when someone is extremely agitated or disorganized and they're, and security personnel, they're there to ensure security. Someone who is severely mentally compromised or unwell may be handled in a way that is focused more on threat mitigation as opposed to the adequate treatment of their mental illness that may be contributing to their agitation. So those kinds of people we often try to bring over to my unit at the Alberta Hospital Edmonton. And the difference between the remand and our unit is on our unit at Alberta Hospital, these are all trained forensic psychiatric nurses. So it's 24 hours, 7 days a week care. I call it the Cadillac level of care. And this is where we can properly assess somebody's mental state. We can properly assess and provide a clear diagnosis of what's happening. We can often offer them treatments, and sometimes patients are so unwell that they're not even able to make treatment decisions for themselves. So we can then either find substitute decision makers to do it, or we go through the Office of the Public Guardian to help make those treatment decisions for individuals. Like, these are things that we just cannot do for individuals who are at the remand center, unfortunately, right? Because like I said, it's not a hospital environment. On our unit, we'll also have social workers, addiction support. We have all sorts of different programming that are offered for individuals as well. And we'll do a lot of discharge planning too. So when somebody is ready to be released from custody, we'll ensure that we have wraparound services ready to support that individual once they get discharged into the community. So as you can see, is that the experience for the patient will be vastly different at Alberta Hospital versus the Edmonton Remand Center. And to be honest, if I could bring over the entire mental health unit from the remand center to our hospital, I probably would, but unfortunately we can't, right? I only have 20 beds on my unit, and we're usually operating at completely maximum capacity. And this is very difficult because I'll still see individuals who are still unwell at the remand center, and then I have no other option but to send them to the emergency department for urgent treatment that we may not be able to offer at the remand center. I hope that clarifies a little bit in terms of some of the differences between the remand center versus the hospital.
I think it does, and in many ways, it also highlights, I think, some of the systemic or larger issues that sometimes we in the kind of problem-solving or therapeutic justice world have to deal with. I think to wrap up our last batch of questions here, I want to recognize that most of our focus has been on Edmonton area and adult kind of issues with regards to mental health forensics. I'm wondering, just for the benefit of our friends who are from out of this jurisdiction and who do unique work like working with youth who are charged, I wonder, Dr. Said, if you can comment on any resource or delay issues that you may have heard of or can speak to with regards to assessments. So, our one of our colleagues in Legal Aid, Jackie Fry, raised a point that in places like Red Deer, fitness assessments often take at least 30 days. And I know that Judge Collinson will speak more to timelines and exceptions and limitations. But just in terms of challenges or status in other jurisdictions outside of Edmonton, as well as any comment about resources or direction for youth involved in this in mental health forensics.
Gotcha. So my child forensic colleagues will be not happy that I've completely forgotten to address the work that they do because it's a huge component of our division. I primarily specialize in adults, so that's what I was focusing on. But yes, so there is a huge or a division of our services that particularly focuses on child forensics. And so there's also an inpatient hospital component. So there's a unit, it's called Unit 36 at our hospital that specializes in the assessment and treatment of young offenders. And then there's also an outpatient division as well. It's similar to FACS. It's called Centerpoint. So it's an outpatient clinic. It's literally located like 2 seconds away from FACS. And they'll do a lot of the similar assessments we do for adults, but for the youth population ultimately. So they'll have, youth forensic psychiatrists who are running clinics. They'll do, and that's for just general treatment. They'll do different kinds of assessments there as well. And they can also offer risk assessments and those kinds of things. So there's a huge child forensic psychiatry division associated with what we do. Obviously, that's just not my scope of work at this time. And to access those services, well, obviously they don't have a mental health court specifically related to that, but you can always fire me an email and I can always share those specific resources in terms of how one can get access to the child forensic services. Often the majority of referrals come from actually the justice system for them to get involved. So I hope that provides a little bit clarity on that component. In terms of the next question, my understanding is about assessments and things in other jurisdictions such as rural. Is that correct, Amna?
Yes, and that sometimes it takes much longer for assessments. Again, might be a little bit of an education component that Judge Collinson can speak to in terms of the maximum times and whatnot, but just in terms of Red Deer rural.
Yeah. So in terms of the, I actually had a slide with the different sections of the criminal code and just covering timelines in terms of the maximum times an individual can be assessed for the different assessments, whether it be fitness or NCR. But I'll obviously let Judge Collinson kind of speak to that. It is very challenging in rural areas. And the reason for that is the rural areas are not as heavily resourced when it comes to forensics as the major cities are, such as Calgary or Edmonton. What we do offer from Edmonton is it's called CGT, or a Community Geographic Team. So we're able to provide treatment actually to individuals in rural areas who are in trouble with the legal system. We can sometimes do fitness assessments depending on the rural area that they are in. They just have to be at a very specific, AHS site, and will follow the, privacy and security things. But we can sometimes assist rural areas doing assessments virtually that way. That can be both either fitness or NCR assessments. It makes it difficult for us as clinicians when we have to do things virtually. It's always better to do it in person, but we recognize practical limitations that we're not able to go out there, and the accused may not be able to come to the city to have an assessment completed. But then the issue then becomes is that if an assessment is being ordered in the rural areas, we then will require time. And this is where things get a little bit tricky. So, for example, if an individual or let's say there's some fitness concerns regarding an accused and they're in a rural area, a 5-day assessment order can easily be ordered. But let's say the individual is refusing to provide consent for a 5-day assessment order. And let's say, practically speaking, we need about, a 30-day assessment order to, get our team organized and set up everything to see if we can adequately assess the individual. That's where things get a little bit more trickier. And there's some jurisdictional issues as well. So typically things from Red Deer, and south of Red Deer will be diverted to Calgary, and things from above Red Deer are often diverted to us here in Edmonton, so the Northern Alberta Forensic Psychiatric Service. We do have within corrections in Red Deer, we do provide a mental health clinic, but once again, it's run virtually by psychiatrists. The clinic is interestingly run by psychiatrists in Edmonton, but often the assessments are going to be done by psychiatrists in Calgary. The most important thing there is when it comes to assessment is time. Our system is already inundated, particularly because of COVID. And so the longer period that we can get to assess an individual, often the better. I also understand that there is a mental health court in Red Deer as well, but it obviously doesn't run nearly as frequently as the one here in Edmonton does. So that could be another kind of avenue to pursue. But the bottom line, the easiest message I will give is if you have an accused and he's in a rural setting, if it's north of Red Deer, just give any one of us an email and we'll help direct you to the appropriate resource. And if it's Red Deer or south, you can always still contact me. I'll just point you to the key person in Calgary, who the section chief is, so Dr. Ken Hashman, who will be then able to provide guidance in terms of how that individual can be appropriately assessed.
Thank you so much, Dr. Said. I just wanted to clarify, we don't have the Red Deer's Mental Health Court up and running yet. Unfortunately, it's still taking some time, but Miss Jackie Fry, who is the duty counsel who will be working in Red Deer's Mental Health Court, you can get in touch with her if you have specific questions about Red Deer's Mental Health Court. I know that with regards to speaking further about delays in fitness assessments, it's certainly something that I know Judge Collinson will be able to address. So thank you, Jackie Fry, for the clarification. I want to also mention we've got one question, a great comment from Darcy about resources in places like the Yukon. Ronald Morin is asking a question about, if there's ever a concern about what we might call a clever criminal, and I think he's referring to the risk of clients malingering, and whether that is an issue, and whether or not that's something that can be detected. So I think whether or not it's an issue is important to address, and then whether or not it's something that can be detected and eliminated is a good question. And perhaps to close off, if you could confirm whether you're comfortable, Dr. Said, with folks following up with you with questions after this session.
Sure. So excellent question. The clever criminal, or the one that may feign or falsely produce symptoms for a very clear and secondary gain. As I alluded to earlier in my talk, So almost all forensic mental health evaluations, we do consider that. And we have to, in fact, consider that because it's a question that commonly will come up when we're testifying in court, is if we have ruled that in or if we have ruled that out. And as I described a bit earlier, is there are specific ways that we can actually detect what we call malingering or feigning or this clever criminal. And that will involve, outside of just the interview in itself, there's some very specific tools that we will use. These are psychological assessment tools, personality inventory tools, and then there's tools specifically designed to assess for malingering or faking or feigning symptoms. We work quite closely in collaboration with our forensic psychologist colleagues in the assistance in helping detect and assess for this clever individual or a clever criminal who may be trying to alter the course of their judicial proceedings in whichever way is they feel is appropriate to them. So to answer your question, yes, that is definitely something that almost all forensic mental health evaluations are considering. We do consider, and we have specialized ways to consider them. The second question is absolutely. I always tell individuals is I'm always open. You can email, call me, text me at absolutely any time. And I'm more than happy to provide guidance. And if I'm not able to answer your questions, I will do my best to direct you to the individuals who may be able to answer those questions for you.
Thank you so much, Dr. Said. I feel like the questions are going to keep coming in for you. So just to make sure we've got time for a wellness break before we get into the nitty gritty of the law on fitness and NCR, I'm going to just thank you on behalf of everyone here. You've provided us with so much invaluable information, Dr. Said, and I'm sure this conversation is going to continue. We'll take a break until about 11:05, and when we return, we'll be happy to start with Judge Michelle Collinson. So thank you, everyone, and we'll take a break here and start back up at 11:05.
Thanks,
Thank
Amna.
you.
Just a quick comment. If there are additional questions or questions that we didn't get to, I'm going to ask Wyatt to put his email address into chat, and please forward those either to the email address that Wyatt gives you or communications, and we will try and get those questions answered and an email back to you. I have the Honorable Judge Michelle Collinson to speak to us now about NCR, so I'll turn it over to Michelle.
All right, thank you very much, Danny. I just want to make sure you can hear me and see me clearly.
Yes, we can.
Yes, confirmed.
All right. You'll note the screen that I put up first. It's kind of an inflammatory screen. I do that just to remind us that the whole area of mental health is still full of stigma. And that one screen where it's, or one paper where it shows 1,200 people killed by mental patients, it has to be put into context because there was, 10,000 people killed in that time frame. And so the majority had actually been killed by people who, a large majority, who are not mentally ill. But of course, this is the headline. So just a reminder that when you're dealing with people who have mental illness, that they are dealing with the stigma that the general community has, and you need to prepare them potentially, particularly in high profile cases, for the stigma that's going, or for the press that's going to come out and the amplification of that stigma. So one of the four things that I'm going to try to cover today is fitness, of course, not criminally responsible, the meaning of mental disorder, which Dr. Syed did talk about, but specifically to the criminal code. I'm going to just touch a little bit on bail and touch a little bit on sentencing. I want to start this presentation too with a plug for a documentarian who's no longer with us, John Kastner. He did a series several years ago on NCR, and I'm going to play the trailer for you. You can find this documentary on I think prime time, I think you might have to pay a fee. You can get it off at the National Film Board of Canada. There's a number of locations that you can find it. Some of it's on YouTube, but I highly urge you to watch this particular documentary. Back to the beginning.
Yes, and we can hear it now.
Great, thank you.
The devil told him to stab the prettiest girl that he's seen.
Am I gonna see the white light now, you know? Is this my time?
He was motivated by a disorder, a disease of his mind.
This is not like a psychiatric unit at a general hospital where you would take your mother. Every client here has some sort of criminal charge.
I've seen lots of violence over the years. Serious violence. We've had murders on this floor. The potential for violence is what got them here in the first place. Not just because they were schizophrenic, because they were violent.
I felt, you know, it's safe now. He's gonna be there in my mind for a very long time.
Is it very common for patients who've committed murder or attempted murder to be released into the community?
That's the mandate. That's what we're told to do. That's what our job is.
I had some plans before I went insane. I wasn't half the madman they suggested I was.
Of course, the music that's on that trailer is designed to be dramatic and capture the attention of the potential viewer. The tenor of the documentary is a lot kinder to the person who is mentally ill. And in the end, there is actually a therapeutic process between the victim's family and the accused person there as a result, actually, of the documentary. So I do urge you to watch it, knowing that, you know, there's a considerable period of time that has passed since that program was made. And so there's some better approaches to dealing with people with mental illness than there was at that time, but it's a very instructive type of program. I put up the flow chart just to show you how many places somebody can go. It's a reference for you to use in the future. I'm not going to go through it specifically now. But the key about fitness and NCRs, we're looking at two different time frames. Fitness to stand trial addresses the current mental condition of the person. And not criminally responsible is dealing with the state of mind at the time the offense was committed. And so what does unfit to stand trial mean? It means that the person, as a result of the mental disorder, cannot understand the nature of the object of the proceedings, is unable to understand the possible consequences of the proceedings, or communicate with counsel. NCR, very simple definition. No, it's under section 16. These are all defined in the code. Suffering from a mental disorder, notice I've underlined that, and that renders a person incapable of appreciating the nature and quality of the act, or knowing that it was wrong. So those are separate concepts, but the underlying all of it is the idea of mental disorder, and it is defined in section 2 of the criminal code. Very helpfully, section 2 says that mental disorder is a disease of the mind. What does disease of the mind mean? And this is where Dr. Syed and I overlap. Cooper was the main case, but Stone as well discusses it, both cases from the Supreme Court of Canada. The term means things like psychotic illnesses, but any illness, disorder, or abnormal condition which impairs the human mind and its functioning, and it includes personality disorders. It includes mental retardation, and to answer the question of the person previously, it does include FASD. Does not include self-induced states caused by alcohol or drugs, or temporary states, those things that we would find in the area of automatism. Self-induced intoxication, even when it leads to a psychosis, is not a disease of the mind, and this does create huge complications for determining the appropriate diagnosis for someone who has been using substances and also has a primary psychotic illness. What is the driving factor? Or do they even have a psychotic illness? You need a lengthy period of sobriety often to be able to tease out whether the person had a psychotic illness or had a substance-induced psychosis. There are times, though, that the prolonged use of substances can fall into the criminal code definition, bolstered by common law, definition of mental disorder. And one of the examples that I like to use, not so much in the delirium tremens area, but a woman, Jodry was her name, from Calgary. She was a socialite, very well known in in social circles that received a lot of notoriety. She attempted to kill her husband, and it was determined that she was suffering from a mental disorder at the time, and that mental disorder was essentially her alcoholism had liquefied her brain. She had used so much, it had liquefied, I guess is, it's not the medical term, but essentially the frontal lobe was impacted so severely by her alcoholism that it fell into that definition, and she was found to be not criminally responsible. The other time you can see it is when somebody is a substance abuser and has a disorder and has long-term use, when they withdraw. So when they suddenly become sober, that can bring along a sudden change to the brain, and it can lead to things that look like a psychosis, confusion, disorientation, delirium, and hallucinations. And the case law has found that to be disease of the mind, and people have been found not criminally responsible with that being the basis for their mental disorder. We've reviewed the common mental disorders through Dr. Syed, so I'm not going to cover that. But what we need to know about fitness assessments, and I know we had that question about North or Edmonton versus Southern Alberta, and I'll talk a little bit more about that, but I can say that there's a philosophical difference between what's involved in a fitness assessment between what happens in Northern Alberta versus Southern Alberta. Dr. Hashman and his team believe that they need to do a full social and medical background to determine whether somebody is fit to stand trial. Whereas in the northern part of Alberta with the Northern Forensic Psychiatry team, they focus on, does a person have a mental disorder? And second, what is the state of that mental disorder right now? And how does that impact on the ability or the fitness to stand trial? And that can be, and most times, 95% of the time, a very quick assessment, and can be done within half an hour or an hour, particularly if there is a long-standing history of mental disorder already documented. But in any event, you want to keep the section numbers handy, particularly if you don't practice in mental health court. Knowing the section number that you're asking for the assessment for is important. For fitness, it's 672.11 sub A. A court can make the the assessment at any stage of the proceedings, but the Crown is more limited in their ability to ask for an assessment. And so their burden is a little bit higher. There actually has to be some reasonable basis to doubt the fitness when it's a summary conviction offense. And the timelines are a big deal in the fitness area because a fitness assessment can only be enforced for 5 days. It's 5 days plus time for travel. So if you are in a rural area, you can factor in time for travel, and you want to make sure that the judge, when they make the order, talks about the assessment being for 5 days plus the travel time. Are there exceptions to that 5 days? By agreement, it can be 30 days. When it is a 30-day order, that includes the travel time. So you don't get 30 days plus travel time, it's 30 days including travel time. And when there are compelling circumstances, the court can make an order for 60 days. One of the advantages that we've had in Edmonton was mental health court was streamlining fitness assessments and having the doctor present and be able to do those quick triage fitness assessments. One of the challenges, particularly with the proliferation of methamphetamines and other drugs that cause substance-induced psychotic disorders, is that you can't always tell in those early stages whether somebody is suffering from a fitness issue that relates to mental disorder as defined by the criminal code, or whether the issues that appear to be fitness are a result of substance abuse. And sometimes it's just a matter of having them sober up. So an overnight adjournment to see if their condition improves as the substance makes its way through the body. That sometimes is quite helpful to keep in mind. What do you need know about NCR assessments? And again, knowing the section number is always helpful, 672.11 sub B. It used to be very common, and at least in the northern Alberta area, to order a fitness and NCR assessment for 30 days, like a joint assessment. And I'm not sure if that's still happening in southern Alberta, but we strongly discourage that because if fitness is an issue, there's ethical considerations about whether you can actually take instructions to be pursuing an NCR assessment. It's also challenging for the doctor if fitness is an issue to receive consent from them for the purposes of an NCR assessment. And they're two very different types of assessments. And again, from my perspective, the fitness assessment for the majority of people is a very straightforward, quick assessment that shouldn't take a lot of time and shouldn't take the 30 to 60 days. Some doctors like to use the opportunity of having the person be referred for an assessment to get treatment going, but assessments are not for the purposes of a treatment. They determine the state of being for that particular individual at that time. And you want to be cautious, and we're going to talk about that. If you move into the 30 days, first of all, the fitness assessment can only be 30 days if there's agreement or there's compelling circumstances which would allow it to be up to 60 days. But you need to be cautious because during an assessment, you cannot be speaking to bail. So if you have not already spoken to bail, your person is going to be staying in custody. And it's not necessarily so that they're going to be transferred to hospital for the assessment. They may be remaining at the remand center with their mental health needs not being met fully. Sometimes, again, the Crown can ask for an assessment. Again, they're limited in their ability. There has to be grounds to doubt that the person was criminally responsible when you're dealing with a summary conviction matter. And that becomes even more important now with the changes to the summary conviction provisions. You're going to see more Crown elections for summary proceedings because the maximum has been increased to 2 years for most offenses. So kind of keep your eye on that if it is the Crown who's seeking these assessments. Sometimes you want more than one opinion. That happened in the case of Lee. The defense or the Crown, one of the parties, and right now I'm not remembering who, wasn't satisfied with the opinion that they received. And so they sought a second assessment. Sometimes the assessment's just not complete and all the timeframes have run out. So the only way you can do it is to get a second assessment order. So just know that there is authority to have that happen. So here's some of the limitations as I was talking about in terms of Crown assessment for NCR. Again, this idea of the reasonable grounds to doubt, but also if the accused puts it in issue, and you'll usually see that after an accused has testified at a trial, then the Crown can raise it and it becomes part of a rebuttal case to pursue the NCR if they decide to do that. NCR times assessments are different than fitness. They're not limited to that 5 days. So even if the accused does not consent, the order can be made for 30 days. It should not be more than 30 days. There is an allowance for up to 60 days if there's compelling circumstance. And while the order is in effect, it can be extended up to 60 days under a different section, 672.15. So what are compelling circumstances? Again, that means the idea that there's some kind of compulsion that requires the court to increase the amount of time. That's different than exceptional or reasonable, but the court is compelled to make a longer order. Some of the things that have been found to be compelling circumstances are that you have a challenging person who has a disability that interferes with the ability to communicate apart from the mental disorder. Case law has found that a lack of cooperation because of a treatable psychosis has been a reason to make a longer period of time. Just again, I caution you because an assessment is not meant for treatment, although the doctors may go in and get the person certified so that they can start treatment, or the person may decide that they want to cooperate and treatment may start during the assessment period. That is not the purpose of assessment. Sometimes the materials really are voluminous and complex, and sometimes it's difficult to determine whether somebody actually has mental disorder, and so that is why, or the person comes from a different jurisdiction and it takes quite a long time to get those documents, so those types of things might interfere. But just because the hospital doesn't have a bed, they're the accused, that's not enough to be compelling circumstances. So what happens if at the end of your 5 days or the 30 days or the 60 days, the assessment has not been completed? Again, if you have to be adding up all the days, you can't have more than 60 days altogether in one assessment order. But so add up your days and check. Sometimes you have to start all over with a new assessment order. But one of the things you might want to do is check with the doctor and find out whether it's actually the assessment portion of it that they need more time for, or they just didn't have time to write the report. Because sometimes these reports, they're long, particularly if you're in Southern Alberta. You know, a fitness assessment can be 25 or 30 pages long. NCR assessment can be is often that long, if not longer. It could be just that they need time to write the report, and there's a provision that gives a court time to adjourn the matter and set time for the preparation of the report. So the person would get returned to remand center and no longer be at hospital, but it would give them time to get the report done. Can an assessment be done out of hospital or out of custody, I should say? A lot of our accused people who are struggling with fitness and NCR tend to be in custody, but there is not, and yet, sorry, I'm not speaking very clearly right now, but there is a presumption against custody, and you have to understand the historical basis of that. Before R versus Swain and the changes that are all of these provisions under this section, it was standard, whether the person had bail denied or bail not spoken to or was out of custody on bail, it was standard that they would be taken into custody for the purposes of an assessment. And so the provisions changed that idea that you don't presume that somebody has to go into custody for an assessment. An assessment, you should presume, can be done out of custody. And so the section, again, if you get anything out of this, read the sections. Every time you are running into these issues, go back and read all the sections. And I know it's difficult in some ways because the sections aren't always linear or chronological. You have to jump from one section to the other section. I've tried to kind of put it in order of the things that will come up in my presentation, but please read the sections. So typically you'll have an accused person say in custody, fitness is an issue. You may require the Crown to show cause because maybe there's really no grounds to keep the person detained in custody before you ask for the assessment. But if the Crown shows cause, they'll be kept in, or if the doctor, you have some evidence to say that custody is desirable for assessment and the accused consents, or custody is necessary, you would have to have evidence of that, then they could be done in custody, or if the person happens to be in custody for other reasons. But keep in mind, once the assessment order is made, that it takes precedence over a bail hearing. So the bail hearing must wait until the assessment order is done. And this is why, particularly those people in Southern Alberta, you might want to think about whether you're going to be agreeing to that 30-day assessment period. You might want to keep the tight rein on it and only allow for the 5-day assessment period for fitness because you want to keep that opportunity, if it arises, to speak to release. If the person is already out of custody, there is a provision that allows for release to be spoken to again, because you may need to vary their release for them to be able to get to the assessment. So, they might have a house arrest provision. You might need to specifically allow them to travel from St. Paul to Edmonton to have their assessment completed, or, say they're in an even more remote location and they need to travel to St. Paul to meet with one of the community treatment team members. You would need to make sure that the current release that they're on allows that to happen. What happens when the person doesn't show for their assessment if they're out of custody? Normally what happens is that we go back into court the next time. Most times they don't even show up for court. Warrant issues just in the standard way. Technically, you can get a warrant under these sections, 672.91. It's and they can be arrested without a warrant under those sections. Very rare to use those sections for an assessment order. We see these sections more often used when somebody has AWOL'd from the court, from the review board process. Most times, as I said, we just, if they actually show up in court again, we just try again. We do another assessment order. From time to time, the Crown may consider showing cause, and that would be specific to 672.161C. They might show cause to have him detained for the purposes of the assessment, but it's only for the assessment period. It's not a revocation of his release. So, and that needs to be made very clear that once the assessment is completed, the person is to be released again on their original release order. So if the Crown relies on this section, make sure that it's well endorsed. You might even want to take a look at the order to make sure that it captures what is intended by this section. One of the reasons I caution you about these joint fitness and NCR assessments is that you have an unfit person who's being asked to participate in an NCR assessment, which is a much more complex and complete type of assessment where they're asked about the circumstances of the offense, and all of that information then becomes available under 672.21, not usually admissible to prove the offense, but if your client decides to take the stands, they could be cross-examined on it because it can be used for credibility. And now the Crown also has that information in their hands. And most times defense don't wish to disclose their case to the Crown. And so this is a strategic decision as well. And keep in mind that that assessment can be used for other purposes like determining perjury. What I don't have listed there is it can be used in sentencing. And so it could be used in a DO or an LTO hearing in the future. And so I just suggest that you exercise caution in terms of pursuing an NCR assessment without the express fit instructions of your client. Going back to fitness, starting point is always that somebody is fit. And I say almost always. We'll talk about when that changes in a little bit. And the burden is on a balance of probabilities. And how are you going to know whether fitness is an issue? It's sometimes flagged by the police. It's sometimes flagged at the JP office. Duty counsel will pick it up when they meet with the person. You'll meet with the person. Sometimes it's in court, and I've just included a transcript, and you'll get a copy of these materials. But the person you'll start to see is so disruptive in court in kind of a meaningless way. And it becomes quite apparent that fitness is an issue. So I've talked a lot about keeping your fitness assessment independent. I caution you that your ability to release hearing is on hold. So think about that when you're asking about it. If you're wanting to speak to release, again, make sure you keep the order. You can tell the court it's my intention to speak to release, and then it's my intention to seek a fitness assessment. But if you do the fitness assessment first and then go, oh, but I want to speak to release, it's already too late because the order is in place. The legal test is set out in section 2, but it's really capturing a case by the name of R versus Taylor. So you should be familiar with that case, R versus Taylor. It's a limited cognitive ability test. And so I know the person had questions about FASD. And that's really what Dr. Syed was trying to talk about. When their intellectual deficits are so great, they may fall under that threshold of limited cognitive ability test, but that threshold is very low. So you don't need a lot of cognitive ability to be fit. If counsel tells a court that they have reason to believe that their client is unfit to stand trial, the court should give quite a heavy weight to that, particularly if counsel's saying that I can't communicate with them. But keep in mind what Dr. Syed said about people with limited or with cognitive deficits, that you might be just having difficulties communicating, and you may need to learn how to speak in a more concrete way for that person to understand. Also, you don't need to be getting along with your client. They don't need to remember what happened. They don't need to make the best decisions for themselves. People are entitled to make bad decisions. Even people who have mental illness are entitled to make bad decisions for themselves. Things that you need to know about a fitness hearing, and just so you know, I prepared some checklists for you for running a fitness hearing. Those things that need to be covered in those checklists is the language that the court should be using when they make their orders. It's the very formal language. Often courts will paraphrase, but if you want the formal language, it's there in those checklists. You're going to get that information once it's handed out by the organizers of this seminar today. Quite often, both people or both parties, the Crown and defense, are in agreement that the person is unfit, but you still have to go through the process when you're doing a fitness hearing, because it is the court's decision as to whether somebody is unfit. Don't forget, if there is a written fitness assessment report, to mark that as an exhibit in mental health court in Edmonton. And I suspect that when mental health court starts running in the other jurisdictions like Red Deer and potentially in Calgary, there won't be a report, because there's been this type of triage fitness assessment where the doctor that day or very close to that time has done an assessment, and then they come immediately in to do a fitness hearing. What if the person is unrepresented? So you can't just go into a fitness hearing without the person being represented. So as soon as the assessment order comes back with an indication that the person is actually unfit, then the court should be making an order pursuant to 672.24 if they don't have retained counsel already. And duty counsel generally are not considered to be 672.24 counsel. But Legal Aid, particularly in the Edmonton region, has worked very hard to develop a very quick process to get certain people from the roster who've expressed an interest and who have expressed some knowledge in this area to be appointed as counsel under this section. And what we want to do is expedite this process as quickly as possible, because if the person is unfit due to mental disorder, we want to get them into the hospital stream and the therapeutic stream as soon as quickly as possible to work on getting them fit, so that they're not particularly sitting in remand center, not having their mental health needs met fully. So what's happening on a fitness assessment, or what happens after a fitness assessment or hearing, I should say? You could ask the court for a treatment order, but most times we don't do that. I'm going to talk about that in a minute. If they're fit, you just carry on as you were. If there has been a hearing and the person has been found fit, but there has been evidence that the person will become unfit if they're not kept in hospital, the court can make an order to keep them in hospital pending the trial of the matter. If they're unfit, then if one of the parties requests, there must be a disposition hearing. But if neither party requests, then the matter gets referred to the Alberta Review Board. And regardless of whether the court holds a disposition hearing or not, the matter will get referred to the Alberta Review Board, particularly on fitness, because as you will learn in one of the later sections, the 3 dispositions that are available are detention in hospital, conditional discharge from hospital. It's not conditional discharge as you would contemplate under a probation order, and absolute discharge. Absolute discharge is not available for an unfit person. When they go to the review board, once they're heard there, every time they have a hearing at the review board has to determine whether they are of the opinion that the person is fit or unfit. If the review board becomes of the opinion that the person is now fit, the matter gets referred back to court. But just because the review board has the opinion doesn't mean that the person just carries on and it's as if they're fit. There has to be a fitness hearing. And now the presumption is that the accused person is unfit, and it's upon the party who's trying to establish that they're fit to establish on a balance of probabilities that the person is now fit. You want to get those fitness hearings going as quick as possible because fitness fluctuates, and you want to kind of get in there while they're still fit and address their criminal issues as quickly as you can while they're fit. And so I said you could ask for a treatment order. Treatment orders only get made on a finding of unfit. They're only made by the court. And there are a lot of preconditions that must be met before you can have a treatment order. They're not common in the northern region. I think they're a little more common in southern Alberta, but it has to be a specific treatment. It has to be on the basis of evidence of a medical practitioner that they have assessed the person, that the person is unfit, that the treatment is likely to make them fit within no longer than 60 days, that the harm of the treatment doesn't outweigh the benefit, that it's the least restrictive and least intrusive treatment. There's no electroconvulsive therapy permitted, and there has to be written notice, and there has to be consent of the hospital where the person is being treated, or the person to whom responsibility for the treatment is going to be assigned. So these are things that you need to know, because the doctor who is testifying may not be the one who ultimately will be providing treatment. So they're not the ones who can consent under this section. So you may need to get consent from the director of the hospital, or you may need to get the one who's going to be providing the treatment, their consent. And as I noted, there has to be written notice if you're going to be making a treatment order application. And that notice has to be in writing to the accused. There's no provision that it go to the defense counsel or to some other person. It has to be to the accused. If you're having a fitness hearing and the person is found unfit, don't forget about the need to establish a prima facie case. That's actually a requisite before you start the fitness hearing. There needs to be an establishment of the prima facie case for the Crown. Most times, counsel will just admit for the purposes of the fitness hearing that there is a prima facie case, but if it's not admitted, the Crown actually has to be put to the test of a prima facie case as part of the fitness hearing. And then after the person is found unfit, every 2 years, or if they're a youth, every year, the matter has to come back to court while the person is remaining unfit. It has to come back to show that the Crown is still in a position to establish their case. And so this is to try and weed out the idea that people are forever in hospital unfit when the case for the Crown has diminished such that they can't prove it anymore. So when you're there, set a date, say 18 months down the road in docket court to set a prima facie case hearing, or if it's a youth, say 9 months down the road in docket court to set a prima facie case. And it can all be done by affidavit evidence, but one of the things the Crown has to make sure that the witnesses are still available or that they have evidence that they could rely on in the absence of witnesses. Let me turn now to the NCR. I'm really not going to be getting into the niceties of running an NCR trial because that's basically a whole day presentation, but I'm going to try and cover some of the high points. Again, everybody's presumed not to have a mental disorder, and the burden of proof in these sections lies on the party that is raising the issue. It's a balance of probabilities. So if it's the Crown raising it, NCR, it's not beyond a reasonable doubt. It's balance of probabilities. And when we're talking about NCR, we're talking about mens rea, because when we're talking about guilt, you know, of course, I mean, this is very basic. You have to have the act, the voluntary act, and then you have to have the guilty mind. And NCR is addressing the guilty mind part of it. I'm just going to play this video. I just warn people this can be an upsetting video. And so if you feel that knowing some of the circumstances of how Mr. Schoenberg's children were killed, you probably don't want to watch this portion of this.
Sorry, Judge Collins, the audio isn't playing. You just need to hit
Still not on, eh?
Yeah, you'll just need to hit the share.
It's not giving me the share button up there. Oh, there we go. Thank you. We'll start again.
Moving on to a murder trial today in British Columbia. Alan Schoenborn's words were described by some in the courtroom as the most horrifying they have ever heard. The British Columbia man testified in court describing to a judge in graphic detail why he killed his 3 young children and how. The CBC's Chris Brown is covering the trial.
It is rare enough for an accused murderer to admit his crimes in the witness box, but today Alan Schoenborn went a horrible step further, taking a Kamloops court through the gruesome, heartbreaking story of how and why he killed his 3 children. Caitlin, Max, and Corden had been living with their mother, Darcy, in Merritt, but that night he was looking after them in her home. She had told him over the phone that their on-off 15-year relationship was finally over. As the children slept, Schoenborn told the court he hugged Max and said he smelled semen in his hair, confirming his long-held paranoia that his children were being abused. After smelling Maxie, I came to the realization this wasn't in my head, he said. I did it for the right reasons. I did it for them. I gave my children up to be in a better place. Schoenborn sobbed and then broke down in tears as he described taking a cleaver to his 10-year-old daughter as she slept. She may have put her hand up. She said, "I'm sorry, Dad." I swung again. He killed 5-year-old Corden next, smothering him with a pillow because he thought it would be quicker, And then finally, he says he took a plastic bag and put it over 8-year-old Max, telling him, shh, 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 as the little boy struggled. Then he continued his testimony, seeming to speak to his former wife. I'm so sorry to you, Darcy, that we didn't connect in that last phone call, that you didn't hear my plea. Did you do the right thing? Asked his lawyer. Yes, I did. Watching on the sidelines were 2 psychiatrists expected to testify later about Schoenborn's mental state. The defense says Schoenborn had shown signs of mental illness going back a decade, but prosecutors say that is just a cover created by an angry man with a history of intimidating his wife, who ultimately killed their children to try to hurt her in the worst way possible. Chris Brown, CBC News, Kamloops.
Moving on.
All right, so let's just talk a little bit about the law and the section. Again, reading the section carefully, you have to keep in mind that it addresses 2 very separate concepts: incapable of appreciating the nature and quality of the act, or incapable of knowing it was wrong. That "or" is very important. You'll see quite often in reports that doctors will blend the 2 different concepts, but they're actually very separate concepts. So when we're talking about appreciating the nature and quality of the act, it's that they don't understand that what they did could actually cause the consequence. So an example that I can give, a patient that we had at the Alberta Review Board, he was found not criminally responsible for killing his mother. In his psychotic state, he thought that his mother was inhabited by another being, like an alien being of some sort. And he thought in his mind that if he cut out the heart, he would be removing that alien being from his mother, and that she would then be able to return and continue her life. So he clearly didn't understand that by removing the heart, he was killing her. That would be an example fitting into this particular definition. The other one is knowing it was wrong. And it used to be the idea that if they knew it was illegally wrong, that was not enough to fit into this section. But Chuck disabused us of that. They might know something is illegal, but they might feel that they're justified in doing it. And so you see in the case of Cock, the person thought they were acting under the instructions of God to kill and felt morally justified. And you'll see it in people who have these types of psychotic thoughts, that particularly when they've killed somebody on instructions of God or to prevent the annihilation of the world, they are perplexed by the idea that somehow people wouldn't think they had done the right thing. They think that everybody would realize that they did the right thing, and they sometimes are perplexed. They actually think they should be heroes. And we saw that with Vince Lee, who, the unfortunate circumstance of killing the individuals on the Greyhound bus. He felt like he had to do what he did because he was preventing the end of the world. And so they might know that it's illegally wrong, but they feel that it was morally right, and not just morally right, that there was really no choice in what they were doing. There's no rationality about their decision making here. And so that's the difference between those 2, and keep those concepts separate when you're looking at a report. And if you see a report where the doctor has blended those, if he's your doctor, you need to do some briefing to make sure that they tease those out when they give their testimony. But if it's not your doctor, that's an area ripe for cross-examination because it appears that they don't understand the sections very well. So morally wrong is enough if they're incapable. Incapacity is often overlooked. So you have to keep that capacity issue in mind when you're dealing with both of those concepts for NCR, because somebody might have thought that they could kill somebody, but they still might have had capacity to understand what was going on. So just because they say, well, I did it for this reason, doesn't mean that they had the incapacity to understand that it was wrong or to understand that that would be the consequence. It's hard to explain kind of in this abstract way, but when you have the facts, it will make much more sense when you're looking at it. But make sure when you are addressing this, whether you're the one putting forward the NCR, if you're putting forward the NCR, make sure that you're covering off the capacity part of this. So NCR can be raised at any time prior to the end. Sometimes it happens, the trial is completed, but before the conviction is entered, if NCR is raised after the accused has been found guilty, you can't go back and use the mental illness to challenge the previous findings of intent. So we're just dealing with what caused the intention, so to speak. When you're looking at an assessment, again, or an assessment order, you want to make sure these things are covered off. First, you need to address the aspect of whether there's a mental disorder as it fits into the definition under the criminal code defined in the common law. Then you have to determine whether that mental disorder was operating at the time of the offense, like whether they had that mental disorder at the time and whether it was active at the time of the offense, and then whether it rendered the person incapable at the time and whether that led to the lack of appreciation of the nature and quality of the act or led to the failing to appreciate what they were doing was wrong. If the Crown is the one who believes that they're NCR, it's Swain, which is the leading case. Basically, the trial is run, and then there's a finding of guilt, and then the NCR portion starts. Sometimes both the Crown and the defense agree that the person is NCR, and it's just procedurally, sometimes it can be a little bit awkward because the person can't enter a guilty plea because guilt implies that all the elements of an offense have been admitted, and that includes the mens rea. And when you're presenting an NCR, you're not admitting the mens rea aspect of it. So you should be advising the court that it's in the intention to propose jointly that the court find the person to be NCR. And then you should be putting towards the court an agreed statement of facts regarding the offense. The court will find that the person committed the offense, and then you call the evidence that supports the NCR. And then you jointly submit that there should be a finding of NCR. But remember, it's the court that actually has to make the finding of NCR. So just procedurally kind of try to keep it clean that way. We see a lot of these, particularly when you're in your review board and you're reading transcripts, that a lot of this has been skipped and the parties don't quite recognize what is happening. So the person is NCR, now what? So the court will find that the accused committed the act, but was at the time suffering from mental disorders so as to be exempt from criminal responsibility. So the specific section is section 672.34. That doesn't end it there. Of course, they're not just free to go. We all know that. That's why you're here. Disposition hearings. So again, just like for a unfit disposition hearing, the court may on its own motion have a disposition hearing, but shall if either party requests a disposition hearing. We generally refer matters to the Alberta Review Board, and there's a few reasons that that has been the way historically. One is your assessment report does not or should not contain risk assessment information. And risk assessment is a critical aspect to what needs to be determined in determining what is the right disposition. And I know the next presenter is going to talk more about that. So it may be that if you request a hearing or the court makes a hearing on their own, there may need to be an adjournment to get an assessment to deal with the risk aspect that's critical to the decision making on disposition. And that creates a delay, which means that the accused person may be sitting in the remand center instead of being referred to hospital, which is where if you have somebody who is mentally ill, particularly who's met the standard of being NCR, you would prefer them to be at hospital than at remand center, where remand center can't necessarily address fully their treatment for their mental illness. But even if there is a hearing, and this applies to fitness as well, even if there is a hearing, the court may determine that they can't make a disposition because they might not have the risk assessment information that they would need to make a disposition. And if they can't readily make a disposition, it should be referred to the review board for disposition. If the court makes a disposition other than absolute discharge, the matter gets referred to the Alberta Review Board. If no disposition hearing is held or no disposition is made by the court, it gets referred to the Alberta Review Board. You don't need to set a date specific. You just, on the record, it gets referred to the review board. The review board will notify the accused person if they're out of custody to have them, they'll summons them to their hearing. If they're in custody, the person will be transferred as soon as a bed is available, so as soon as practical, to the hospital, and then they get notified while they're in the hospital to appear at the review board. If the court made the disposition, it's 90 days that a hearing has to be held before the review board. If no disposition has been made by the court, then it's 45 days that the disposition hearing has to be held, unless there's exceptional circumstances. Most times that exceptional circumstance is that it's the Christmas break, and the time frame from when the NCR finding was made to when the next review board hearings are is longer than that 45 days. But when you're around Christmas, like right now, keep in mind that you might need to have a longer period of time. And that applies to fitness or NCR for the timeframes for disposition hearings. What do you do with bail? It is the status quo unless the court varies the order. So sometimes you might want to have the court say that the person is to be detained at the particular hospital instead, or if the person is out of custody, you may want to have the release order varied to ensure that they actually show up at the Alberta Review Board hearing when directed. Now this slide talks about bail, and this is just generally bail outside of the NCR, outside of the fitness provisions. Mental health is one of the most challenging aspects when we're dealing with a bail hearing. Dr. Syed touched on it a little bit because quite often their social factors that are impacting on their illness aren't easily resolved, like housing and ensuring that they're getting regular treatment. And when somebody is so sick, how can you even trust that they're going to comply with their release order? And you don't want to be setting up your client for additional breaches of court order charges. So it becomes really delicate because you don't want your client to be in custody any longer than they need to be, but you don't want to set them up for failure. So it does impact on both the primary and the secondary grounds. This is the advantage to mental health court. It's such a struggle when you're in other regions that don't have a mental health court and don't have easily accessible resources at hand to try and develop reasonable bail or a bail plan that will work for the person who is committing offenses, particularly driven by their illness. And of course, Antic creates that wrinkle because they really spoke strongly against treatment as being a provision in a release order. If that is going to be a condition, consent has to be expressly stated on the record and within the order itself. Sentencing, again, I'm just touching on this. This has to do really with moral blameworthiness and whether specific deterrence or general deterrence works or is meaningful for people who are committing offenses driven by or influenced strongly by their mental illness. And the other aspect of it is really the humanity of it all. People who have mental illness have way worse outcomes when they are detained in custody or they're in custody. And we know, practically speaking, that the availability of treatment, and again, this applies both whether they're in custody pending a trial, bail denied or not spoken to, or sentencing. But if they're in custody, the availability of the full treatment options is just not there realistically. We know that a number of the medications that assist people with their mental illness are also medications that are abused and become valuable while they're in custody. And so the range of medications that doctors are willing to prescribe in custody or are permitted to prescribe while they're in custody is limited. So sometimes they're not on the medication that works best for them. Sometimes they can't even access any medications. So being in custody for a mentally ill person can have devastating impacts on their health. And so you always have to be mindful of that, both in terms of bail and sentencing. You also don't want your sentence to be longer to accommodate. It's not just you don't want, it's not permitted. You can't be making a sentence longer just to address the mental health concerns. There is some provision for a conditional sentence order that requires the person to live in hospital, but that should only be done if you have the consent of the hospital. Knobloch is the name of that case. It is actually an Alberta case. It went all the way up to the SCC. And just because somebody has a mental illness doesn't mean there will necessarily be a reduction in a sentence, because we also have to consider risk to reoffend, compliance issues. And so, but it has to be addressed. The court has to address their minds to the mental health. Council should be assisting the court in addressing that and making sure it's on the record how mental health has been considered by the court. So I'm now at that point that I can ask for questions.
Thank you so much, Judge Collinson. I've heard you give a similar presentation like this. And again, like I said to Dr. Saeed, I learn something new, a lot of new stuff whenever you speak. So thank you so
Oh,
much
thank you.
for the detail of information you provided. It's certainly raised a number of very good questions.
All right.
And what I'll ask is
I'm always
maybe,
afraid.
no, they're very good questions. And what I'll ask Judge Collinson, if you don't mind, while we do the Q&A, if you can stop sharing your screen.
Okay.
That way we can bring you up. Perfect. Okay, so
Okay.
one of our first questions for you comes from Jackie Fry, who's our duty counsel in Red Deer. She's asking, and this is of course because she deals with this issue and has been dealing with this issue for years, is there a remedy when fitness assessments are not completed within the mandated 5-day time? Especially, and I'm going to add this on to Jackie's question, especially in the cases where after the 5 days, they receive nothing back from FACTS or AHS.
So first, in terms of not getting something back, just this is a reminder to some and new knowledge to others. As you heard from Dr. Syed, a lot of times they're doing their fitness assessment the morning of court. And so they see a whole bunch of patients and then they write up their report. And the reports are often not available until 11 o'clock or even a little bit later. So call the service that has provided, who is supposed to be providing the assessment, to find out where the report is, to see if it's on its way if you don't have it. In Edmonton, we would just wait until after 11 o'clock anyways. We would just say, well, let's wait till 11 and see if it arrives. I know when I'm the judge in the regional areas, I'll say, let's just wait until 11 o'clock and see if it arrives. And it almost invariably arrives. So quite what we learned when we were doing mental health court is that assessments were being completed and then ordered again and then done again and ordered again because the reports weren't making it to court by 9 o'clock or 9:30 when court started. They were showing up later in the day. So that's the first thing. Call the service. Just find out where they're at in terms of their fitness assessment. Find out why they haven't provided the fitness assessment. You may require them to come to court, ask the court to subpoena them to provide an explanation as to why they haven't complied. I think that's probably your best way to address that if it's a chronic issue. First is a call to find out what's going on. Second is see if there's a good reason. Third, if there's not a good reason, compel their appearance before the court.
And I'll just add on to that, Judge Collinson, as you recall, we employed that procedure to put pressure to kind of get things back on track and in line with the legislation in terms of timelines, and that worked for us. But it did require some kind of heavy pressure to say, well, if it's not happening, we need an explanation. And in places like Red Deer, I understand that accused are expected to be transported elsewhere, for instance, Edmonton or Calgary, versus in Edmonton, where the psychiatrists attend there to conduct the assessments that morning. So certainly a systemic gap, which has been alive for a number of years. But I think that what council may be interested in is now this this ability to compel, facts to provide reasons, and also to what the remedy will be if they don't comply.
Yeah, and it won't be FACTS for Red Deer and South. It'll be FAOS or SAFPIC. And so there is kind of a geographical cutoff. So we're using these shorthands. So FAOS is Forensic Outpatient Assessment Services. That's the service that provides the community forensic mental health provisions for Southern Alberta. FACTS, Forensic Assessment Community Services, is north of Red Deer up, and that's in Edmonton. FAOS is in Calgary. Alberta Hospital Edmonton is north of north of Red Deer, and you'll see AHE, Alberta Hospital Edmonton, and SAFPIC, which is Southern Alberta Forensic Pavilion Center, I think, or Forensic Psychiatry Center. Sorry, it's been a little while since I've had to say it. And it deals with Red Deer and South. And Dr. Hashman is the lead. So he would be the one that I would be contacting. Dr. Santana takes a big role. I'm not sure if he's still there because it's been a little while, but he did take quite a large role. But yeah, it's applying that pressure. And you'll be in a better position to do that once you have kind of a dedicated mental health court, whether in Red Deer or Calgary. Also, I understand in Calgary that they do have kind of a stakeholders meeting regularly. So you, Jacqueline, you might want to get on that stakeholder meeting if it still exists. I know Judge Graham, Marlene Graham, used to be on that, but talk to Dr. Hashman and he'll tell you about it and he can maybe get you on it.
Thank you, Judge Collinson. The next question is also from Jackie, but I know that it's going to have a wider relevance for everyone else here. And it has to do with ethical considerations when raising the issue of fitness as duty counsel, especially. So Jackie's question is, that advice is often given that duty counsel may be the only person to see the signs that there may be a fitness issue based on their conversations with the accused person. And it can put duty counsel in a difficult position, that ethical dilemma where we cannot get instructions to request a fitness assessment. And while we have concerns about fitness, we don't want to reveal discussions, those privileged discussions. So some people's advice is just put the accused on the screen for the judge to start to ask questions and get to, the Taylor test. But is this a correct approach? Should counsel be raising this issue for the court? How to get the court or crown to turn their mind to the issue of fitness without revealing privilege to kind of communication or prejudicing a client?
I really can't talk about fully defense counsel's ethical considerations as a judge and a crown prosecutor. Those were not my high on my level of knowledge, but I can say I find nothing inappropriate for counsel to alert us. I think it's appropriate for a counsel to say, I cannot get instructions. I am concerned that fitness is an issue, and that's it. But alert us, like just don't say I can't get instructions because I don't know what that means. Why can't you? Because you guys don't like each other, you don't speak the same language. I don't know what it means. Alert me to, I think fitness might be an issue. And then say, but I'll have the court meet with the accused. I'll ask the court to make their own determination. And you can say, ethically, I just can't reveal anything more because of solicitor-client privilege. You can say that. We're not going to fault you for that in any way, shape, or form. You have to realize, though, that I have a lot of working experience in the area of fitness. And so I might actually know the questions to ask or, how to have the conversation and sometimes I can actually get out of them information that satisfies me that they're fit. Sometimes you have to, particularly someone who is in a paranoid kind of psychotic state, they will select who, not deliberately, but their paranoia may be selective. They may be choosing not to give you information because they see you somehow as being dangerous to them, but they may not see me as being dangerous to them. Or it could be the other way around. They might not find you to be dangerous, but they find the court to be really dangerous. So a different person asking the questions might get a different answer. So I do think that works. I don't have any problem with it happening that way.
Thank you so much, Judge Collinson. I think that that's a really good answer, and I'll be prepared to delve into some of that from my experience as duty counsel, especially in that dilemma area of trying to do something that's in their best interest versus providing them with the agency required by sometimes low bar of fitness. So definitely, I can further elaborate on some tips for counsel on how to speak to mentally ill clients who may be fit but difficult to get instructions from as well. Darcy raises an important point that I wonder if you can touch on. And that is the question of why counsel need to understand and be wary of the consequences of a finding of unfitness, and the consequences of transfer of the individual to the purview of the review board. In other words, why do council have to be very careful when they're raising the issue of fitness and when it gets to a point where it's a fitness hearing? If that puts that
delay. That's why, from my perspective. You might have some other ideas, Darcy, about and you know, if you wish to chime in about what those determinations are. You know, Edmonton, I have to say, we're pretty streamlined now in terms of we'll have a fitness hearing. It's quickly they get referred to the review board. If the review board determines that they're fit, it comes back to us and we have a fitness hearing really quickly. But I know previously in other jurisdictions, Calgary, I have seen it get delayed 8, 9, 10 months before they even have the fitness hearing again in court. And your guy's been stable, but not able to do anything, hasn't been able to access bail, hasn't been able to move their matter forward. They want to plead guilty. They can't because they haven't been found fit yet. And so it's just put a hold on everything. So again, I'm hopeful with the idea that there might be some mental health courts opening in other regions, that we can start to streamline things in the same way that we streamlined them in Edmonton. That's some of your risk, is that there's going to be these delays. And because it fluctuates, they can bounce back and forth, be fit, unfit, fit, unfit, fit, unfit. And so you really want to get in there quick when they are fit and deal with all of their matters as quickly as possible, realizing that not all people are going to be entering guilty pleas, but you want to take advantage of their health when they have their health.
Thank you so much. Next question is from Deborah. Deborah was wondering that in relation to treatment orders and that it's not possible to get one for ECT therapy, she's wondering why this might be the case in a forensic context when it is possible to get a treatment order for ECT for a certified patient. Why would there be a difference when it comes to a treatment order?
Because it's specified in the law. In the section itself, 672.58 very specifically says that you cannot order ECT. And so ECT, and again, I'm just speaking as a layperson, got a really bad rap through the 70s and 80s and 90s. And Dr. Syed's probably in a better position to speak to this. There have been advances in ECT, and it can be a really good treatment, particularly for treatment-resistant depression. But there is a real sense that it is very invasive, and the risks outweigh the benefit in the criminal context. And so I think that's why that section is in there. And there's not the safeguards. There's, you know, we think of the criminal laws having lots of safeguards to protect people's rights, but it doesn't have the robust or as robust safeguards as the civil mental health context does.
Thank you. Darcy is wondering if you could comment on the use of conditions, so whether by a suspended sentence or conditional discharge, to require or stipulate mental health treatment conditions over a period of time following sentencing.
Yeah, very challenging, because you can't force somebody to take a particular medical provision, medical treatment by using suspended, you know, probation terms. But what you can do is put provisions are that say they will meet with their doctor, go to their doctor and follow the advice of the doctor. But it is very challenging because there is agency in terms of medical health. And mental health is, of course, medical health. And most times I look at those provisions as being guidance as opposed to being enforceable. So there is a real challenge with them being enforceable. And they have to be crafted very carefully. And when you go to put them in, you need to have the consent. So when it's a suspended sentence or a conditional discharge for medical treatment, which includes mental health treatment, you need to note the consent of the person, that they're consenting to that condition being in there. And now which case? Knobloch, K-N-O-B-L-I-A-C-H, I think, A-C-H. Let me see if I can find it for you quickly. And sometime today. What's that?
I put it right into the
Amna's
chat.
put it in chat.
Did you already grab it, Ms.
Yes.
Qureshi? Oh, okay. You're ahead of me. Thanks.
No problem. I've got a question here from an Odian wondering whether the defense counsel has any obligations to the court after the court orders a fitness assessment.
To the court after the court orders a fitness assessment. In what way? I need to understand what they mean in terms of.
Yeah,
what do you need to do after the court orders a fitness assessment to make sure that your client actually meets? So particularly if your client is out of custody, make sure that your client actually makes it to the fitness assessment appointment. You can make sure you can, if you're wanting to be like super careful, you can get a copy of the assessment order and make sure that it says what it's supposed to say and that it gets sent to the appropriate people. That's one of the ways you can facilitate to ensure that it gets done. You can follow up if you're in Southern Alberta with Dr. Hashman to make sure that they're getting it done and let them know what the deadlines are. Those are the things that I could see. Do you have any other ideas, Ms. Qureshi?
You know what, those are certainly things that I can address when I talk about tips for defense counsel and advocating for their clients in places like mental health court or those places where there isn't mental health courts. And in terms of fitness assessments, I would say following up to make sure that one's been prepared and you've received it and that the courts received it, the Crown's received it. I would also say, as a practice tip, that many times, even if an opinion from a doctor comes back with your client being fit, read it because many of the comments will help you in talking to your client. They'll have advice for counsel, such as simplify your language or provide breaks when talking to this client. So those fitness assessments, even if the purpose is to decide if there's an issue with regards to their fitness, may also be instructive for counsel in terms of guiding how they ought to interact with their own client. So in terms of, we've got a question from Kale that I'm scratching my head about, and so please follow up if I've got it wrong. Of course, Judge Collinson, you can read it for yourself, but I think that this question is about psych assessments generally, and perhaps not fitness assessments per se. So other kinds of psychological assessments or reports that may be meaningful and impactful, but counsel have trouble receiving because of resistance from court. Maybe it's a resource issue. I know with regards to fax assessments, there had been some restrictions in the last couple of years. So perhaps you can speak to that.
Well, one of the challenges that they're outside of these provisions and the DO and LTO provisions in Section 34 of the Youth Criminal Justice Act, there is no legislative authority for ordering a court-ordered assessment. So when FACS and FAOS did pre-sentence reports assessments, they were doing so essentially under the authority given under probation reports, where probation can request other reports, and we're doing so as a courtesy to the courts. We were and are privileged compared to other jurisdictions in that regard. Other provinces didn't get the same service from their forensic psychiatry services. So it's not, the apprehension is not sisters and brother judges saying we're not going to order assessments because we're worried there's going to be too many. We as judges appreciate having as much information as possible in our decision making. The aspect is that our service providers who have been providing those assessments through their goodwill have indicated that they have limitations. And so we have to respect those limitations. the best that you can do sometimes. I know you're not getting paid, but if you can get consent from your client to get medical information from their service providers, and it means you have to go through and pick out the salient points and try and make them impactful and meaningful to the court. Sometimes that's how you have to do it. I think Ms. Qureshi's going to have more tips about that.
Yes, I can certainly provide some information there that might be helpful. There is another question that relates to mental health diversion, and so I'll just ask council if they don't mind, I'll tackle that during my presentation, just to help the information gap between understanding what the mental health diversion program in Alberta means and how that might be different from mental health court, and how to advocate for your clients to get into either one of those types of programs. Just noting the time, though, I do want to make sure that we've got time for a good lunch break. So I'd like to just say thank you, Judge Collinson, for all the information you've provided and for, again, being such an invaluable resource to myself and the rest of the mental health court team through the past almost 5 years of its working. So I'm going to turn it over to Danny if you have any other comments for our first two speakers before we take our lunch break.
Thank you. I just wanted to thank you both again for giving of your time today. Excellent presentations. I've learned so much from both the presentations so far. And just in case you're not here this afternoon, I wanted to advise you that Legal Aid, to thank you, will be making a donation to the Mental Health Foundation of Alberta for your participation today. So thank you very much.
I'm pleased to hear that. Thank you.
I'm just going to reintroduce this afternoon's speakers in case anybody forgot. So first speaker this afternoon is Alexandra Seaman. Alex is a senior partner with Dawson, Duckett, Garcia, and Johnson, where she practices criminal, administrative, and professional discipline law at both the trial and the appellate level. She's a graduate of the University of Alberta Faculty of Law and is a sessional instructor at the U of A Law School teaching advanced evidence. She regularly provides presentations on issues including ethics and substantive legal issues to law students and lawyers. Alex is a member of the Criminal Trial Lawyers Association, Alberta Prison Justice Society, and a legal aid roster lawyer. Alex is an active community volunteer. She sits on a number of boards and is the mother of 2 young children and 1 fluffy labradoodle. So I'll introduce the others as they come up. So I'll turn it over to Alex now.
Thank you so much for the introduction and for asking me to be here today. It's my pleasure to be speaking with you this afternoon about practicing before the Alberta Review Board and what that looks like as counsel when we walk into those hearings, how to prepare for them, and some practical considerations. And I know you've spent much of the day today hearing about other parts of the criminal justice proceedings dealing with mental health issues. The Review Board is a really interesting area of practice, and it's very different from what we do in court. So I hope to provide a little bit of insight and hopefully encourage some of you to engage in this kind of practice. There's certainly a significant need for counsel to be involved, and counsel who have an understanding of how to practice before the Review Board. So for anyone who is not familiar with the Review Board, it operates under the Criminal Code and has jurisdiction over individuals who are found to be unfit to stand trial or who are found not criminally responsible on account of mental disorder. There's a provincial review board set out for each province and the territories in Canada, and they operate independently from the criminal justice system, but very much in conjunction with the criminal justice system. And I've prepared a significant number of slides for you today, which will hopefully contain a lot of detail. But essentially, the legislation requires that the review board be comprised of 5 members. They're appointed by the Lieutenant Governor, and 5 is the absolute minimum for the board. At least 1 member must be licensed to practice psychiatry, and another must have training or experience in medicine or psychology. And in order to have quorum, in order for a hearing to proceed, the chairperson, a psychiatrist, and another member must be present. In reality, the review board almost always sits in panels of 5 There's other members as well, but typically they'll sit in panels of 5 and they'll be either the chairperson or an acting chair. The other people who appear before the review board are the NCR accused or the unfit accused, or the patient as we might call them. And typically they'll be represented by and accompanied by counsel, or in the case of the unfit accused, by duty counsel. The Attorney General is present, usually represented by Crown Counsel, and someone representing the hospital will also be present and has standing to make submissions. So typically, at least up here in Edmonton, that will be someone from Alberta Hospital. And I note that someone is saying that up in BC and in the Yukon, the review board typically sits in panels of 3. In Alberta, I've always seen them sit as panels of 5, but as I said, quorum can be made up simply by 3 members. So certainly where that's more practical, I imagine that's the case. Other people can attend the hearings as well. So it's not just the board and then those 3 parties. Members of the treatment team will often be present. This could include people from nursing, social work, occupational therapy, various staff members who are involved in the day-to-day treatment of the accused. Supporters or family of the patient accused may be present. Boyfriends, girlfriends, parents, siblings, anyone who might be designated a responsible adult for them, or just someone who's there in support of them. Or the victim and the family of the victim can also be present. Unlike our adversarial proceedings in court, the review board has an inquisitorial mandate, which is very different and operates on a much less formal basis than the way court proceedings unfold. So whereas in court, we're bound by very strict rules of evidence and very strict procedures that need to be followed, things before the board are a bit more informal. That's not to say that they are not still formal to some extent. They're certainly conducted professionally and formally, but it's very different from court proceedings. For example, when we were appearing in person, we would often sit to make submissions and be seated while asking questions, whereas in court, of course, we would be on our feet standing whenever we address the court. The board can ask questions of the accused or the patient, and you may be asking questions of the doctor, and another member of the treatment team may just jump in to provide the answer because they're more suited to provide that answer. So things are a little bit less formal when it comes to the rules of evidence and procedure, but there's still very clear procedures to be followed. As part of this inquisitorial mandate, the board has the responsibility and is required to seek out and consider evidence on all sides of the issues. And I've cited the Winco case here, and we'll talk about the Winco case in some greater detail because it's really one of the leading cases in this area. The final point, though, I'll make on this is that the chair of the board has the same powers as a commissioner under the Inquiries Act. And the chair of the board is allowed to do things like adjourn the hearing to gather more evidence. The board can subpoena witnesses if required, that sort of thing. So there's really 2 different types of scenarios before the review board. We have accused who are found not criminally responsible, and we have individuals who are found unfit. And I'll talk about both, but I'll start just by saying that, much is the same appearing before the review board on a fitness hearing as opposed to an NCR hearing, but the threshold question is different, and fitness engages different questions and different issues than NCR hearings. But some of the comments I'll make here about procedure and that sort of thing are applicable in both scenarios. I'm going to start, though, with dealing with the potential dispositions for an NCR accused and kind of an overview of the NCR stream in hearings before the review board. So there's 3 potential dispositions that are allowed in law for an NCR accused appearing before the review board. The first, as you can see in sub A, is an absolute discharge. Sub B is a conditional discharge, and subsection C is maintaining on a custody disposition in hospital, or what we often refer to in Alberta as a full warrant. So those are really the 3 options that are available anytime a person comes before the review board. And review board hearings typically, and I'll talk a bit more about timing in a moment, but typically take place every 12 months or so, every 11 months. So it's an annual review, but that's not always the case. So looking first to the absolute discharge, that first available option. An absolute discharge can only be granted where the board is satisfied that the accused is not a significant threat to the safety of the public, which requires the board to make a positive finding that the accused remains a significant threat to the safety of the public. If the board is unable to come to that conclusion, if they think that they may be, but they can't conclude that they are in fact a significant risk, then an absolute discharge must be granted. And once an absolute discharge is granted, the review board has no further jurisdiction over that accused person. So that concludes the legal proceedings, so to speak. In looking at an absolute discharge, the board is entitled to and is required to look at future risk as well, and future risk to the public. But that risk has to be more than just speculative. It must be a risk of serious harm, and it must be a real risk. So looking at the HMH case from the Alberta Court of Appeal, it tells us that a possibility or even a likelihood of decompensation, which could lead to depression or self-harm or paranoia, was insufficient to prove a significant threat in all the circumstances. The test is not whether the appellant's behavior could lead to decompensation and therefore the risk of serious harm, but whether there is evidence to support a positive finding that there is a significant threat to public safety. And yes, I'm going to talk a little bit about how absolute discharges are not available to unfit accused. I'm dealing right now just with the NCR stream, and we'll talk about fitness in a moment. So some of the things that the board will be looking for, and that as counsel we should be looking for in assessing whether an NCR accused is ready for an absolute discharge, are things such as whether there have been instances of violence or threats of violence, medication compliance, insight into illness. Does the person know that they have a mental disorder? Can they recognize when they need help? Do they ask for that help? Can we point to instances in their history that show that they understand this and that they know how to seek out that help when they're having a difficult moment? And these are things that the board is often significantly looking for. And as it says here in this 2018 Ontario Court of Appeal case, insight is an important factor, though it's not determinative of whether an NCR accused is entitled to an absolute discharge. Some of the other things to look for as well are things such as community supports. Who will this person turn to if they start to decompensate? Do they have an established relationship with a treatment team or care providers in the community who can assist them? And the way this plays out as counsel is we receive a letter and a pre-board checklist or an assessment report that will outline the patient's history before the review board. It will outline the circumstances of the offense, which has brought them under the jurisdiction of the review board. And then it will outline all previous reporting periods that they've had and the current reporting period and their current risk assessment. And it's in looking at in that report that we look for indicators of some of these things to assess whether proposing an absolute discharge is something that the patient might be ready for. And of course, we follow our client's instructions as well. So as I said, the Winco case is really the leading case when it comes to practicing before the review board. And it sets out the test and the guiding principles in significant detail. And I'll go through them here, and I've reproduced them because they really are some of the most salient points to keep in mind when you're appearing before the review board. So the test or the question that the review board has to ask in every case, in every review that is conducted for every NCR accused, is, does the evidence disclose that the NCR accused is a significant threat to the safety of the public? Which means a real risk of physical or psychological harm to members of the public that is serious in the sense of going beyond merely trivial or annoying. The conduct giving rise to the harm must be criminal in nature. And there is no presumption here. So even where the NCR accused or patient has been found NCR on a homicide, there is still no legal presumption that they pose a significant threat, nor does the NCR accused bear any burden before the review board to prove that they are not a threat. The board must find positive evidence to support the conclusion that they are a significant threat. So if there's uncertainty, if they can't resolve whether or not the NCR accused poses a significant threat, then the NCR accused has to be discharged absolutely. Now, the risk assessment that is conducted typically by the treating psychiatrist will indicate their findings on whether or not this person remains a significant threat, and that will help resolve this, and that'll be evidence that's put before the board. So as I said, given the inquisitorial mandate of the board is required to seek out evidence that it needs to make its decision. So if the evidentiary record is lacking, the board is required to seek out of its own motion evidence to assist in reaching that decision. And a significant range of evidence is presented. As I said, the board looks at what the index offense was, the circumstances of that offense, as well as how the person's trajectory has been under the jurisdiction of the review board through all the reporting periods, and how they're doing, not just in the last 12 months, but as we'll talk about later, often for so many of these people, they've been under the jurisdiction of the review board for such a long time that there's a very significant history there for the review board to look at in determining whether or not a significant threat remains. But the fact that the person was alleged to have committed the index offense, often a very serious offense, is not itself determinative. So we don't simply look at someone and say, well, this one time you did something, therefore you will always be a significant threat. That doesn't meet the test that's been set out. So what happens once the board concludes that someone is a significant threat? They then have two options: a conditional discharge or the full warrant option that I mentioned earlier, subject in both cases to appropriate conditions. So the board must then decide, taking into account the needs of the public and the condition of the NCR accused and the potential for reintegration and rehabilitation into society, and make an order that is the least onerous and the least restrictive in order to properly balance and address all of those concerns. And I have prepared a list to go through a bit later that will set out some of the potential conditions that we often see in review board dispositions. So the Alberta Court of Appeal in WCR in 2019 distilled down the safety of the public test to these four components. Is it at the time of the review, based on evidence before the board, with some certainty that the accused is a significant threat to the safety of the public? So those are the four almost check boxes that need to be checked off in order to make a finding that a significant threat remains. And goes on to again define what a significant threat is. And it's a risk of serious physical or psychological harm resulting from conduct that is criminal in nature, but not necessarily violent. And goes on to explain that it cannot be trivial harm, it must be significant, and it must be serious. Speculation or uncertainty is not enough. And again, emphasizes that if there is any uncertainty, an absolute discharge must be granted. But where a significant threat remains, the board must select the least onerous and restrictive disposition that is compatible with the safety of the public and the other criteria that's mentioned in section 672.54. And the Leonce decision from our Court of Appeal in 2021 talks a bit about what those other factors are under section 672.54 of the code. They include the mental condition of the accused, the reintegration of the accused back into society, and other needs of the accused, which includes a consideration of the impact on the life and the liberty of the patient, and the significant restrictions that are often accompanying full warrant dispositions, and balancing that with the need for them to be as least restrictive as possible. One of the other factors that isn't explicitly mentioned under section 672.54 of the code and hasn't necessarily been explicitly considered yet, but I hope will be soon, is the need to consider gladue under the other factors or other criteria in terms of looking at the need to reintegrate into society and how to successfully accomplish that. And as our understanding of intergenerational trauma and the interplay between substance use disorders and mental health continues to grow, I'm hopeful that this is something that might start to gain some traction with the review board, perhaps with the Court of Appeal, and start maybe moving the dial a little bit on this. And while we don't have any explicit case law on this from Alberta yet, this 2005 decision from the Ontario Court of Appeal talks about how in some cases it may be the board's duty to consider Gladue principles, and that the inquisitorial mandate may impose a duty to seek out Gladue information in some cases. So I hope that this is something that Council can hopefully start working toward in speaking with patients and identifying cases where it's appropriate to be presenting this information and seeking it out. In particular, in terms of looking for treatment options that are more responsive to the needs of Indigenous offenders and substance use disorder, and recognizing some of the treatment that has conventionally not worked may not be culturally appropriate. There is another decision from the Ontario Review Board, which seems to have sort of accepted in principle the application of Gladue principles. It's a 2001 decision that talks about, the need to undertake highly individualized and broadly based evaluation and assessment. And it needs to include an analysis of the unique historic, cultural, political, and systemic component of the Indigenous heritage and traditions. So there is some support for this in law, and I personally remain very hopeful that it's something that we can urge the review board to start considering more often, and hopefully bring before the courts where it may not be considered as fulsomely as it should. And ultimately, given the inquisitorial mandate of the review board, I think there's a real important role to be played in ensuring that the board seeks out that evidence where it's appropriate as well. Ms. Swick has asked if there's any information as to whether Indigenous patients are overrepresented in the NCR population. And that's a great question that I don't have an answer for, but if our experience with the criminal justice system has taught us anything, it's that Indigenous people, unfortunately, are even more likely to come into the grips of the criminal justice system. So it wouldn't be surprising if they were overrepresented amongst the NCR population as well, but I don't have any solid evidence on that or anything to back that up. So the next option then is a conditional discharge. So we've talked about an absolute discharge and the WINCO test and what's required in terms of getting there. Where the accused is a significant threat to the public safety, a conditional discharge is one of the two options that remains. And typically what this means, just like a conditional discharge in the criminal justice stream, is that the accused is discharged conditionally. This enables them to live in the community, typically, subject to specific conditions set out by the board in a disposition order. Those conditions often include things like remaining under psychiatric care, refraining from using alcohol or drugs, reporting any change in address, refraining from contact with certain individuals. One of the driving factors between why the treatment team might ask for a conditional discharge is it gives the hospital the ability to bring someone back into custody and into the custody of the hospital on a full warrant should they start to decompensate, or should there become any concerns about their compliance or their behavior or anything like that. So it leaves the board with a mechanism, or not the board, the hospital with a mechanism and the treatment team to bring the accused back into custody. That doesn't exist with an absolute discharge. Once someone is absolutely discharged, there is no longer any jurisdiction over them to bring them back into custody or anything like that. So that's why the hospital will often, and the treatment team will often recommend a conditional discharge to allow them that extra layer of supervision and that extra ability to bring someone back into custody if things aren't going well. Because the unfortunate reality when dealing with many of these NCR accused is that their mental health, as we would expect, often ebbs and flows. And from time to time, people do decompensate, whether through exposure to community stressors, exposure to substance use, or any other number of different factors that can cause that decompensation, and the need to bring someone back into custody in the hospital to potentially stabilize them and get them back on track. And of course, the conditional discharge is typically for patients who are doing quite well, but they aren't quite ready yet for that absolute discharge. Then the final option is a custody disposition or an order for detention in hospital, or what we typically refer to as a full warrant. So this is where the board orders that the patient be detained in the hospital by way of a warrant. It will likely specify the hospital where the patient is to be detained. And the order will also contain the conditions regarding the privileges and the movements of the patient and their access to the community. And I have on the next few slides, some lists of the types of conditions and privileges that might be included on any of these orders, whether conditional discharge or for a full warrant, but particularly for a full warrant. Community privileges may include things like permitting the patient to reside in approved accommodations if they're ready for that. And that may be 24-hour supervised accommodations or other accommodations. The board may also delegate certain privileges to the zone chief. So what that would mean is that some privileges may not be available to the NCR accused immediately, but rather would be delegated to the zone chief, which means if the accused is doing well and wants to access these privileges and the treatment team supports that, they can go to the zone chief to grant the privilege at their discretion. So it's a way to grant a privilege with an extra layer of protection built in, meaning it's not immediately available, but in the next 12 months, if the patient is ready for it, it could be a possibility for them. So in terms of potential conditions that you might see on these types of orders, there may be conditions to keep the peace, to abstain from the use of drugs or alcohol, not possess any weapons, maintain good health, attend before the review board when notified to do so. And of course, for anyone who practices in criminal law, these will sound not that dissimilar to the types of things we might expect to see in other types of criminal orders. So the previous ones would be kind of the typical ones we would see. The rest of these are the more discretionary conditions that you might see put in place. So things like ground privileges that could be supervised by a staff or a responsible adult. And a responsible adult is someone who has been designated by the hospital and the treatment team to be someone who is capable of supervising the patient. So it's not just any adult, it has to be someone who is designated as a responsible adult, which is a very particular term. Unsupervised ground privileges, so allowing someone to walk the hospital grounds unsupervised. And of course, we never start with unsupervised grounds. You would typically see them starting with supervised grounds. And there's a very gradual escalation of privileges to kind of see how someone is doing and slowly allow them greater liberties and greater movement. Next would be staff supervised passes into the city of Edmonton or the city of Calgary. Then, of course, unsupervised passes would be the next one or the next step. Supervised picnics or recreational outings, attending drug or alcohol treatment programs, utilizing passes, and the board can specify exactly how many days and nights someone might be able to utilize a pass to a city or a town somewhere. So for someone who might have family out of town, the board could grant permission for them to go spend 2 nights with their mom or dad in Fort McMurray, for example, or to travel for a certain period of time, or to live in approved accommodations. So these are some of the conditions that we might see on either a conditional discharge or a full warrant. And that's just, again, speaking to the delegation aspect of it. So allowing those additional liberties that it may not be contemplated that the accused could use right now, but maybe 6 months from now. So for example, someone who it's contemplated would have staff supervised ground privileges only, might have delegated unsupervised ground privileges on their disposition order, simply to allow them to maybe use that in the reporting period if they get to that point. Other conditions that you may see, and these will vary on a case-by-case basis, but things like no contact with the victim or the victim's families, if that's appropriate in the circumstances, restrictions on the use of electronic devices, requirements not to drive a motor vehicle, restrictions on having pets, requirements to report all romantic relationships to the treatment team, that sort of thing. So those are the types of more creative conditions that might be imposed. And those will be responsive to the specifics of the index offense typically and the needs of the specific offender or the specific accused. A few other decisions from the Court of Appeal that I think are important to highlight as well. And our Court of Appeal has issued quite a few decisions in the last couple of years on review board decisions. So one from 2020, just reiterating that the resulting disposition must be the least restrictive on the liberties of the accused in the circumstances. And then the DeGroote decision from 2021, a liberty increasing condition cannot be granted if it elevates to an unacceptable degree of risk or serious physical or psychological harm to the public. So the board is very careful in imposing only privileges or conditions that must be the least restrictive, but that also must also balance the safety of the public. And it's a careful balancing act and will have to be based on the evidence that's presented before the court. And I note that there's a number of questions here, and I hope to address those at the end, but I'm going to, just in the interest of time, keep going now to talk about fitness, which is, as I said, separate. It's a separate stream from the NCR scenario, and an absolute discharge is not an available option for an unfit accused. So as I said, the threshold question for dealing with fitness is different. The first question that must be addressed is whether the accused is found to be fit. And if the accused becomes fit, the board must return the matter to the court. So the board's jurisdiction over the accused ends and they're returned to the court for court proceedings. If the accused is unfit, then the board is required to impose a disposition, but it, as I said, is limited only to a conditional discharge or that full warrant or custodial disposition. So the absolute discharge is not available here. And in the second stage of the inquiry, the same factors in section 672.54 apply, but there's no requirement to establish that the accused is a significant threat. So I know that fitness was covered at length today by Judge Collinson. So just very briefly, the accused is unfit to stand trial where they're unable on account of mental disorder to understand the nature or object of the proceedings, the possible consequences, or to communicate with counsel. In the case of an accused who has been found unfit, the court retains a residual jurisdiction over the accused, but the board maintains jurisdiction over the unfit accused for so long as they remain unfit. And it's important to know that once an accused is found unfit, they will likely be remanded into hospital following that finding. So there's also the possibility for someone to be found permanently unfit. And as I said, they cannot be absolutely discharged, even if they pose no threat to the public. But there is the provision for the review board to recommend that the court hold an inquiry to see whether a stay of proceedings is appropriate. The other thing to think about when we're dealing with fitness is that the Crown is required every 2 years to demonstrate that a prima facie case exists against the unfit accused and that they're still in a position to prosecute the case against the accused. So as I said, someone may get taken into custody following their fitness hearing and taken into custody in hospital, and then they stay in custody pending that finding of fitness while their matter gets referred to court on what we call a keep fit order. So someone may be found fit and then they stay in hospital while the matter returns to court, just to ensure that they remain fit under section 672.49 of the criminal code. That's one available option. And then the other little nuance here is what we call dual status offenders. So a dual status offender is someone who receives both a sentence of imprisonment and is under the jurisdiction of the review board. And in the rare case where that happens, it's important to reference this section to see which order takes precedence and to know that the review board of its own motion can make a motion to review the placement of the accused or the dual status offender at that stage. So just to be aware that that scenario does exist as well. So I wanted to talk a little bit now about some very practical and real considerations for counsel faced with an accused person in the criminal justice system who may be potentially NCR on account of mental disorder, and the difficult decision as to whether or not to pursue an NCR application on behalf of an accused. And it's a really difficult thing to put a fine point on, but detention in hospital and the restrictions on someone's liberties will often very significantly exceed the type of sentence that an accused in the criminal courts would otherwise receive. So it's really important that counsel think very carefully before pursuing an NCR defense for an accused and think about what the long-term implications might be. There are many individuals who spend many, many more years in hospital and under the jurisdiction of the review board than they otherwise would have if they're facing probationary sentences or that kind of thing. And of course, every case must be evaluated on a case-by-case basis, but the NCR system in particular can be very, very restrictive for a very lengthy period of time. So it's important to have a really informed understanding of what someone's trajectory might look like before advising them as defense counsel to pursue an NCR defense, particularly on more minor summary conviction offenses. So I want to turn now to talking a bit about procedurally how to actually conduct hearings before the review board, but this might be a good time to pause and answer some of the questions that have come in. I'm just going to read through them. I noticed that you use the term treatment team, yet Section 672 explicitly prohibits treatment without consent. Given the clear prohibition on treatment without consent, do you have views on the common practice of having treatment imposed on accused detained by a review board order without consent using provincial legislation? I'm not going to touch on the provincial legislation side of it, but what I will say is that when I use the term treatment team, I'm not speaking from the perspective of a treatment team imposing treatment, but the treatment team typically consists of the treating psychiatrist, nursing staff, occupational therapists, etc., social workers who are all involved at the hospital and through FACS or down in Calgary in terms of providing the overall care and treatment to the accused. And so when I use the term treatment team, I'm speaking of it in that context, in terms of kind of the group of participants who oversee the overall treatment. There is a window of opportunity where treatment can be provided without the consent of the accused, and it's provided for in the criminal code in a very brief interval after someone is found unfit, which is also an interesting issue to look at. When seeking a conditional discharge, should there be an admission of a guilty plea? No. When we're in the NCR system, someone has been found NCR, there's no discussion about guilty pleas or anything like that. Also, would there be an application to order the client to access treatment from the defense counsel without Crown objecting? Typically, if there's going to be a suggestion that the NCR accused or the unfit accused on a full warrant access some form of treatment, and sometimes we talk about residential treatments and those types of treatment programs as an option for the accused, it's often done with the support of the treatment team. And in my experience, the Crown is often very supportive of that as well. And that's one of the kind of other discretionary conditions that might be imposed in a disposition order that would allow the accused to attend. For example, I had one very recently where it specified that he could attend residential treatment at Poundmakers. So typically that's something that everyone is working toward. Because this is a much less adversarial proceeding, there's a lot more common goals. You know, ultimately everyone wants to see the accused doing well. So it's not often that there would be Crown opposition to that, unless there was some significant concern for the safety of the public, because they may take the position that this isn't an accused who is yet able to be in a residential treatment facility and away from the supervision of the hospital. In which case, you know, as defense counsel, you want to make sure that you have the evidentiary record supporting that that's something that could be managed. I thank Dr. Syed for providing the breakdown in terms of the NCR population. There's a question regarding the Mental Health Act. And again, I'm only going to touch on the criminal code side of things, but I think there's some discussion later about proceedings under the Mental Health Act.
Alexandra, I was sort of asked to maybe put some of these questions into context. And since you brought up the Mental Health Act, I think the question really is whether the JH decision, which significantly altered the Mental Health Act, some of the principles that came out of that case, was that, to your knowledge, has there's been any effects on the review board side of things?
Not that I've seen yet, but I think, you know, the difficulty is that we're always quite a ways behind when something like that happens to see the practical effects of it.
I might answer that question for you then. I don't expect it to be, because I think that case is really, while it discusses principles of detainment under the Mental Health Act, I think that is still provincial legislation that we're talking about here, and I think it's specific to the Mental Health Act and the issues arising out of the Mental Health Act. I think the review board is a creature of the criminal code, and it sort of has different concerns, notwithstanding that the two may cross at some point. I think that I guess the answer is I don't know of anything that is from that case specifically that has impacted the decision and how things are done on the review board stand of thing. But not to say that maybe someone wants to take that issue and expand it further, then there always is that possibility. And I think that there's other questions as well that I'm going to try and help you with, but I'll let you continue. But I thought I'd just jump in there because I noticed that Mental Health Act came out.
Thank you. And as Andrew said, and as I was saying, this is really a criminal code based thing. So the Mental Health Act, while there may be some implications there, ultimately this is a creature that has been created by Parliament and is governed by the provisions in the criminal code. So I'm going to turn now to talk a little bit about how to actually conduct these proceedings and the procedures that need to be followed. So starting with the timing as to when a review board hearing is held. So when an accused is found unfit or not criminally responsible, the board is required to hold a hearing within 45 days if the court doesn't make a disposition order. And in my experience, most courts will defer to the review board to make those disposition orders, and most courts will decline to make a disposition order themselves. If the court does make a disposition, then an initial review must be conducted by the board within 90 days. So someone comes before the review board, they have their first initial hearing. The board is then required to hold a review hearing no less than every 12 months, can be extended up to 24 months if the accused is represented by counsel and all parties consent. And typically the way it actually plays out is it's every 10 to 12 months, but hearings can also be held earlier, in theory at any time, on the motion of the board or the request of the accused or any other party. So it's not uncommon to see early review boards held earlier than that 10 to 12 month window. So for someone who's been found newly NCR'd, it might be a good idea and good practice as defense counsel to ask for an early hearing, maybe 6 months down the road, to see kind of how the NCR accused adjust to the medication that they've been placed on and kind of stabilizes in hospital and see how they're doing. For serious personal violent offenses, hearings can now be delayed for up to 2 years or up to 3 years for accused who are formally designated as high-risk accused in some circumstances. And if you find yourself in a scenario where there's going to be a lengthy delay, what I would encourage counsel to do is ask for some of those privileges to be delegated. As we talked earlier about delegated privileges, what that would mean is it would give the accused the ability to potentially access privileges down the road should they be able and in a position to be able to do so. And the zone chief signs off on it, because ultimately, if someone's going to be waiting 2 or 3 years to come back before the board again for a new disposition hearing, you want them to be able to access some of those privileges and have some ability to have some liberty. So some notes on the procedure for conducting one of these hearings. As I said earlier, the chair is able to subpoena witnesses, so the hearing can be conducted in as informal a manner as is appropriate. The accused has the right to be represented by counsel, and where they are not, the review board shall assign counsel for an unfit accused or where the interests of justice so require. Interpreters should be retained in advance. A formal record must be kept, so if for the record recording is actually made, interpreters are very commonly arranged. The accused generally has the right to be present for the whole hearing, subject to certain exceptions. The chair may permit the accused to be absent, or if they're disruptive, may bar them from the hearing. Counsel can obtain instructions to proceed in their absence in certain scenarios. I had an accused a couple months ago who simply couldn't remain in the hearing due to some medical issues that were ongoing, and who gave instructions halfway through for me to proceed in his absence. So, these aren't exhaustive lists of some of the procedural nuances that come up, but just important things to keep in mind. The board can adjourn the hearing for a period not exceeding 30 days to find additional information, and the time for holding a hearing can be extended where there's consent. So how this actually plays out and the way a hearing is actually conducted is it starts with the report and the recommendations from the treatment team, which includes a pre-board checklist, at least here in Alberta, where the treatment team essentially checks off what privileges they're looking for that may be different or that they're looking for in this disposition. And there'll be a pre-board conference that's held, and there'll be notes of that where the accused or the patient attends along with the members of the treatment team and often says, what they're looking for at this year's disposition hearing, and talks about how they're doing as well, not just from the psychiatric perspective of the treating doctor, but from the perspective of the entire holistic treatment team. So looking at some of those other components, social work, nursing, occupational therapy. Are they engaging in programming? What does their financial position look like? Are they someone who is subject to, involvement from the state in those types of affairs? All those types of questions are often kind of distilled out in there. So when the hearing actually starts, counsel should have reviewed the report in advance with their client. So you get it in advance and you speak with the patient. You get instructions from them as to how they want to proceed. In other words, if they want to go along with the recommendations from the treatment team, what they're looking for out of this hearing. So the hearing starts, and typically those would be marked as exhibits on the consent of counsel for the accused and Crown and hospital. So you'll need specific instructions on that, and that's why it's important to have reviewed that with your client in advance. Then the chair of the board will ask the treating psychiatrist to provide any updates or corrections to the report, or I should say the treating doctor. And then it's an opportunity for counsel to engage in questioning the report author and any other members of the treatment team to try to create that evidentiary record to support the position that you're ultimately going to put forward on behalf of your client. Whether that's that this person is ready for an absolute discharge, even though it's not what's being recommended, or maybe it is what's being recommended, that there should be additional privileges added, whatever the case may be in the particular hearing. This is the opportunity for counsel to highlight the evidence that's going to support that position. So procedurally, defense counsel goes first, which is unlike most procedure we're used to. Then the Crown has an opportunity to ask questions. And as I said at the outset, one of the nuances here is that you may ask a question of the doctor, but it may be a question that someone from the treatment team is able to answer better, and they'll often jump in to provide that answer. The hospital representative is then entitled to ask a question as well, and each of the board members can ask questions. Then if anything's arising, you go through the same list again, and everyone has an opportunity to ask anything else that may have come up. Then the patient has an opportunity to address the board, and the board may ask questions of the patient or potentially of supporters of the patient as well. This is their opportunity if the board has any questions for them. And often the patient will want to address the board and express what it is that they want or how they're doing or how they felt the last reporting period went. And then again, contrary to the way things often go in court, we hear submissions from defense counsel first, then from the Crown, then from the hospital, and then the board adjourns the hearing to deliberate. Reasons are usually provided by the board shortly after the hearing, within about 10 to 15 days. And the reasons of the board must be written, and they're subject to appellate scrutiny. An appeal must be filed within 15 days by the patient if they want to appeal the outcome of the hearing. Appeals go to the Court of Appeal, and the appeals are conducted on the basis of administrative law principles. So reasonableness, procedural fairness, duty to provide reasons, all those types of principles are at play. And in particular, we want to encourage people to appeal decisions where there is an arguable ground of appeal. There have been a few decisions from the Court of Appeal, and thanks to the hard work of many practicing lawyers who appear before the review board, including Ms. Petrie. I know she just had to leave, but to really ensure that the review board is doing their job and providing reasons that are cogent and that explain their decisions properly. So I'll conclude by talking a little bit about the assessment report and the letter and a few kind of miscellaneous things that come up here. So as I said, that assessment report will include the background, the history before the board, the circumstances of the index offense, and summaries of each reporting period. And by reporting period, I'm talking about the period of time between each hearing. And often these will be provided in great detail in terms of where the patient has been residing, how they've been doing with their medication, adjustments that are made to their medication, their behavior, their compliance, their interactions with other patients, with staff, with programming. All of those things will be documented. And the reports just get longer, the longer someone is before it or spends before the review board, because each reporting period will be included in there. And then of course, the current reporting period, the risk assessment, and the things that we're really looking for as counsel and that are important to the board's decision making include things like that level of insight, violence, threats of violence, compliance with medication, staff direction, use of privileges. So what privileges they had and did they use them? And as defense counsel, I'd encourage you to suggest to your clients that they take advantage, not take advantage, but utilize the privileges that are granted to them, because it's hard to ask the board for more privileges each year when they haven't used the privileges that they already have. So as counsel, my advice is always to try to use their privileges and to try to get to a point with the treatment team where they are able to use those privileges. Because of course, just because the board grants privileges, they're still at the discretion of the treatment team. So the patient still has to be, the treatment team still has to think that the patient is capable of using them. Substance use is another big one as well. Just a few other kind of miscellaneous things that I didn't know where else to put them. Sometimes our patients or clients will have materials that they want to put before the board. They may have written letters, they may have letters of support, they may have confirmation that they've been attending AA meetings or NA meetings. Any of those types of materials that can be very helpful should be provided to the registrar in advance. Reviewing those reports in advance with your client or your patient and ensuring you have instructions so that you're ready to go at the time of the hearing. I take the view that unless the patient is unfit, they can provide instructions to counsel. Sometimes the level and quality of those instructions may vary, but Unless they're found unfit, they can provide instructions to you and you act on their instructions. Victim impact statements can also be provided. And of course, because the COVID-19 pandemic remains ongoing, video hearings are still taking place. So review board hearings for the last couple of years have been over WebEx, but that can only occur where the patient agrees. So this is done with the consent of the accused. And if the accused doesn't consent, then arrangements need to be made for an in-person hearing. So I would encourage counsel to confirm those instructions. And if the accused isn't going to agree to that, to make sure you let the registrar know in advance so as not to unnecessarily delay things. So that is essentially all I've got. Ultimately, what this comes down to as counsel appearing before the review board is ensuring that you're familiar with the reports that are provided, reviewing them with the accused in advance, and making sure that you have a good understanding of where this person fits within either the NCR stream or the fitness stream, and what options are available for your client, and how to best come up with a litigation plan as to how to best advocate for that and advocate for the outcome that you're hoping for. But subject to any questions, that's what I've got for you today.
Thank you so much.
Danny.
Oh, go ahead, Andrew. Sorry, I didn't know if you were there because your camera wasn't on. Go ahead.
Yeah. So just looking through these questions, Alexandra, there's really, I think you answered all of them except maybe for one last one by Peter Ward asking whether does the ARB have any rules. I'm not sure exactly what rules, but I'm assuming the rules are contained within the code, but I'll let you answer that question.
Yeah, so the procedure set out actually really quite clearly in the criminal code, and I've tried to highlight a lot of the relevant sections in terms of the various procedural things that will come out, but that really codifies the rules and the procedures that are followed. And the sections are lengthy, they're complicated, sometimes they're a little convoluted, particularly when it comes to things like the dual status offender portion of it. But yeah, the rules are set out essentially in the criminal code.
And I think you pretty much answered all the questions as you were going along. So I believe we've got in the Dr. Sayed as well answered in the body, in the context of the chat, some of the statistics dealing with Indigenous populations as far as NCR. I know that the representations you made are correct. I think that this runs across the board in terms of not only NCRs, but dangerous offenders legislation and being found dangerous offender and long-term offender. We have the same issues. So why it's on, and I guess I'll just stay on since I'm doing the next one.
Yeah, well, actually, I saw we had a question from Catherine Checklin in chat, and Catherine, I enabled your
Yes.
microphone.
Hi. Yes. Can you hear me right now?
Yes, can hear you.
Okay, very good. Oh, hi, Alexander. I do a lot of the mental health panel review hearings. For years, I've done them. So I just want to let you know the appeal period is now extended to 30 days, not 15, just so you're aware. And also, I want you to know that all of the forms that the panel now uses say that because of COVID, in person is not possible. So those are just two practical aspects. I just wanted to not leave any misinformation, if not to offend you, but just to clarify. Thank you.
Well, and that's the case for the mental health review panel, but the criminal code is still clear that video hearings can only proceed by the consent of the accused, and the hospital is taking the position that in-person hearings can't proceed. But my view of my interpretation of the case law is that the accused still needs to provide their consent. So it's an issue to canvass with your client, and like frankly, most clients don't take significant issue with it, but my reading of it is that consent is required per the criminal code.
Yes, and I think you're quite right for the criminal matters. I would strongly disagree with you on the other aspect, though, for mental health hearings. But thank you very much for hearing me. Thank you, and have a great day.
Any comments on how to best approach challenging the risk assessment done by the doctor, from Laura Metalis? It's a great question, Laura, and I think we could probably spend 2 or 3 hours today just on how best to challenge the risk assessment and looking at the factors that play into the risk assessment. So things like the imminent risk of violence, as opposed to the static factors that can't be changed. including the nature of the index offense. I think to provide an answer in 2 minutes, the best thing to do to approach a risk assessment and to challenge a risk assessment is to treat it like you would in criminal court when you're challenging an expert opinion. Look at the evidence and the foundation underlying that opinion and see what arguments are available to make. Are there treatment options that haven't been explored yet? Are they overstating the risk associated with one factor or weighing another factor, that sort of thing, but approaching it kind of from the same mindset you would in criminal practice in terms of how they reach that conclusion is kind of the really, really short answer.
Were there any other questions for Alex before we move on today? Alex, I wanted to thank you so much for being present today and sharing your expertise with the group. And I also want to let you know that as a thank you for presenting today, Legal Aid will be making a donation to the Mental Health Foundation of Alberta. So thank you so much for your participation today.
Thank you again so much for having me.
So we're going to take a break after Andrew's presentation. So next we have Andrew Hochul, who's going to be presenting on an introduction to the Mental Health Act and Mental Health Review Panel process. So I'll turn it over to Andrew now.
Good afternoon, everyone. Just like to mention here that this is going to be a presentation basically on an introduction. I think the Mental Health Act, those of you who practice in that area are quite aware that we could spend a lot of time on this aspect of the legislation that we have here in Alberta. And I'm just going to ask Wyatt to turn to slide number 2. So just generally speaking, I think we're going to, as the day goes on, we're going to see a sort of reoccurring theme in all the aspects because we're dealing with people with obviously serious cognitive disabilities, abilities to communicate with us, and it's a specialized area of the law. I've been doing this for a very long time, and I find that the people that act and represent clients in this area of law have, I think, a unique sense of how they approach their client base. They have a great deal of patience, and they certainly have a great deal of dedication. The Mental Health Act, first thing I just want to mention as well is that the Mental Health Act is not mental health panel is not the review board. And the reason I mentioned that, like I said, those that practice in this area, it goes without saying, but people who deal with law and mental health patients and family members in particular, if you talk to people, and lawyers will sometimes assume that you're dealing with one and the same. The review board is the mental health panel. And I think it's always important to ask that second or third question to make sure that they're not asking you really a question about the mental health issues under the Mental Health Act versus the review board. And this is sort of a reoccurring thing that when you practice in criminal court, whether you're duty counsel, whatever the case may be, try and at the outset sort of make sure we know you're talking about the Mental Health Act versus the review board. So the review board is a creature of, as I indicated, the criminal code. The Mental Health Act is civil legislation, but it's certainly one of the most powerful pieces of legislation in terms of affecting people's rights and liberties that we have. I can't offhand even think of anything that would be more important in terms of affecting people's rights, the ability to be free and even make decisions over issues of treatment. Now, I indicated here in the first part of the slide, just a sort of nutshell definition of what the Mental Health Act is. And the Act provides the authority, criteria, procedures, and timelines for the apprehension, detention, admission and treatment of an individual as a formal patient, and contains other provisions that apply to all patients who fall under the Act. Also, I included the part about the community treatment orders, the CTOs, as we commonly refer to them, because that's a trend that's over the years taken off to include a lot of the patients that may have in the past been required either to be in a formal proceeding or may not have had the help and the follow-up that they required out in the community. So I think those two things are important to remember. And I'm just going to go to the next slide, slide number 3. Wyatt, can you go to 3? There we are. Okay.
Yeah,
Someone mentioned previously, and I wasn't really going to touch on this just because it was brought up in something called the JH case that was a case that was appealed, I think, a few years ago, not too long ago. It's a case out of Court of Queen's Bench in 2019. It was a very significant case because it resulted in substantial and significant changes to the Mental Health Act. But I may touch on it a little bit, the differences since that case was implemented, but I think I'd rather just approach it on a going forward basis. And the mental disorder is defined as a substantial disorder of thought, mood, perception, orientation, or memory that grossly impairs judgment, behavior, capacity to recognize reality, or ability to meet the ordinary demands of life, but does not include a disorder in which the resulting impairment is persistent, caused solely by an acquired or congenital or irreversible brain injury. So this was one of the changes in the resultant changes in the JH. It basically addressed those situations where people had a brain injury that really there was no significant thing that you could do in terms of helping them under the Mental Health Act, and that required the definition to be changed. And there was actually a fourth criterion that was added into the analysis of much what happens under the Mental Health Act, which I'll get to in a second here. And I'll let you read through that definition, because a lot of the stuff that you'll see here will end up being the subject of review or questions if there's ever a mental health panel formed to address an appeal. So just to let you know what we have here, as I indicated, it's a statutory body. The Mental Health Review Panel oversees issues addressed under the Mental Health Act. That's their mandate. That's what they're designated to do. I would suggest to those that prefer to do it by going through the Mental Health Act, you can do that, but there's a lot of different paths and patterns through it that you need to sort of get familiar with in terms of how you get to a certain point before you go to the review panel hearing. As I indicated, this is a specialized area of the law, and I think that when I started doing mental health review panels, I think probably back in 1990 or somewhere around there, there wasn't a lot of lawyers that were jumping to do this kind of work. In fact, it's like a lot of things, you end up getting one case. I think mine was on a private retainer, and you develop an interest in that area. And then when people know you've got an interest in that area, the files start coming towards you for consideration. And duty counsel back has evolved, obviously, over the years, but the duty counsel is sort of the people I want to address this to as well, in terms of people that are thinking about practicing in this area of law, and certainly encourage people to consider it, because I think you'll find it to be a very rewarding place to practice. Now, let's move to slide number 4. Basically, there's really a couple ways you can a patient can fall under the purview of the Mental Health Act, and I've included in here 4 criterion for admission certificate, because even though this is the criterion for the admission certificate, it's once again a reoccurring theme throughout the act. It follows through on renewal certificates and other areas as well. So you have to become familiar with this criterion. Now, the Mental Health Act, usually, I said, people get involved in the Mental Health Act one of 2 ways, really. One is voluntarily, and the other one is involuntarily. So the voluntary path could be somebody who is presented at a facility, a hospital, knows there's something not quite right, that they're feeling bad, may have had past diagnoses through a psychiatrist, has had connections. They may voluntarily walk into a hospital, into an emergency room, and having done that, they may get certified under the Mental Health Act. The other one is just ongoing patients who get to a point where the person, the psychiatrist or the nurse designated feels that they need to be certified. So the other way is what a lot of you who are practicing criminal law find is they may get presented to the hospital under what they call a Form 10 statement that's filled out by the police, where the police also have a power to present to people for examination. So just try and think of it in steps. The first step is the act talks about how do we get to people for an examination under the act, and just because a person's brought into hospital for an examination doesn't mean they're going to be certified. In order to be certified, they have to meet certain criteria. So the criterion that they have to meet is the ones that I've placed out here. That person is suffering from a mental disorder, has a potential to benefit from treatment from the mental disorder, is within a reasonable time likely to cause harm to others or to suffer negative effects, including substantial mental or physical deterioration or serious physical impairment as a result of or related to the mental disorder, and is unsuitable for admission to a facility other than as a formal patient. So this is what the people that examine the person that's brought into the hospital, whether it's the psychiatrist, whether it's the physician in the emergency department, these are the criteria they have to look at to see whether they can forcibly detain somebody in a hospital setting for a period of 30 days. Now, there's going to be other things that has to be done depending on there's going to be required for a second admission certificate as well. But when a person is presented at the hospital, it can be by a police officer under Form 10. And just going back to that for a second, those that practice as duty counsel in the criminal courts, you'll often see that in the notes. If you have a bail package, hopefully you see that in there. But I think, just as an aside, it's always, if you've interviewed somebody in a docket court, you're a duty counsel lawyer, or that's your client. If you have suspicion that there may be even if you think the person's fit, but you have suspicion that mental health issues are at play, it's always not good to communicate with the Crown and find out whether a Form 10 was ever considered. Even if the person was brought to the hospital and not detained, these criterion weren't met. I think the mere fact that a police officer felt it was necessary to do so should tip you off that there still could be potential mental health issues. It's just that the physician looking at these issues may not have found that they were all available at that time for the person to be detained under Mental Health Act. But the other thing too is that I think sometimes the Form 10s are missed for a lot of reasons, and one of them, like I said, is that maybe a person should have been taken in for a Form 10 when they're arrested. It protects protects the facility as well. It protects the police in the sense that they've done their due diligence and looked at different potentials for why somebody's acting out the way they are. A lot of times, of course, it's a drug-induced psychosis that's maybe contributing to these things. Now, the other way a police officer might be involved in presenting somebody for an examination is on a warrant, and warrants can be sworn out. So information can be sworn to ask a court, a judge to issue a warrant so somebody can be presented to a designated facility for a mental exam. And those are usually Form 7s and 8s, it's commonly referred to those. But what happens there is a family member, somebody feels that their loved one or a friend or somebody's gone to a point where now they've reached a state of psychosis, or they're potentially in a situation where they might harm themselves or others, or they feel that they really need to be brought in for an examination. And sometimes in the rural courts, you'll see this. If you're duty counsel in the rural courts, there'll be a regular docket day, and the judge may say, I have there's somebody here that, and then they're making an application for a warrant under the Mental Health Act. I would suggest, if you are duty counsel on that day, that you bear in mind that this is, I think, a priority issue, and notwithstanding that everything seems to be a priority issue when we're in the courts, this in particular, have a little patience. These people probably have come to a situation where they've sort of at their wits' end, and somebody's told them to go to court, and they're just a lot of times just ordinary people, may not see the courts that often, and are told to come to court during a docket day, and then they see all this other people running around with criminal charges and everything, so they may be a little intimidated by it. If you are duty counsel and they happen to come up to you, just let them know that they'll get their application, and certainly have some sense of um, compassion for letting their matters get heard, even if it's in the middle of a busy docket day, because these are people a lot of times that are not used to coming to court. Now, having said that, of course, you will also hear, when you hear people talking about the Mental Health Act, what I think a lot of people have experienced is a frustration maybe with the Mental Health Act in some ways, because they don't understand that the act has criterion, and that not everybody can be quote unquote committed to an institution. Um, and that we can't simply make everybody a formal patient. That's why we have all these tried and tested criterion under the Mental Health Act to make sure we treat those people that need to be treated in a formal facility. But you will, from time to time, and whether you're in mental health court or whether you're out on the circuit, you will hear the frustrations of people who um, their sons or daughters are all of a sudden charged with offenses, and they'll tell you and say, "See, we tried to get them help. We tried them." And you say, "Well, what about the Mental Health Act?" No, we tried. So you're gonna hear those frustrations because the the people that end up now in front of the criminal justice system did not qualify for a treatment under the Mental Health Act. So just keep that in mind, and that goes kind of back to what I was talking about, trying to determine whether a person had been even under consideration under the Mental Health Act previously. Some of the questions you can ask them is, was there ever a review panel hearing? Do you remember about having to visit him in the hospital? Do you remember him being detained or her being detained in the hospital against her will? So these 4 criterion, suffering from a mental disorder, there's a slide on the next one, but before we get to that, which further defines a mental disorder, and has the potential to benefit from treatment for the mental disorder. This is one of the newer criterion under the Act, which follows after the JH case. The third criterion here that I have is within a reasonable time likely to cause harm to others or to suffer negative effects, including substantial mental or physical deterioration, serious impairment as a result of or related to mental disorder. This little paragraph here, this sentence, has sort of over time developed. It used to be, when I started, there used to be the criterion, I think, is a person likely to be dangerous to himself or others. So sometimes you'll still hear this to be referred to as the dangerousness criterion. Now that goes back quite some time, and it since that time has been changed a few times to include not only, so we don't hear the word danger, we don't see the word dangerousness in there anymore. We see likely to cause harm to others or to suffer negative effects. And there's also a component now of substantial mental and physical deterioration or serious physical impairment as a result of or related to the mental disorder. So it's a lot broader now, but and this will end up a lot of times maybe the criterion that becomes the source of discussion on whether the certification should be upheld at a panel hearing. It's unsuitable for admission to a facility other than a formal patient. Well, thank God we have CTOs now, community treatment orders, because we can now get people into out of the hospital and get them into programs that we can still monitor them without having to completely let go of them because they don't meet the criterion. And I'm just going to go to the next slide. Oh, no, the one sorry. So I did get through the mental disorder aspect, which I was going to mention again, but it's okay. These are all points that take some time to go through the criterion. Now, what I've done here is a flow. What we have here is a flow chart, and this might help you maneuver. I don't think I really need to go through it all right now, but this will help you maneuver through things later on if you have questions about the Mental Health Act and how we get to certain points. So I mentioned how a person might be apprehended or brought to for examination under Form 10 or Form 8 warrant. So if a person meets all 4 criterion, the person has to be, a second person has to be a psychiatrist, usually within 24 hours of arrival at the designated facility. So the Mental Health Act also has a lot of time guidelines that you have to watch out for examinations, for notices of when things have to be brought for an appeal. There's a lot of those little things. It's sort of like a mini rules of court. Kind of difficult to go through a whole, do a presentation on rules of court within an hour. But what I want you to get out of this is to be cognizant of the fact that you're going to find things in the Mental Health Act which require time guidelines, and that certificates be done with a certain period of time as well. And that if a person is certified that there always is going to be a right of appeal to most things. And so we sort of covered the first part about getting a person in for an examination. Now, the second part is going to deal with what happens once a person's been certified. So let's say the criterion have been met. Person is now a formal patient. A lot of different things kick in. And one thing that the JH decision did is it created a lot more duties, I think, with respect to what the board or the facility has to do. Certain things were addressed in that decision and were implemented within the Mental Health Act to essentially put more responsibility, I think, on the hospital and the psychiatrist to do certain things like, for example, treatment plans. So once a person's been certified and there's been a second certificate and the person's under an admission certificate for 30 days, the board must also ensure that the formal patient is provided with a written individualized treatment plan no later than 1 month after the issuance of the second admission certificate. That's right in the act. And the treatment plan must set out the type of treatment expected to be provided to the formal patient, the criterion on which release of the formal patient would be granted, and the criterion on which privileges, including leaves of absence, would be granted. So this is fairly new, and also the treatment plan later on, we'll talk about it as well in terms of, I think it sort of changes how you might approach some of the panel hearings if you're a duty counsel lawyer representing a patient out there. The treatment plan is great, I think, because it focuses people's attention towards addressing individuals, person's needs, as opposed to just sort of forgetting about them and waiting until the certificate is about to expire and then looking at it and saying, oh, geez, what are we going to do with them now? Do we renew it or not? Now, that's not the case, obviously, the way it should be, and it doesn't happen that often. But I think we have to. What I think what this treatment plan may have really done is just sort of codified what the psychiatrists have been doing anyways. I mean, psychiatrists are, as you know, very well educated. We've heard from Dr. Syed, very concerned, well-educated people, and their desire is to help their patients, put them on a treatment plan anyway. So some discussion whether the treatment plan really changes anything. I guess it really depends on whether somebody hasn't had a lot of contact with their psychiatrist. Now, remember, this sort of came out of that JH decision where there was and I'll encourage you to read that yourself because it's a pretty long decision, but that decision was that somebody who was wrongfully held, not under the act so much, but was really not provided with a lot of information on why he was there and in terms of what can be done and some sort of anticipation like the treatment plan has of when a person can be expected to have the certificates canceled. And that JH decision was one where somebody had been in hospital for quite some time as well. I think he was already on his the 6-month review, so he had been in the hospital for quite some time. But I want to more concentrate on sort of what you can expect in under the Mental Health Act in terms of the type of patients we get here. The other thing we have to bear in mind is that we heard a lot about the criminal side of things and mental health. Very important to keep in mind that most people under the Mental Health Act are not involved currently involved in the criminal justice system. This is a civil piece of legislation. People that you get in here are people that were brought in by their family members, people that were brought in by maybe concerned mental health um, uh, people like the crisis team, or even police officers that saw people out in the regular course of their patrolling duty. So they're not all involved in the criminal justice system. So it's very important to remember that we're dealing with a piece of legislation that addresses people that are seriously mentally ill and require treatment. Maybe go to the next slide. Well, a person can be brought into hospital, as I indicated, number one, or brought into for an examination under the Mental Health Act, then they can be certified and required to stay against their will in the hospital. And then there's circumstances where we address treatment as well. The goal of the hospital isn't to just it's not a jail. It's not a place just to keep people away from everybody. It's a place where there's an interest to help people with their mental illness get the appropriate treatment that's required. So that is the eventual goal, and eventually to provide them with a release plan, I guess, in the sense that either hopefully they'll be on a community treatment order, or they may have follow up within the community to take their medications and be in a better position than they were prior to being involved under the situations of the Mental Health Act. Also, it's important to understand that the Mental Health Act has its own definitions of things, and the competence section 26, deals with how a person is mentally competent to make treatment decisions. Now, you'll see different definitions of competence. We've heard definitions of fitness. We've heard definitions of under other aspects, and those are the practice in areas of wills and estates and that sort of thing. There's different levels of competence to provide different instructions and enter a will. For example, a person that could even though a person is not mentally competent to make treatment decisions, theoretically they would be competent to do a will, perhaps, and we've seen that situation. So competence defined as a person identifies a person as mentally competent to make treatment decisions if they're able to understand the subject matter relating to the decisions and able to appreciate the consequences of making or not making those decisions. So it's really a two-part test. Whether they're able to appreciate the subject matter, and the second part, where they appreciate the consequences. Now, I mentioned about the treatment plans before. This is one area where the treatment plans can be helpful as well, because I think the treatment plans sort of compel one to consider what treatments are required, and also gives an objective way to perhaps later on ask questions of the psychiatrist of what the responses were of the patient when they were presented with a treatment plan. Just going to before we get into the aspects of the um, actual hearings themselves, I just want to, for those that don't know, I just want to reiterate um, the panel. The panel basically consists. The panel is a panel struck under the Mental Health Act. It's an appointment in council. As I indicated before, it's basically a very quasi judicial role. The panel consists of 3 members. One, which is a lawyer who is a chair. It's either the chair or the vice chair who will preside as one of the panel members if the chair is unable to do it. So it's required by legislation to be a lawyer. Second panel member is psychiatrist who has no affiliation with that particular hospital where the patient is being kept. And the third is what they call a layperson. So one of the recent changes was when I was on the panel, there was 4 of us. The chair was once again the lawyer, but a psychiatrist, layperson. But we also had a physician on the panel as well. So there's 4 panel members. And for those who wonder, how do you get a vote with 4 panel members? Well, the chair had the deciding vote. So you never had a split decision. So the panel is struck to usually once a week will hear hearings in the various jurisdictions. There's the northern region, which I was a part of. There's the Central region, which includes Ponoka and Red Deer, and then there's the southern region, Calgary, and so forth. There's a number of facilities where these hearings can be held, called designated facility. Designated facilities are hospitals, usually, or it can also be places like Caritas home care, places which are designated to be facilities that can accept patients, mental health patients, but also have certain requirements without going through everything. One of the requirements is that they have psychiatrists available in the facility as well. And so if a person has an application that doesn't disagrees with them being held under a certificate in the facility, they have a right to appeal that decision, and they appeal that to the mental health review panel. If it's a decision in relation to them being held, then they file a notice of form, and that goes to the chair, and then the chair has an appeal hearing. There's an incentive to have these hearings as soon as possible, because there's an incentive for everyone to have a decision so they can act on that decision. And the way it's done in each jurisdiction may be a little bit different in terms of where it goes, but the basic thing is that the patient files the appeal, and then he has a review panel hearing in front of the 3 members of the review panel. At that hearing, they can be represented by duty counsel, and duty counsel usually gets notice of this ahead of time. Once again, depending on what jurisdiction you're in, my understanding is in the Calgary that they get notice. Same way, sort of when we do duty counsel now with the shift board. Shifts is posted and you accept it, and then you find out you are. And in Calgary, my understanding is that they will send out a notice right away to the facility where the person is being held, and obtain consents to review their medical information as well. So for admission certificate, it has to be heard within 21 days. For a issue with competency, and when we see up on the screen right now, if a person objects to a certificate being issued by the psychiatrist saying they're not mentally competent to make their treatment decisions. A person can object to that, and a hearing has to be done actually within 7 days. They look at that. The act is designed to view the competency issue to be a little bit more urgency, because when a person objects to the competency of treatment decision, that sort of puts the treatment on hold, and you want to get an answer with respect to that issue as soon as possible. Now, certain things, since that the person will get from the hospital or even through the lawyer. I understand that we have some material on even on our website that deals with the form letters, things that you should send to the hospital, indicating there will be a review panel hearing. And so usually duty counsel will send a sort of a form letter and advise the person that they have rights. And that's one of the things that came out of that JH decision as well. It seemed to have been sort of a shortage of attention to informing people of their rights when they're under the Mental Health Act. Remembering what we said from the beginning is it's a very powerful piece of legislation. When you think about it, even under the criminal code, you can't really persons in a jail, we can't force treatment on them. But this is a piece of legislation that basically can force treatment on people against without their consent. So the form letter that usually you send out will have certain things so the patient knows that what their rights are. And it also explains what the duty counsel's role is. So the duty counsel is available for anyone in a facility wishing to have a lawyer present at a review panel hearing. Duty counsel are there to assist people who do not have a lawyer and provide assistance. They are not your private lawyer. So duty counsel is similar in the way that we have duty counsel in our docket courts. Except usually the duty counsel certificate, my understanding in Edmonton and Calgary and in the central region as well. If you get duty counsel, you're usually duty counsel for that whole week. So in Calgary, there's more hospitals probably where they have duty counsel scheduled for certain days, and without getting into the reasons why, if you're a duty counsel, you'll probably be appearing for that whole week in those facilities. And one of the things under the Mental Health Act, but not only under the Mental Health Act, but in relation to all things involving privacy, and particularly to medical information, and you can't think of more serious medical information than what you would get with somebody who's has treatments and issues under the Mental Health Act. Those are very personal items that you don't want to necessarily disclose. So you want to be careful that you have the consents for that. So as part of that, the facilities have worked out a system with their local duty counsel on how to get that information and the consents. So I will just, if you're going to be appearing in one of those areas, I would suggest contact the duty counsel that regularly appears in those areas to give you a heads up on how you should proceed. But under the Mental Health Act, Section 14, patient has a right to know about a community treatment order. And usually the kinds of things that are put before the review panel are the admission certificates, a review of the physician certificates, and there's things called deemed applications, which are after a person's been in an institution or a hospital for more than 6 months, even if he's not or she's not appealing the decision, it's what they call a deemed application. So For example, if you have an admission certificate and that admission certificate is renewed and upheld, it'll be upheld for another 30 days, and then there'll be a second renewal certificate for another 30 days, and then after that, it'll be a person's in the hospital for 6 months. So in order to prevent warehousing and keeping people somewhere for a long period of time without addressing basically what's going on with it, what treatment has been going on, what the person can expect. It's called a deemed application. So that it's deemed because the chair is deemed to have made the application, and the review panel is obligated to hear that application. Sometimes the patients won't even come to the hearing. They just, because it's a deemed application, they may just say, I don't want to be there. And they could care less, I guess, but they're in a state of they're still very unwell, and they're not appealing the certificates. Often, if you're duty counsel, though, it's always a good idea to hang around, and the chair will probably ask you to do that, or duty counsel on their own will just be cognizant of the fact that there's some deemed applications and may be required to assist if required. So what's interesting is that what I heard from talking to some duty counsel is that these applications are a lot of this done by video now, of course, as seems to be the trend lately. So you need to before you appear with the person. I think if there's one single thing that I can relate to people who are thinking about becoming duty counsel or currently duty counsel, but I'm sure the current duty counsel is doing this, is that it's very important for you to speak with your client before the hearing. And the reason I bring that up is when I was doing the duty counsel, it was obviously all in person. You need to go through the records. You need to speak to the patient, the applicant. There's nothing worse than showing up on the day of and talking. The hearings are all scheduled a certain time, and there could be a lot of hearings that day. And the lawyer coming in, duty counsel coming in and saying, I need some time to speak to my client. Well, I can tell you that the panel members all kind of turn to each other and think, why didn't you speak to him yesterday? Why didn't you do it, 2 days ago when you heard that you were going to be duty counsel that day? So when you get if you're duty counsel for a certain week, you'll probably get a list of patients that have requested you from the administrator for the chair. That person is the person that will you have to become very good, have a very good relationship with, because that's the person that will tell you any changes, will give you a lot of good advice on basically how things are going. But that person will send you a notice of how many patients, how many people are there for that day. And I think it's very important. Like I said, there's one thing that seems to be a recurring vital importance, is that you speak with the patient before the hearing. And for a lot of reasons, really. One of them is it's just like any client that you may have. Can you think going into what it's like to go into a trial where you've had limited contact with your client? A lot of times, not a fault of your own, but you haven't, or you haven't had a chance to review the disclosure with them. The same in the context of the Mental Health Act is you've got access to mental health records. It'd be good to if there's going to be points that need clarification, you need to speak to your client about as well. And the other reason is you need to get instructions. It seems kind of odd that you're getting instructions from somebody who's possibly not mentally competent to give you instructions, but you still got to get instructions, because the alternative is to get no instructions. And you need to meet with your client, because you may find that perhaps, you may find that what really the person is concerned about may not be the subject of the appeal. There's a lot of reasons that people are in the hospital, and because some of their concerns may have changed even in the short period of time from the time when they filed the notice of appeal, sent their notice for appealing, and the time that you actually speak to them. There's certain things that valuable information that you need to determine by speaking with your client. One is the strategy of what you're gonna ask, what kind of questions what's going to be your strategy at the review panel hearing. The review panel hearing usually has the treating psychiatrist there representing the hospital, and that psychiatrist will know a lot about that patient. So you need to look into, when you're speaking with your client, find out what exactly are ask the client, what exactly are you concerned about here? What are you appealing? And it's also a good time for you to go through you can go through the criterion with them. Everybody has a little bit different approach. So I'm not going to say exactly how you should do it, but I think it's very essential that you confirm some points in the medical records that maybe only your client can confirm and explain away. You need to come up with a plan. I mean, when you go into a review panel hearing, like any application in court, you can't take the shotgun approach and start raising every single issue under the Mental Health Act. Concentrate on which one it is out of those first four criteria. Take a good look and say which one, if there is a weak point, which one is it? Where am I going to focus my attention on? Is it the carelessness issue? Is it the likelihood that the person is going to deteriorate physically or mentally? What is there? Or you may just having spoken with the client, you may come to the conclusion that there isn't a lot of points to bring. The client's case may not be that strong. So it's different. It's not like when you've got a client, even criminal court or civil matters, you're going to be there for that person at the hearing, and meeting with them beforehand is extremely important to come up with a theory, come up with something that will assist you at the hearing. Now, I'm just going to go straight to the hearing right now. The hearing is, yeah.
About 5 minutes to wrap up.
Okay, I know. This is what I said at the beginning. There's a lot under the Mental Health Act, but some very important pointers. Remember that the person that's appearing in front of the hospital is a treating psychiatrist. And I think it's important to remember that person is a concerned individual, and that person is an expert in what they do. So keep cognizant of that if you're going to be asking questions of that person. And it's kind of an unusual situation in that, try and think of it as if you're a lawyer and all of a sudden somebody appeals in the midst of you representing somebody in some matter. There's a hearing brought forward, and another lawyer is going to ask you questions on how your case is going and what you're doing. So sort of trying to keep that in mind. It's one of the recurring things you'll see you may have heard. It's going to continue into what Amna is going to talk about. Is that this area of Mental Health Act, mental health is, and the law is more of a tendency to be less adversarial, and that doesn't mean that you're not up there making sure your client's rights are protected, but it's less adversarial in the sense because you are dealing with people with mental health issues, and it's more of a collaborative approach as well, because you will be discussing with the psychiatrist. And when you're looking at the treatment plan, you're looking at possibly asking questions about, is there a community treatment order in place? What can we do? and so forth. And you'll find that kind of discussion helps also with the client to feel better after the hearing. What you don't want to do is come out of a hearing where the psychiatrist is upset, the patient is upset, and so forth. A lot of times the patients will come out of the hearing upset because they really didn't have much of a grounds to overturn their certificates. But if you can, you want to come out of a more collaborative approach, take a more approach what we can do in the future. So just to briefly touch, there is a rights of appeal to the Court of Queen's Bench. It was changed from, as somebody had mentioned, from 13 days to 30 days. You have to file an appeal. It goes by originating notice. Legal aid will usually, if the person is appealing the decision, they contact legal aid, and legal aid will ask you to be an opinion, give an opinion. So give note, take some notes, so you can give an opinion. Usually, the duty counsel lawyer has a very good feel for whether this is an appealable issue. What happens is if the matter is appealed, like I said, it goes originating notice, the hospital will then will appoint or will have a lawyer representing them, and you meet with that lawyer, and you have all the disclosure you want in the world to address that issue. Not a lot of matters, like very little matters actually go to the Queen's Bench situation, because what may happen is in between the time period that the actual Queen's Bench matter is heard, and it's heard de novo, the person gets better, and there will be a likelihood that the certificates can be canceled, or a mutually agreeable solution, such as a CTO or something, comes into play. I didn't get a chance to talk about CTOs too much, but what I'm going to say about the CTOs is the criterion there are similar, but well, CTOs are a godsend because they really meet a niche in making sure that we get people out of formal institutions, and it's a good in between sort of thing between just releasing and canceling their certificates and maintaining good mental health by watching them and treating them while they're out there. The hammer over the head, or the carrot in front of them, is that if they don't uh, abide by good mental health and abide by what's required in the CTO, that there is a possibility that they could become a formal patient again. But that's only one of the possibilities. But you always hear, generally speaking, from people who are in CTOs, some of the complaints you'll get as duty counsel, and that is the side effects of the medication. And in fact, that is a recurring theme throughout when you talk to patients who have antipsychotic medication administered to them. Usually people on CTOs are injections, and there are deemed applications so as well. The CTO is good for 6 months. It can be reviewable. It's reviewable after 6. There's a deemed application, so every second 6 month is a deemed application. Once again, to sort of prevent people from getting lost in the system.
Hey, Andrew, I'm going to have to stop you there.
Okay.
Sorry, I know it's a lot to try and get through in the time limit that we gave you, but thank you very much. Why don't we take a quick wellness break, and then we'll start with Ms. Qureshi's presentation. Thanks again, everybody. So our next presenter is Amna Qureshi. Amna is going to be talking to us about the Edmonton Mental Health Court and practice tips for working with mentally ill clients, and also a bit about trauma-informed practice. So take it away, Amna.
Thanks so much, Danny. I know that I've also been tasked with providing a lot of information to you folks. So I want to just premise by saying I apologize if I am not able to be responsive to every single query, but I will be available after this conference. And my contact info is pretty readily available these days, so please don't hesitate to reach out or come visit us at Mental Health Court, where we can provide you more info. I wanted to also start by acknowledging some other folks in Legal Aid's Mental Health Court team, some of whom are on the line here with us, including Ms. Cindy Brand, who has been a long time justice navigator since Mental Health Court's inception, and without whom the work we do in mental health court would really not be as effective, as well as one of our other designated duty counsel in mental health court, Miss Alicia Somji. And she's on the webinar as well and has contributed so much in her role as designated duty counsel. Thank you, Ms. Somji, and both Ms. Brand and Ms. Somji's contact info are also available in some of our materials, and they're also open to being contacted to provide info about practicing in mental health court. I'm going to give a very brief history about Edmonton Mental Health Court and its purpose. And then I'd like to talk a little bit about what mental health court is for, how files get into mental health court, what makes mental health court unique from other docket courtrooms, how to advocate to get your files, your clients' files into mental health court, and once they're there, how to advocate to keep them there. As well, where in jurisdictions where there are no mental health courts, and we've learned that there's some in progress in Red Deer and some hope that we can get one going in Calgary soon too. But I understand that here in Edmonton, we are kind of setting the bar here. And so we're here to help, and I certainly encourage further meetings and discussions to get more mental health courts off the ground. I'm radical in that I believe every criminal court should be conducted the way mental health court is, and in that to be a therapeutic court. I'm also going to make sure I provide general tips on working with mentally ill clients. What you do when your client is fit but still unwell and it interferes with getting instruction. So how do you deal with that? And I know that that was raised in Judge Collinson's presentation earlier. I also feel it's important to touch on mental health first aid when we talk about trauma-informed lawyering. In other words, how we take care not just of our clients and in terms of preventing further traumatization and harm by our actions, but also how we make sure we have the capacity to keep doing this really important work. For instance, how to handle disclosures when clients are about to disclose traumatic things. So Edmonton Mental Health Court started in April 2018, so we're coming up to about 5 years. Edmonton Mental Health Court originally started with only matters that were from Edmonton jurisdiction, so EPS charging matters, so Edmonton city matters. And there's very few exceptions since mental health court started to allow for matters from other jurisdictions. So general rule is that it's only for Edmonton matters. The only times that I can say that an exception would be made for sure is when a client has Edmonton matters and also has matters from other jurisdictions, and they're already in mental health court. Most crowns don't take issue with having matters dealt with globally in Edmonton mental health court when a client does have matters there as well. And I wanted to also give a shout out to a few crowns that I see who've joined our webinar today, and they work in the regions, and I'm very thankful that they're here to learn about some of this. So mental health court, it's a specialty court, so it is like other courts like drug treatment court, etc., but different in its scope. It's there's two streams, okay? So one is an involuntary stream of how files come into mental health court, and one is a voluntary stream. I'll start by just touching on what we mean when we see involuntary stream. So these are the matters that come into mental health court because fitness had been raised as an issue in another docket court or even at JP bail office. So usually, or what the intention is that they get referred from those other docket courtrooms with an order already having made for fitness to be assessed. Therefore, when it lands in mental health court, there's a good chance that we'll also be met with a fitness report for that day to see if fitness is still an issue. But that is the involuntary stream where we talk about fitness assessments and fitness hearing. Yeah, and it doesn't require, of course, the consent of the accused person. But we do that so that we know that there's as we talked about, understanding the criminal code provisions and the extension and time limit stuff, it's so that we can preserve that and make sure we're noting any issues, right? So one issue that comes up with fitness assessment orders, and that I would say is 100% the first place to look, is if you're in a docket court where on the last appearance there had been a fitness assessment ordered and on the return date, there's no assessment. Check with the clerk, check with on the endorsements to make sure that that assessment order was actually forwarded from the clerk to fax or FAOS or whatnot, to confirm that at least from that end, there's no disconnect. And, in mental health court, we're blessed by having contact with Alberta Health Services nurses who can confirm very quickly if they've received such an order or not. So just a practice tip when you're dealing with the involuntary stream. I'm going to spend more of my time talking about the voluntary stream of mental health court, because that, in my opinion, is where a lot of advocacy pitfalls and rewards can occur. So in that mental health court, it's not a trial court, so it's a criminal docket court, and we deal with guilty pleas, bail hearings, check-ins, by the way, of, if folks are released on bail conditions, we often see them have them report to mental health court rather than probation. We also really rely on probation check-in. So after someone's been sentenced and they've been placed on a period of community supervision, we often have them report or check in on their probation every so often, whether it's every month, every couple months if they're doing well. And the primary purpose of that is to ensure that, all these rehabilitative or therapeutic efforts we've made in the court and in their sentence really do come to fruition in terms of making sure they're not falling through the cracks 2 years down the road after they've been sentenced, right? And to prevent that cycle of them coming back in. So check-ins are relied on heavily, and they are not to be underestimated in terms of how much support they can provide your clients. So we often see lengthy adjournments in mental health court to allow time for treatment or connecting to supports, stabilizing folks before resolving the matter or before eventually setting the matter for trial if it needs to be set for trial, and then it goes to another courtroom for trial. So what are some of the ways that mental health court is unique? I've touched on some of them. When we first started 5 years ago, almost 5 years ago, we were very keen on making sure the principle of consistency was established. So consistency in judges, consistency in Crown Counsel, and consistency in duty counsel. And to some lengths, we've been able to maintain that. But of course, as is the case with any rehabilitative kind of process, we're also challenged by resources and constraints with regards to the pandemic. So who do we have, or ideally, who have we had in mental health court? We've had, in addition to those designated regular players that have this consistency in coming to court every week or sharing notes with each other as the judges in mental health court do, we have Alberta Health Services nurses who provide us with medical information on the clients if they've consented to it. Now, of course, we'll talk more about the consent process because that is an area that provides a great deal of challenge and I think education still 4 or 5 years into this. So who else do we have? We have, of course, a psychiatrist who comes in now once a week in the afternoon. We used to have a psychiatrist come in every Monday, Wednesday, Friday that the court ran. We're also lucky to have a justice navigator, and I named her Cindy Brand. She's one person for many, many folks, not just duty counsel, but other defense counsel who take files are supported by Cindy's non-legal expertise in the realm of community supports, housing, income support, counseling supports. You know, we even had a trauma informed sheriff at the start of mental health court, and though we do have a sheriff again in mental health court, that piece has been impacted by some resource constraints as well. You know, we do extend out of the court into community, and we do that by connecting with whatever supports the client already has. And so in mental health court, we routinely see elders, we routinely see and hear from social workers who attend with their clients. Sometimes they are the key to bringing their clients to court often. And so they receive a lot of space in the courtroom and recognition that we couldn't do the work in terms of that holistic understanding of where this client's coming from unless we have those the awareness of what that client has for them outside in the community. So we bring those folks into the courtroom, we give them space, and we hear from them in this collaborative approach. We have, to some extent, a reduced volume or quantity of files compared to other busy docket courtrooms, but that allows us to spend some extra time that I think is necessary. And when we talk about trauma-informed lawyering, working with those people who face considerable challenges, whether those challenges be through intergenerational trauma, distrust, whether they have all these other concurrent issues we see alongside mental health, whether it's poverty, addictions, direct trauma, vicarious trauma, etc. Um, we have those at the forefront, and what I mean by that is, you know, we have a very good understanding that we meet clients where they're at when they come to mental health court. And like Dr. Raheel Said said earlier, this allows us and encourages us to readjust our approach when dealing with those concurrent issues. So, sometimes that means that our interviews as duty counsel or defense counsel, as you likely know, mean we spend extra time and extra patience, and some of it has to be done in stages. We do this work in stages because we understand, just like when we think of Maslow's hierarchy of needs, that if we're expecting these people to be making very complicated legal decisions that can impact the rest of their life. But if their basic needs at this bottom of the pyramid are not met, they're not going to be operating with that cognitive functioning that we would be assuming. And so, in other words, um, it, the lack of these pressing basic needs being addressed for them interferes with their capacity to handle their legal matters right away. So oftentimes we do have folks that come into mental health court with fingers lost to frostbite, folks who are so drowsy due to not having slept the night before. Many of our clients are those that rough it on the streets, don't even feel safe in shelters. They are experiencing extreme victimization on where they are, and sometimes they're very hungry and haven't eaten for 3 or 4 days. And so that is where they meet us, right? And so many of our clients know mental health court to be a very safe place, and I think that taking that approach into other courts or other places where the hope is to create mental health courts, that needs to be a precursor to any kind of therapeutic aim, is to create a place where they aren't, when they don't follow decorum, for instance, in courtroom, they're not chastised for that. Matters in mental health court are triaged based on how folks are doing in the courtroom. And in other words, the usual rules don't apply. In other courtrooms, counsel seniority sometimes, most often, directs who goes first in court. And mental health court, it's not that way. I would like to just not dwell on that, because there are a number of efforts we've made through the years to make sure that this understanding and kind of the different expectation of counsel in mental health court is out there. We've created a tip sheet in conjunction with Alberta Health Services to provide tips to defense counsel primarily, but I do see it as aiding other Crown counsel as well, and counsel who work in in other jurisdictions as well, may be able to benefit from some of the contact information we've put in and some of the procedural steps that we've given guidance on. So that's been provided by Wyatt in that library, and I'll tell you that that library will contain a number of very good resources. And where I don't dwell is where I'm going to direct you to go see that info. So the info sheet is a number one place for you to get information on what the expectations are for counsel in that courtroom. And those are ways to make mental health, the mental health court experience, not just smoother for the client, who we should always have an eye to, but also for you as new counsel. And I've heard from many counsel, they are daunted by having matters come into mental health court, which is disheartening to hear, because of course their clients may be the ones that would be most successful or might benefit the most from this approach. So please don't be daunted by, the complexity of the nature of mental health law, and just understand that the courts appreciate a human-centered approach, and the rest can be education that comes with time. So in other words, the court's expectation in mental health court may not be perfect criminal law knowledge, but it will be trauma informed, and this understanding that if you put the needs of your client's most urgent needs out there, that you will be heralded as providing good advocacy, right? So don't be daunted if you want to have the best result for your client, but you're worried that you may not know how to navigate such a court. I want to just give an example of kind of like a typical case we'd have in mental health court and how we could see it being treated differently than in other courts. A typical case in mental health court would be someone charged with a simple substantive offense like a theft under 5,000, stealing eggs from a convenience store, or mischief, causing disturbance because they were trying to get warm between two doors during a cold winter. These are real cases. So that happens, they're issued a promise to appear. If the client has a brain injury, their ability to retain memory becomes impaired, and suddenly they miss their court date. Okay, they miss their court date. There's a warrant issued for their arrest. This is before mental health court. Then they're carded on the street, and or they call, they're involved in something, their name is run, find out they have warrants, they're arrested again, perhaps released again, and the cycle may continue until they reach a point where they're no longer deemed releasable. So what do we have? We have someone who may not have any criminal record, maybe struggling with a number of these concurrent issues, including mental health issues, but they're set up in the circle, they're this revolving door. So it might be that case. It might be the case that it's someone who's unhoused and loses their paperwork, or resides in a shelter and they don't have a fixed way to have folks contact them, or a lawyer contact them, or legal aid contact them when a lawyer's appointed. And so that's where creative problem solving comes in, and we take each case case by case, approach is taken, right? One size does not fit all. But I'll give you examples of how in a typical case like that, you would do some creative problem solving, right? And I would be sitting and interviewing a person with Cindy Brand, the Justice Navigator, at the same time. We juggle these various concurrent issues. If we have a client who struggles with short-term memory or memory loss, developing some kind of reminder system so that they know their court is a way that we can advocate for their release. We can say, well, now we know what their issues are, and these are the gaps. This is what was not in place before and may have contributed to why they missed court, or their further criminalization through breaches of court orders. And when we can institute a plan like that, for instance, Cindy Brand may offer to send a text reminder to those clients with cell phones the day before their court appearance. Or, if they are someone who, though is unhoused, attends at somewhere like Boyle Macaulay Health Center every few weeks or something for an injection, we can connect with that support that is more regular for them, something that does, that they have some way to remember. We can work in conjunction with those supports. So, in mental health court in the first year, when we had our nurses that sat in the courtroom with us, and we'd have a concern about a client who hadn't appeared even after they had gone into mental health court, if they had provided consent for the release of medical information, we could look into that to see, well, okay, they haven't been in court for 2 weeks, but we heard they had an appointment to get an injection a couple days ago. Nurse, can you check to them to see if they made it for that injection, or the appointment that's coming up in a couple days? Could you make sure that there's a reminder for the nurse to tell them to come to court? And so when you can provide these kind of out of the box thinking and solutions, you can be very successful in convincing crowns, maybe not all crowns, but the crowns who You can convince by saying that, this is going up the antic ladder in terms of release. It's not a type of release that's been considered before. So these are ways that you can certainly advocate using the tools in mental health court. And when we have someone that's released on bail conditions for mental health court, they're released. We make sure we turn our mind to whether or not we'd be setting them up for failure. So in other docket courts, when folks are released on bail conditions, sometimes there is a level of not coercion, but a level of you have to understand that if they're if those are the conditions being presented to them, that if you agree to them, you'll be released. They don't often feel that they can advocate for something different or add or put in that might cause them issues. So something as simple as a reporting to probation condition can often lead our clients to failure and inevitable breach. And so, one way we avoid that is if we know we have a client, for instance, who has a significant diagnosis like FASD, fetal alcohol spectrum, then we know that we have to make the bail conditions very plain language, and we don't use jargon. We take out the jargon. So you'll hear judges in mental health court really break it down and say, instead of saying you shall not be in uh, direct or indirect communication with so and so, it's don't talk to this person. You can't message them. You can't call them. If you see them on the street, turn around and walk away. Or often we have concerns with regards to abstinence provisions. We don't have that problem in a mental health court, I should say, but I know that problem exists in other courts where those who struggle concurrently with issues of addiction and mental health, which is virtually always the case, in my opinion, when we see them criminalized, that putting them on a condition that expects them to abstain absolutely from the consumption or possession of substances will inevitably set up someone for failure if they're pre-contemplative or, as I think one of our attendees called it earlier, sometimes in denial. Right, pre-contemplative is one of the words that we use instead, because we recognize that sometimes trust needs to be built up, and people that we help are often in a very hopeless place. And I think turning your mind to all the ways that the systems may have let them down before they reach your door or your desk is important in understanding why they may be resistant, for instance, to providing a great deal of information about something very vulnerable and still stigmatized, their mental health. So on that, I want to talk about, how to advocate to get your clients' files into mental health court if you do believe that they fit the criteria on the Alberta Courts website. Um, so ultimately, the decision of how files get into mental health court in Edmonton is by judge or justice of the peace. And so though there can be arguments, perhaps pushback rightly by, the Crown, that there's not enough information to warrant a referral, etc. Ultimately, it would be up to the judge or justice of the peace to have the final say. And so that's to say there is an advocacy element for folks outside of mental health court to try and get their file here. So referrals are requested into mental health court for purpose of bail hearing or resolution. So again, we're not talking about the involuntary matters that would come in without any advocacy necessary. If a judge makes an order that fitness needs to be assessed and then it goes to mental health court, council doesn't play a role necessarily after that order is made in determining whether it ought or not go to mental health court. So if you're wanting your client matter to go into mental health court, whether they're in custody or out of custody, and you face pushback. Most of the time, the pushback will be on the veracity of the mental health information that you as counsel may be presenting. So I want to make sure I say that it is not a condition precedent to confirm that someone has a mental health diagnosis prior to seeking a referral to mental health court. But having a confirmed diagnosis or information that tends to support a confirmed diagnosis will obviously help your case to get the file in. And I want to dwell on that a little bit because there's many reasons why at the outset counsel may not have all that information, and especially duty counsel. And that is what mental health court is for, is to try and bridge that information gap. But ways to bolster information at the referral stage can involve asking your client, if they have a diagnosis. If your client provides, um, a diagnosis, as Dr. Said had outlined, one of the diagnoses in the DSM-4, that's great. You can lead with that. You can ask them further questions. Sometimes they don't know. They don't know what they've been diagnosed with, but they know that they're receiving medication for the management of their mental health symptoms, right? So they may say that I'm on, they might say I'm on Zoloft or I'm on Prozac, and you don't have to be the expert to go Googling what those medications are for, but you could ask the client, what do you think that medication is for? And you can be as broad as saying that I understand that they've been prescribed medication by a doctor to assist with their management of their mental health. If you have the name of their treating, family doctor or psychiatrist, especially if it's a psychiatrist who may be working out of FACS, the Forensic Assessment and Community Services Office, or a place like 108 Street Clinic. And, if you say FACS or 108 Street Clinic when you're asking for a referral to mental health court, I can't expect that you'd face pushback. You can ask you can ask your client, do you receive income support for any medical disability, or do you receive AISH, assured income for the severely handicapped in relation to a mental health issue? If they say yes, or there's a way to bolster that information, that's good info, right? Because it's the hoops that they would have had to jump through already to confirm diagnosis to get on AISH is quite high, right? So again, I'll just reiterate that it's not a condition precedent to have confirmations of mental health info at the outset and prior to referral to mental health court, but it will help. And if you do continue to face challenges in getting a file into mental health court, I would welcome you to talk to me, and we can think of some reasons why that might be the case and what we can do to help get it in there. So once it is in mental health court, how do you keep it there? There is sometimes issues when we have files that come into mental health court with a paucity of information with regards to diagnostic criteria or current mental health issues. And there can also be reasons for that. So, for instance, if your client agrees to sign the mental health court consent form for the release of medical information, which again, I would say is not a condition precedent to get the resources in mental health court, but they surely help, and without which you will face pushback and will involve greater advocacy to make the case that despite consent, despite consent yet you want to keep it there. If you do accept a file in mental health court, you have to advocate. There is, I think, an ongoing myth about any kind of specialty court, including mental health court, that it exists as a discount court. And so if you can make the case that your client has mental health issues, you're going to be able to somehow guarantee automatically that they'll receive a discount. It's myths like these that I think really muddy the waters when it comes to, making sure these resources are available for those who need them, and also not unnecessarily restricting access to those. So it is, by that token, still an adversarial court, albeit highly collaborative in nature. But know that if you accept a file in mental health court, it does involve advocacy, and often work and on the part of the client to make the case that they're making strides, or that they are indeed of reduced moral culpability and deserving of a lighter sanction, right? So it's not a discount court. That is a myth. And, it's a myth, I think, perpetuated not just by folks that are outside the legal system, but in the legal system too. So I'd ask you to pay heed to that. Defense counsel are often the gatekeepers of information, vulnerable information of their client. And I want you to also know that when your client signs a consent of release of their medical information, you are the gatekeeper. And you have to realize that there are prejudicial aspects of their their healthcare information that you may have a responsibility to make sure you are um, gatekeeping or canvassing, right? And let me expand on that. Okay, so I often see the case that if a client has mental health issues concurrent with addiction issues, and there's some paucity, some lack of information on their mental health side, which can be explained by a number of reasons. And I did say I would touch on that, and I will. But if there's a paucity of information on the mental health side, but a lot of information on their struggles with addictions, which you've heard Dr. Said say unequivocally that in the medical sphere they do consider mental health issue or mental health disorder to an extent. When that information is presented, sometimes it's presented in a way that this is just an addictions issue, or this client has no mental health information, therefore they have no mental health issue. This is just an addictions issue, and this is the place where I see a lot of pitfalls of advocacy, because I don't see counsel fighting hard enough to make the case that there's so many reasons why they may not have that mental health issue, and also, of course, this idea that or this education that addictions also have a role to play in mental health issues, and to say they're separate, and that someone who has they use addictions to self-medicate, or they have a genetic predisposition to substance abuse because of alcohol addiction being something that was used in their is something that their family or their history was plagued by. You have to advocate on that basis, even in places like mental health court. So let me talk about why you may not get the information you expect from Alberta Health Services when your client signs that consent. If your client has been diagnosed as a youth, Alberta Health Services and Mental Health Court may not have ready access to that info, the youth record info. If your client has diagnostic information from another jurisdiction outside of Edmonton or Edmonton region, even something as close as Sherwood Park, sometimes that information may not be very readily accessible or visible to the Alberta Health Nurses staff. Um, you know, I want to also reiterate that and make the point that often um, our clients have never, this is the first time that their mental health has hit a crisis, that they've been criminalized, and now will open the door to them receiving a diagnosis that could then lead them to other supports like AISH, etc. And so um, being so restrictive in the understanding of mental health courts purposes can also leave a lot of people behind who do need that help a lot quicker. So what else can I say about medical information coming from Alberta Health? You got to dig deeper as counsel. And if you can find out from your client, like I think it was Dr. Said or Judge Collinson who said, find out who diagnosed them, right? If it was in another city or it was as a youth, then tell the nurses that when you ask for information, say that I understand that he may have been diagnosed as a youth, etc. That way, when you do get a reply back from the nurses, they'll be more likely to, instead of saying no mental health info found or history found, they may say, oh, that's why we don't have info, but may give you options or leads on how to get that information that may not be directly accessible by them. Okay, so advocacy important in mental health court. See the tip sheet we've created for more ways that you can ensure that the files can stay in mental health court when you do get pushback from the Crown or the court. Maybe one last thing I'll say about when you do get pushback from the court, that pushback may be that you're not doing, not taking as many steps that may be expected by the court in terms of ensuring that we've got all the information that we could have. Um, you know, a lot of our clients have been criminalized for a long time before. And so if you know that your client is, for instance, Indigenous and has had many criminal convictions or lengthy sentences, ask them if they've had a GLADU report ever written. Uh, if they don't remember, but they think there might be a case, or you think by looking at their record, it's likely they've had a GLADU report, email Natasha Lake. She's the one person you have to contact, and ask her if there is a prior GLADU report prepared on your client. And that may give you all the information you need without re-traumatizing your client by unnecessarily asking them to recount potentially traumatic information. The same goes for prior facts assessments. If you have, the contact for prior counsel who may have acted for that client, or duty counsel often has, as being the first kind of point of contact with these people, we've asked those questions. And so if you are counsel who is sensitive to perhaps not asking your client information that may re-traumatize them, it's never a bad idea to get in touch in a place like mental health court, to get in touch with duty counsel who may have learned a great deal about your client in their beginning stages before they had counsel appointed. And that will increase, I think, some trust, and on that, where you don't have mental health courts and you don't have this easy process to, once you get a file in mental health courts, in some ways you can breathe a sigh of relief because you understand that, yeah, things will slow down for that client, and all the decisions are informed by understanding where that client is at. And so if it means, pausing and not expecting that a plea ought to be entered, even though there have been 27 prior docket appearances, will give counsel some breathing room, and you can work with that. But where there's no mental health courts, what can you do? Um, I'm just going to talk about mental health diversion as an option. Mental health diversion is a formal program run by Alberta Health Services. That is different from mental health court in that there is some level of control and a great deal of inclusion exclusion criteria of its own. And so I've included in our library some information created by AHS. So I'm not going to take any flack if contact info perhaps is not up to date, because of course Alberta Health Service contacts have changed a great deal recently. But if you need contacts for specific mental health diversion teams in specific jurisdictions, I can help you with that. Mental health diversion is a great option for folks in other jurisdictions who have mental health issues, who have simpler charges, not serious charges, and it opens the door to them getting access and connection to mental health resources quickly and free. But it also, in terms of their legal matters, can lead to their charges being withdrawn because it's an extrajudicial measure. There's gatekeeping functions that can happen even in programs like mental health diversion, and ways that advocacy can play a role in making sure that your client can get a good shot at this program. Um, many There's many reasons why a file may not be deemed suitable for mental health diversion. And so sometimes if you think there's a risk that the Crown may not think it's appropriate for mental health diversion, go to the mental health diversion contact person first and ask them what they think. Give them the scenario that your client is in, or just talk about your client specifically. And sometimes they may know who your client is and might say, yeah, that person would 100% be a good candidate. Using that information then to take to the Crown, I don't think is in any way manipulative. It's actually very instructive, because who's making that kind of assessment? It's those very people who would be tasked with assessing whether they'd be suitable for the program after the Crown agrees to it, right? So in some ways, you're going to do that advocacy work to make sure that you're going to reduce the chances of the Crown saying no. Often I see with our clients that they'll be deemed unsuccessful in mental health diversion. because they miss appointments. That's one of the primary reasons that they are deemed unsuccessful. Sometimes, there's some contact, some efforts made, and so mental diversion may, you know, support an extension being sought by that accused person to extend the time they spend in the diversion program. But oftentimes, if they're deemed unsuccessful, um, you know, the Crown might think it's the end of the line. And you might think it's the end of the line, but it's not the end of the line if you're a good advocate. So, how do you convince a Crown to let someone back into mental health diversion? I've been successful in that by sometimes just talking to the client and the diversion team to find out what went wrong. Oftentimes, it's because their client has changed contact info or housing has fallen through and they've lost touch. So reconnect with your client or show how your client has the means to reestablish good contact. Find someone who may be willing to be a second contact person. When I fill out that blue mental health diversion form and my client is unhoused or unstably housed, and they have a text now number, I will put my contact info, or I'll put a social worker's contact info, or I'll put the house manager of the group home or something they're in. So just find ways to make sure that that stuff doesn't fall through the cracks. I've been almost all in all cases that I presented to the Crown, hey, what if we, now we have better contact info, and I give them a little bit more information about the rehabilitative potential of this client, they're very likely to give that person another chance. It's less work for them, right? And they can pat themselves on, in some ways on the back to say that, yeah, okay, now this is not a hopeless cause. Now we have some hope, and that person will get the help they need. Where mental health diversion is not an option or not seen as an option, the charge is too serious, or this person has a lot of criminal convictions, and the Crown's not convinced that this is really going to rise to an exception that they should be allowed in. Pitch informal diversion. That's a term that I started to coin before mental health court started, and I did it in rural places. And so, what I meant and what I mean by informal diversion is if you know how the mental health diversion program works, you know, you can kind of make your own program for your client, or maybe your client has already a treatment program that maybe is more intensive than what the mental health diversion team could offer them, right? More culturally competent, sensitive to their needs, etc. And so to put it simply, you talk to your client and they're not eligible for diversion, but they're willing and wanting to go get counseling, right? So do the work as an advocate. Find out in their jurisdiction where they can go for easy or sorry, free or subsidized counseling, and give them the contact info and tell them that when you see them again in 1 month's time, they should have a letter from their psychologist confirming they've gone, and you go have a chat with the Crown and say, hey, what do you think about this? I know we can't guarantee anything, but if in 1 month's time the client shows up with the letter proving they've gone to 4 to 6 counseling appointments, can we consider that that's mitigating enough to lead to a better resolution? Maybe in a case that's super serious, it's not going to lend itself well to expecting the Crown to withdraw the charge, but it may lend itself well to, fighting for a community supervision order as opposed to incarceration. So advocacy in the void of a mental health court process. Um, I want to leave time for questions, but I don't think that it would be responsible of me to finish before at least talking a little bit more about mental health first aid. Okay. Um, I want you to see a few resources that I have linked in the directory. When we're talking about mental health first aid or trauma informed lawyering, the expert that I'm going to say, the one person you should follow and support, is a lawyer by the name of Myrna McCallum. She is a Indigenous lawyer in BC who is, I would say, the preeminent expert on trauma informed lawyering. And also understanding that it ought to be a core competency requirement in all fields of law, but especially when working with mentally ill, Indigenous, or otherwise marginalized people. So Myrna McCallum has a podcast called the Trauma Informed Lawyer Podcast. She also holds courses, 2, 3 courses. We're actually in the middle of one of hers now, and it was her first one, geared towards players in the legal system and really practical tips. So sign up for that, okay? Getting instructions from clients who are unwell but still fit, that low bar. Let me just talk a little bit about the policy, about how low, why this bar is low. In that Taylor case, there's a really important quote, and I want it to just stay with you, that an accused who has not been found unfit must be permitted to conduct his own defense, even if it means that the accused may act in his or her own detriment in doing so. In other words, even if the client is going to be making giving instructions that are going to make that prejudice them, they want to run a bail hearing, but they don't fully appreciate that that's going to be very, very risky for them, for instance, and you're trying to get across to them that it's in their best interest to stay in jail for another week, right? What a difficult place to be for counsel. The dilemma between acting in a client's best interest and providing them agency. There's a lot of nuance in this, but all to say that you have to, you have to understand that the law as it stands, mm, doesn't say that a client has to be able to meaningfully participate in their legal proceedings, just that they can participate, right? And so there's some room, I think, for critique there, and there has been a great deal of critique in the law there. But when you do have a client who is unwell and you want to get instructions from them, take tips from the psychiatrist who has assessed them with an opinion that they're fit, because they will give you some guidance. I had a client who was diagnosed with Asperger's, and one of the symptoms he had was that he would have utterances of expletives running on for some 30 seconds or so. And at the outset, that looked like a fitness issue, right? But when we found out that this was a symptom of his his medical disorder, it became very easy to say, okay, he's gonna just let him go for 30 seconds and then you can redirect, right? Let him talk for 30 seconds, redirect. Patience, right? Meet the client where they're at, but also understand some of the challenges. And in COVID, many unique challenges came up that made it difficult for us to obtain instructions from people. And you just got to put yourself in that person's shoes. I don't know if I can say it any simpler than that. Understanding that fitness is a fluid issue and can change hour by hour, and many other factors can also help you get instructions from client at the best time for them. Understanding what impacts fitness, like the jail conditions they're being held in. Are they being held in a structured intervention unit? Are they being held in solitary confinement, by whatever name you want to call it? Have they eaten? What time of day is it? Have they been awoken from a very deep slumber to come and talk to you, and therefore are maybe reticent in providing details to you? Do they have intergenerational distrust or trauma with the system that you have to do your part in helping, remedy by telling them that, and showing them that they can trust you? Are they on medication while in remand? What medium are you using to communicate with them? During COVID, many of us were only able to talk to our counsel that were in custody by phone. So they've got mental health issues, they're being held in segregation, and then there's someone who claims to be a lawyer while these officers are staring at them, and there's a nebulous voice on the phone, maybe at the same time that they're hearing other voices, right? And remember that you can be deemed fit even if you have delusions, right? So the way you appear to them, can factor into how much trust they'll have and how easy or difficult it might be to get instructions from them. I've linked a very important and very recent comprehensive document. It was the first ever national study on the psychological determinants, health determinants of the legal profession. And there were some very concerning, albeit I think unsurprising findings. That over half of the legal profession suffers from significantly high levels of psychological distress, anxiety, depression, burnout, and suicidal ideation, and that the prevalence of those symptoms are much higher for those of you who are earlier in your career. The percentage is higher still for those legal professionals who themselves have an intersectional identity. In other words, they are living with a disability, that they are members of an equity seeking group, that women, almost half of the legal professionals that recognize they need help will not seek help because of the continuing stigma in our profession that attaches to understanding what you need to do to build capacity and take care of yourself. And I want to also highlight one other finding from that report, that it is the emotional demands of clients that is seen as the risk factor with the most significant impact on us. So the emotional demands of your clients have the this most significant impact on our own mental health. So what does mental health first aid mean? It means putting your oxygen mask first, right? Like you are in the plane. Understanding that you're not there to heal your client's trauma, but you're there to help them in that moment, to give them what they need. And sometimes what they need is just to have someone that's able to listen to them, validating the place they're at and understanding that, it's not just a matter for them to decide whether they're pleading guilty or not guilty. It is for them deciding where they're sleeping that night, right? It's going to be deciding where whether they're just going to be seen the same way that every other person that looked like them had been treated in the justice system, right? Intergenerational distrust. So you're not there to harm their trauma or heal their trauma, but you are there and you have a responsibility to reduce the harm that you can occasion by them. So never take things personally. When your client is upset with you, understand the power differential. And the amount of times that I have personally witnessed counsel becoming impatient and frustrated with a mentally ill client is too many times. You have no grounds to lose your patience with the client who has very little power compared to you. So I have to say that with a great deal of emphasis. If you believe that your client is about to disclose something very traumatic, whether it's self-harm, whether it's, that they've been victimized in an incredibly brutal way, you are able to pause and say to them that, it sounds like what you're about to say to me is really important. I want you to know I'm here to listen, but I may need to connect you to someone who may be able to help. Is that okay? Before you go into this terrain, right? You do have some obligations as counsel, even as an articling student under your code of ethics, to disclose and to breach solicitor client privilege in certain cases. And you go look those up. That's your duty to be aware of. But, just one example that comes up often is when our clients disclose a risk or a intention to harm themselves, especially when they're in custody, and what your obligations are. I think that it's very clear cut that you do have an obligation to report potential harm, especially when your client is in a place where there is some level of out of sight, out of mind, right? They may not be willing and able, or it may be difficult for them to talk to healthcare staff at remand, right? So you may be that person that is required and obligated to ensure that they're safe when they say something like that to you. And how you do that? You notify healthcare at remand. You talk to the sheriffs at CCDV, and you say this is an issue. My client told me that they're intending to harm themselves, right? And you put it on them so that they have to tell their healthcare staff, right? So that that responsibility continues through this process, and it's not just dropped off and you understand that you know you don't have an obligation. You do have an obligation. I want to just end by saying just some final words about resources for yourself. I've included a great deal of resources that talk about self-care for helpers and you know the signs of vicarious trauma, compassion fatigue, and burnout that we all should be aware of. Most especially the document from the Law Society of Alberta called a Wellness Supplement Resource Package that was developed and published October 2022 as an addendum to their conference on this topic. Provides the best information you can ever have in your pocket, both for yourself and for your client. You know, my clients are those that humble and inspire me through the work they do in overcoming their own struggles in places like mental health court. And they provide unexpected gifts in this work, right? And I don't want to say that all we get through this work is vicarious trauma, but we also gain a great deal of empathy and what we call post-traumatic or vicarious resilience, right? And so they're the ones that give me all the power to do the work and a capacity to do the work I do. But I'm a huge proponent of ensuring that you aren't going to re-traumatize or pass on your lack of capacity or lack of window of tolerance onto your clients. Okay, trauma-informed lawyering should be the status quo and the expectation in all areas of law. And I think we need to do away with that old way of thinking that you have to be hardened, and totally objective and neutral when you handle cases like this. I think that the goals of justice can be achieved equally well when counsel is empathetic and sensitive to the systemic issues that their clients struggle with. So that being the case, you know, I can go on for a long time. This is something I'm very passionate about. But with the 2 minutes I have you for, just thank you for your time. Thank you for being here for such an important topic. You know, our community in Edmonton is being plagued by a very visible issue right now, and I think it's incumbent on us to acknowledge that and do what we can to remedy the harm caused to those who are the most impacted. So thank you so much for your time.
Thanks, Amna. There's a minute left. I don't know if you wanted to take a question or two. I've tried to pull a couple questions from the conversations that have been going on in chat. One of which was, when you have a client who's obviously has a mental health issue, but they don't think they have a mental health issue, how do you get them to participate and sign a consent? Or can you?
Okay, so I think that's a good question. It comes up so often. You can't get a client to sign a consent if they don't understand it. Number one, if they don't understand why they're there, you know, if they're not willing or able to acknowledge that they have a mental health issue, then you know you might be in a situation that if there's no fitness issue, but your client is not helping themselves in that way by saying, "Yeah, I do have some mental health issue. I just don't know what it's called." Then your hands may be tied and you may be in the court's hands, so to speak, and the court and the crown may decide that without the client acknowledging or wanting to acknowledge they have mental health issues, that file will get taken out of mental health court. But some ideas for counsel who do believe their client has mental health issues, but the client is kind of worried, have a conversation with your client about whether they're worried that admitting they have mental health issues is going to be bad for them. Because, you know, the reality is, and you know, question about malingering came up earlier. The reality is, empirically, statistically, you're more likely to have a client who's worried and afraid about talking about their mental health issues because of the stigma that's occasioned on them And then you would have a client who's trying to fake it so they'd get a sentence discount, because the stigma that attaches, and the things that flow from a diagnosis are often become immutable, and follow your client along, and your client may be very well aware of that stigma. So we have to operate with a different presumption. The presumption, it's much more likely that someone will be reticent or scared to talk about their mental health issues, so have a conversation with them about that. And the final suggestion I have is talk to their support people with their consent. Hey, your mom's in court today in support of you. Is it okay with you if I go talk to her? And if your client says yes, that mom is going to tell you, yeah, they were diagnosed at the age of 15, or and there's your info.
Excellent.
Question.
Thank you. So we've gone past our time. I will say that there's some other questions that we haven't gotten to, but I'm going to post some email addresses when we finish, and feel free to post your questions to any of us that I give you the email addresses for, and we'll try and get answers to those. I wanted to thank again all our presenters from today. What a fantastic session today was. I don't know about the rest of you, but I've learned a tremendous amount. The experience that all our presenters have, their expertise shone through. So thank you so much for sharing all that with us. Wyatt is going to put in chat a link to a survey regarding this session. Please take a minute or two to try and complete that survey, as it helps us determine what kind of educational sessions to provide as we move forward. Wyatt has mentioned a number of times in chat today that all the materials from today's session will be in a shared Google Drive, and the link will be sent out via email. I don't know if it'll be later today or later this week. I don't want to put too much pressure on Wyatt. And there will also be a link to the actual videos from today. So you can go through, and if you missed any particular session and you want to see it, you'll be able to do that as well. And Amna, can I include your email address in the addresses I'm going to share in chat?
Absolutely, and I'll just say that please I'm going to apologize for being delayed in my responses. I have to triage based on what fire is burning hotter. So forgive me for delays in responses in advance.
Thanks, Amna. So there, I posted Amna's email. I posted Andrew's earlier. There's mine and there's Wyatt's. Feel free to send questions if you have any, and we can direct questions to other presenters if that's what you're after. So again, thank you so much. Really appreciate everyone's attendance today.